joining us on the virtual platform. And now, to take you to the quiz, I would like to invite my co-host, Miss Simran.
Thank you very much, Sapna. Good morning, ladies and gentlemen. I'm Simran, and I'm delighted to be your anchor for this segment today. And I hope everyone will be having a wonderful and insightful experience here at the 12th NATHEALTH Annual AROGYA Bharat Summit 2026. And it's a truly an honor for me to engage with such an amazing and distinguished audience over here today. So, while we prepare for the next segment, let's start with a small quiz to lighten up the room. Thank you very much. Team, can we have the quiz alive? Thank you so much. So I would like to request every one of you to please scan this QR code over here on the screen to participate in the quiz round. So I request to scan this QR code. So this is only one-time practice. You can scan this QR code and you can participate in the entire quiz round. I hope everyone has scanned this QR code. Can I hear out the one quick yes? Can we go ahead? Can we go ahead? All right, thank you so much. Team, can we have the first question, please? All right, so here's the first question on the screen for everyone. And the question is, what is the estimated percentage shortage of allied health professionals, AHPs in India? And here are the options: 10 to 20%, 20 to 30%, 40 to 50%, and 30 to 40%. I hope you all have clicked the answer. And can I have, ma'am, can you please tell me the answer, what you have clicked?
I pick 40 to 50%.
All right. May I have the guesses, please? Sorry? 40 to 50%. Sorry? 30 to 40%. All right. So here is the right answer in next 15 seconds on the screen. And here is the right answer. This is 30 to 40%. Congratulations to you, ma'am. What's your good name? What's your good name?
Ruma Banerjee.
Ruma Banerjee. Can we have a huge round of applause for Ruma Banerjee? Thank you so much. I request to the team, please share a giveaway with ma'am. And here is the next question. What is the annual economic cost of morbidity in terms of DALY, HALE, YLD impact? The options are USD 70 billion, USD 100 billion, greater than USD 100 billion, or less than USD 1 trillion.
More than 1 trillion?
Sorry?
More than 1 trillion?
I think you are very close. I think, please check the options.
It's greater than USD 1 trillion. 750 billion.
Okay, anyhow. Can we have the right option, please? That's correct. What's your good name? Apurva. Can we have a huge round of applause for Apurva? Alright. Team, I request you to please share a giveaway with Apurva as well. Alright. Can we have the next question, please? What is the health life expectancy in India? And the slider over here, you need to select the percentage and submit it over the phone. And if you have a right figure in your mind, you can tell me. Ma'am, which percentage you have selected?
62.
Alright. Anybody else? 70. Sorry? 70. Anybody else? Yes.
74.
Yes. Okay. Anybody else?
74, yeah.
66. We are still waiting for the correct figure. Any other guesses? Only 5 seconds left.
74.
65.
Alright, the right answer is 76. No, 72, 79. Okay. 61. So the closest one. What's your name, ma'am? Alright, give a huge round of applause for Vaidehi. She is the closest one. Can we have a giveaway for Vaidehi? Can we please cheer the winners? Can we have a huge round of applause for Vaidehi? Thank you very much. Okay, a small announcement before we move to the next slide. So here is the leaderboard. You just need to track your position in the leaderboard. We do have a giveaway for the winner of this entire quiz as well, right? All right, can we have the next question, please? What is the percentage of global health expenditure spent on health in India? Again, the slider is here. All right, can we have the guesses also? Okay. All right, we have first guess, this is 4%. Any other? Any other guesses? 2%. We have only 30 seconds.
3.7.
3.7. All right. 1%. 2.5 to 3%. Interesting. What's your answer? 5%. Okay. All right. Only 5 seconds left. 4, 3, 2, 1. And here's the correct answer, which is 2%. Kudos to sir. Can we have a huge round of applause? What's your name, sir? Dr. DP?
Dr. D.P. Samadar.
A huge round of applause for the sir. Can we have a giveaway for sir as well? All right. Can we have the next question? And the question is, what is the total percentage of global disease burden in India? Again, the slider is live. You can lock your answers over your screens as well. And can we have the guesses as well?
10%.
10%. All right. 20%. All right, 20%. Any other guesses? 16%, okay, 23% I heard some. 23%, okay.
10%?
10%,
8%.
30%, 8%,
And here's the correct 30%. The correct answer is 25%. Can we have a huge round of applause, sir? Was the nearest and the closest one. What's your good name, sir? Yogendra. Can we have a huge round of applause for Yogendra, sir? And team, can we have a giveaway for for sir as well? All right. Can we have the next question, please? Currently, Tanush is leading the leaderboard. Okay, the question is, NATHEALTH One Community solves what problems? Options are, enables collaboration among stakeholders, improves knowledge sharing and communication, both options or none of these. Can we have the guesses, please? Both options. Very nice.
Both options.
Amongst
Both
stakeholders.
options.
Enables collaboration amongst stakeholders.
Okay, okay. Both options. Both options. Anybody else? I mean, any other guesses? Any other guesses? Sir. All right, here is the right answer, which is both options. Kudos to sir who answered very first time, the topmost one. What's your name, sir?
Sunil.
Sunil. Can we have a quick giveaway for Sunil, sir, as well? Thank you very much. Keep your eye on the leaderboard as well. Deb is here, who is leading the board currently. Can we have Deb over here? Deb. Okay. All right. Thank you. So let's start with the current and main session. And thank you very much. We'll continue this quiz rounds in later sessions as well. So over to you, my co-host Sapna. Thank you very much, everyone.
Thank you very much indeed, Simran, for hosting that wonderful session of the quiz. I'm sure each one of you enjoyed. Also, those who are joining us on the virtual platform had a good time. So, ladies and gentlemen, we are waiting for our guest of honor, Dr. V.K. Paul, Honorable Member Niti Aayog, Government of India, to join us to go ahead with the proceedings of our event today. Meanwhile, we are honored to welcome with us our guest of honor, Srimati Punya Salila Srivastavaji, Secretary, Ministry of Health and Family Welfare, Government of India. Ladies and gentlemen, before we go ahead with the proceedings of our first session, we would like to extend our sincere gratitude to all our sponsors and partners, our gold partners who continue to lead from the front in shaping India's healthcare ecosystem. We would like to convey our gratitude to Apollo Hospitals, Indium Capital, Polymed, Equia, Peerless Hospitals, Philips, Thyrocare, Test You Can Trust, Maringo Asia Hospitals, Humane by Practice, Jupiter Hospitals, Patient First, and Roche. Our heartfelt thanks to our silver sponsors, Afford Plan, Quality Care, India and Metropolis. We also acknowledge our bronze sponsors whose valuable support strengthened this initiative. BD, BPL, Charnock Hospitals, Dr. Lal Path Labs, Fortis, Wipro GE Healthcare, Intuitive and BD Hinduja. Ladies and gentlemen, also a special appreciation to all our session sponsors, Agilus Diagnostics, Ambuja Neotia, Ketan and Company, Mediversal, RAT 365, and Styler for enabling the rich, focused discussions across key themes. We would also like to recognize the efforts of all our esteemed knowledge and thought leadership partners whose insights and expertise have added immense depth and direction to the discourse. We would like to convey our gratitude to Bain and Company, Praxis Global Alliance, Convergence Foundation, Gates Foundation, PricewaterhouseCoopers House Services LLP, Indian Capital Advisors Private Limited, and Ad Factors PR. Ladies and gentlemen, while we are awaiting the arrival of our guest of honor, Dr. B.K. Paul, Honorable Member Niti Aayog, Government of India, may I once again request everyone to kindly join us inside the hall and kindly take your seats with your mobile phones kept on to silent mode from now onwards till end of the proceedings of the summit, so that we can have an uninterrupted flow of the event today. Ladies and gentlemen, let's put our hands together to welcome our guest of honor, Dr. V.K. Paul, Honorable Member, Niti Aayog, Government of India. May I request you, sir, to kindly grace the stage with your august presence. Also inviting on stage our guest of honor, Srimati Punya Salila Srivastava, Secretary, Ministry of Health and Family Welfare, Government of India. Ladies and gentlemen, let's continue the round of applause to welcome our guest of honor onto the stage, please. Also inviting our eminent dignitaries, Mr. Parijat Ghosh, Partner Head of APAC Healthcare and Life Sciences Practice, Bain & Company, Ms. Ameera Shah, President, NATHEALTH, Healthcare Federation of India, Promoter and Executive Chairperson, Metropolis Healthcare Limited, Dr. Sangeeta Reddy, President-elect, NATHEALTH, Joint Managing Director, Apollo Hospitals Group, Mr. Himanshu Baid, Vice President, NATHEALTH, and Managing Director, Poly Medicure Limited, Mr. Varun Khanna, Secretary, NATHEALTH, and Group MD, Quality Care India Limited. Namaskar and good morning. Guests of honor, Dr. V.K. Paul, Honorable Member, Niti Aayog, Government of India, Srimati Punya Salila Srivastava, Secretary, Ministry of Health and Family Welfare, Government of India. Esteemed dignitaries on the dais, all our distinguished dignitaries, esteemed policymakers, healthcare leaders, industry partners, respected members of the medical fraternity, respected members of the press and media, ladies and gentlemen. It is my great privilege to welcome you all to the 12th NATHEALTH Annual AROGYA BHARAT Summit 2026, a premier platform that brings together the nation's most influential voices from government, healthcare institutions, industry, academia, and the global organization to shape the future of healthcare in India. The theme for this year's summit, True Partnerships Toward Viksit Bharat 2047, catalyzing value, stimulating innovation, and strengthening healthcare service delivery and supply chains, reflects a defining moment for India's healthcare ecosystem. As the nation advances towards the vision of Viksit Bharat by 2047, healthcare stands at the heart of inclusive growth, economic resilience, and social well-being. Ladies and gentlemen, today we are honored to have with us Dr. V.K. Paul, Honorable Member, Niti Aayog, Government of India, who has been a key architect of several transformative health initiatives in the country and driving reforms aligned with the vision of Arogya Bharat and Viksit Bharat 2047. May I now request Ms. Ameera Shah to kindly do the honors of welcoming Dr. V.K. Paul with a floral bouquet. Thank you very much indeed, sir, for sparing your valuable time gracing this occasion, and a warm welcome to you, sir. I would now request Dr. Sangeeta Reddy to kindly do the honors of welcoming Srimati Punya Salila Srivastava, Secretary, Ministry of Health and Family Welfare, Government of India, with a floral bouquet. Very, very warm welcome to you, ma'am. Ladies and gentlemen, NATHEALTH, the Healthcare Federation of India, is a leading industry body that represents the collective voice of the healthcare ecosystem in the country. Working closely with the government and the global partners, NATHEALTH focuses on policy advocacy, innovation, quality standards, and collaborative solutions to improve access, affordability, and outcomes in healthcare. Through platforms like the annual Arogya Bharat Summit, NATHEALTH continues to foster dialogue, partnerships, and actionable strategies to build a resilient healthcare system aligned with the vision of Arogya Bharat and Viksit Bharat 2047. And now to begin the proceedings and set the tone for today's deliberations, it is my proud privilege to invite Ms. Ameera Shah, President, NATHEALTH, Healthcare Federation of India, and Promoter and Executive Chairperson, Metropolis Healthcare Limited, who is a distinguished leader in India's healthcare and diagnostic sector, has been instrumental in advancing quality diagnosis, strengthening healthcare delivery, and advocating for policy reforms that enhance access and affordability in healthcare. So please join me in welcoming Ms. Ameera Shah for the welcome address.
Good morning, everyone. So good to see all your faces, and I just wanted to warmly welcome all of you, our honorable dignitaries, my esteemed colleagues from the government, industry leaders, and delegates. Welcome to NATHEALTH's 12th Annual AROGYA Summit. A special welcome for our guest of honor, Madam Srivastava and Dr. Paul. Thank you so much for being here. We gather here today for not just a defining moment for our nation, which is not just economic, but significant because it's going to determine the many, many years to come. As we look forward towards the horizon of 2047, the vision of Viksit Bharat, a self-reliant, independent India, it's not just an economic vision, but it's a fundamental promise to our citizens. Let's be clear, there is no Viksit Bharat without a Swasth Bharat. And the trajectory of economic growth is inextricably linked to the health and the wellness of our 1.4 billion people. India's healthcare ecosystem has been going through humongous transformations. We have a rising disease burden, we have rapid demographic changes, and incredible advantages in digital technologies. However, the scale of challenge continues to be large and very challenging for any one party, one people to actually solve on their own. It's unprecedented. The data tells us a very sobering story. Chronic diseases are expected to impact over 63 crore Indians by 2030, while our elderly population will go really clearly close to 25 crore. All of this is going to land up in significant challenges which we need to anticipate and potentially solve for. As we know, oncology, cancer, and mental health diseases are the two fastest growing areas and will be globally for the next 10 years, including in India. We have already so many mental health challenges, but do we have answers yet on how do we tackle this at scale? The quality of our food, the nutrition, what we eat, what we put in our bodies is going to be very relevant when we talk about healthcare. There is no healthcare when we don't talk about what we ingest and what we actually take in. And the specific Bharat and India divide, which we've all known about and talked about for years, we still don't have blueprints on making economic models really successful in rural India. So a lot of things to be done and a lot of answers to be found. But to meet this demand, we cannot rely on frameworks of the past. We need aggressive, sweeping reforms, and we have to look at them through a lens of partnership, innovation, and execution. So first, if we look at one of the big challenges that we've actually looked to address is about the ease of doing business and the regulatory lay of the land. One of the things, as we all know, is we have a fair number of conflicting laws, regimes, state, center, different situations where sometimes there is not a full clarity or a framework in which everybody can operate in. As an industry, while we are committed to patient safety and clinical excellence, this remains a bottleneck for us while we operate. And it actually creates a lot of complexity in the way we deal with the patient. It not only drains this fragmented system, not only drains resources which can be spent towards patient care, but if we have to scale our capacity, we have to be able to rationalize reforms and regulations. We need digital single window clearances for many things. We need to look at end-to-end compliance. We need to harmonize regulations between center and state. And we have to clear the path for more innovation. The second area that we really look to focus on is around financing at scale. Expanding access, like I said, especially in tier 2, tier 3 areas and in rural India, requires patient, long-term capital, which is not just looking at profit as the outcome. While we welcome the push to increase public healthcare spending, government capital alone cannot bridge the gap. In fact, the ideal situation would be if government used its capital to use as incentives, as key ways to get private capital to come and put 6 or 7 times the amount that government is putting in. That's when we can actually address the issues of our entire country versus in government being operators and private being operators. And finding that convergence is going to be very critical. And the vital reform that's going to unlock access to low-cost, long-term capital for hospitals, digital startups, and diagnostic networks needs to be found. And later today, Varun Khanna, Secretary NATHEALTH, and Group MD Quality Care will take a dedicated session to dive deeper into how we can build innovative models to truly solve such a big challenge that we have today. The third area that we'll be focusing on is around digitalization and the AI leap. AI as a word is thrown around a lot, and we really need to put the governance around it. And I know personally, as I was on the committee with them, there is a lot of work that's gone in putting a framework for AI, for the future time to come. There will be rules, regulations, and a framework around how you can introduce AI, where it will be used, how it needs to be disclosed, and I think that will get, released by the government in time to come. India is uniquely positioned to emerge as a global health innovation hub. But the critical bottleneck at this point of time is data, fragmented data. We don't have longitudinal data for our patients from end to end because we don't have repositories to really house this in, which is common where everybody can access. But to accelerate this, we have to move forward interoperable data exchanges through ABDM. Our government has actually put amazing stacks together that really will facilitate this data interoperability for the future, and we as a private industry must support this and make sure that this becomes successful, because this is the only way to get amazing patient care where the patient is at the center and their data is housed together. Furthermore, we need to capitalize on the government's 1 lakh crore R&D push by creating a national innovation consortium where we are looking at AI for primary care, we are establishing clinical sandboxes for innovation. And over the course of the summit, Dr. Sangeeta Reddy will outline a bold vision for digital and AI innovations, while Mr. Rishabh Gupta will share roadways to scaling digital health adoption. Fourth, we're talking about medtech convergence for Atmanirbharta. Finally, a truly self-reliant healthcare system cannot import the vast majority of its devices and technology. We have to find a way to be more self-reliant, and we have to find true convergence between providers and domestic medtech manufacturers. Doesn't matter whether they are global or whether they are indigenous, the important is domestic manufacturing. Providers must become early adopters and anchor customers for local innovations. My colleague Himanshu Baid will be leading a crucial discussion on how we can build supply chain resistance, and especially in the world we are in today, this becomes even more real and even more critical at this particular point in time. On a personal note, over the years that I've been in NATHEALTH, there's always been a question of we're releasing these papers, we're doing these conferences, but who's listening? Who's really caring about the input that private sector is able to bring to the table? And my biggest learning this last year is that we have many senior leaders in the government who have shown me that there is a real willingness and an intent to want to do good things in India for our patients, really wanting to lead the way and willing to collaborate and bring people together to really take this forward. And we are going to be able to give better help to our patients, better safety for our patients, and really grapple with the machinery, which is government, but they're willing to take that on. Dr. Paul, Dr. Sen, their team, Mr. Pathak, Secretary TOB, Madam Srivastava have all given us this belief. And it is with this that I believe that our efforts from private sector to the government can really result in change. We've managed to this last year make an impact on various different fronts, and we've spoken on them. But I think the couple of things that are most important that we're excited about is the work on removing the bottlenecks for the healthcare industry, which we are working very closely with Dr. Paul's team on actually getting done. And we are also looking to sign a statement of intent to talk about a coming together of various facilities of the government, starting with NITI and with NATHEALTH, to say how can we look at quality as a larger purpose for healthcare in India. Can we put frameworks? Can we do some standardization? Can we put some guidelines under which we all sort of operate? This is the first of its kind coming together of public and private, and we really are very excited to be able to work on this together. For a long time, private and public worked in a parallel way, not necessarily together. And we're very excited to see that all of us who care for India's future are able to bring our wisdom and knowledge to the same place. It's been an amazing year for us at NATHEALTH. And again, I leave today's discussion and remain this next year with a very strong feeling of hope and belief that the next years are the best for us to come. And along with the wisdom that we have in the public sector and the knowledge in the private sector, we can truly break through all these challenges that we've put in front of us in our country and truly move towards a Swasth and Viksit Bharat. Thank you so much.
Thank you very much indeed, ma'am, for your inspiring welcome and for setting the context for today's summit. Ladies and gentlemen, our guest of honor, Srimati Punya Salila Srivastava, Secretary, Ministry of Health and Family Welfare, Government of India, is an officer of the 1993 batch of the Indian Administrative Services and brings with her over 3 decades of distinguished public service across key institutions of governance. Ma'am currently leads the Ministry of Health and Family Welfare, guiding several national initiatives aimed at strengthening public health systems and improving the healthcare delivery across the country. Before assuming the responsibilities as the secretary in the ministry, Ma'am served as an officer on special duty in the Ministry of Health and Family Welfare in the rank of secretary to the Government of India. Prior to that, held the important position of Special Secretary in the Prime Minister's office, contributing to critical policy and governance initiative at the highest level. Ladies and gentlemen, please join me in welcoming our guest of honor, Srimati Punya Salila Srivastava, for the special address.
So a very warm good morning to all the dignitaries on the dais with me and all the participants of this very important summit on true partnership towards Viksit Bharat 2047. So Dr. V.K. Paul, Honorable Member Niti Aayog, President NATHEALTH, President-elect NATHEALTH, all the NATHEALTH members and all the industry leaders and distinguished guests. It's a pleasure to be with all of you today morning. And it's indeed a good start to the morning today because we are speaking of partnership. I still recall that in 2023, when the goal of Viksit Bharat in 2047 was announced, a very extensive exercise had been taken up to identify what its elements should be. And I am sure Dr. Paul sir recalls that on the MyGov platform, lakhs of suggestions poured in as to what should be the elements of our vision. The government constituted sectoral group of secretaries. Niti Aayog was of course playing a very important role in coordinating the entire vision exercise. And it was realized that we need to work through convergence, and that's why I like that one of the themes in the current summit is convergence. So that's the reason why we had these sectoral groups working together. And during this exercise, of course, health was recognized as one of the foundational pillars for Viksit Bharat. And the goal that was set for all of us who are in the health sector was that we need to provide high quality, accessible and affordable health care to our citizens. And these goals that we identified, the roadmap for that is something that is being made. The roadmap is evolving through every budget webinar, through every pre-budget consultations for which NATHEALTH has been very supportive. We work towards further fine-tuning our strategies and our roadmap for achieving Viksit Bharat. A lot of youth connect is also being done because they are the people who will be leading Viksit Bharat for this initiative, and that really helps in a part of our goal, which is innovation. So the main action points that were on which we had to work was, one was of course, as I mentioned, affordability. Second was innovation. Third was technology driven. And then fourth was high quality healthcare solutions. Some of the initiatives which we were taking have already been mentioned by President NATHEALTH. And many of these are also mentioned in the paper that has been prepared, which is really good because this shows that there is better convergence of ideas, and I'm sure both government as well as the private sector will benefit from that. So to ensure that affordable healthcare is there, I'm sure many of you are aware that there is a very comprehensive primary healthcare initiative that has been taken by setting more than 1,80,000 Ayushman AROGYA Mandirs. And these Ayushman Arogya Mandirs are focusing both on health and wellness. And there have been over 480 crore patient visits in these health and wellness centers. The second part is the free drugs and diagnostic services. And I'm sure many of you are partnering with various states to provide especially the free diagnostic services. The number of tests in this entire network was expanded. So if you look at the free diagnostic services, 14 tests at the level of sub-centers, 63 tests at the level of primary health centers, 97 tests at the level of community health centers, 111 tests at the level of sub-district hospitals, 134 tests at the level of district hospitals. Why I'm mentioning these figures is that government is striving to expand the free diagnostic services initiative. Similarly, the free drug services initiative, the essential medicine list includes 106 drugs at the level of sub-center, 172 at the level of primary health center, 300 at the level of community health center, 318 at the level of sub-district hospital centers. Now, various technological solutions are being implemented through the drug and through our various portals to monitor whether these drugs, whether these diagnostics are available. The health facilities across the country have come forward. Over 2 lakh have assessed themselves against the IPHS, the Indian Public Health Standards. We are striving to get the National Quality Assurance Standards in place. Over 50,000 public health facilities have certified themselves as meeting NQOS. So while we are trying to make healthcare accessible and affordable, we are also trying to retain the quality. You must have heard of the announcement, and many of you might be participating in it, to set up daycare cancer centers in all our districts. This was last year. We have the Pradhan Mantri National Dialysis Program. So 1,768 dialysis centers are reducing the out-of-pocket expenditure for patients across the country. The Pradhan Mantri Jan Arogya Yojana, of course, 36,164 hospitals are impaneled, of which a large chunk is in the private sector. And you all have been supporting this initiative despite many challenges. Third part, next we talk about digital transformation. As Ameera ji mentioned, the Ayushman Bharat Digital Mission has generated over 86 crore Abha IDs, and we really need to get it going. So I'm so happy that you have included it as a part of the deliberations in your summit, because continuum of healthcare records becomes important for each one of us. I mean, I'm great at misplacing all my records, so I don't know about everybody else. E-Sanjeevani, 45 crore teleconsultations are helping patients talk to doctors at our sub-centers and our primary health centers. They are helping doctors talk to specialists. So E-Sanjeevani has really developed as a very robust solution, which is being acclaimed across the world. Preparedness and resilience are the targets that we are trying to move through our Pradhan Mantri Ayushman Bharat Health Infrastructure Mission. So this is the third time I'm using Ayushman Bharat. It's the third pillar of Ayushman Bharat, which is the Health Infrastructure Mission. For sharing with the participants here, we are constructing urban health centers, block public health units, which are laboratories at block level, integrated public health laboratories at district level, and of course critical care blocks, along with many other elements for strengthening disease surveillance and emergency response systems. So we can always sit down together and see how the private sector can contribute to this. Because of initiatives taken in the public health sector and by many of the partners here, our maternal mortality, as you are aware, has declined sharply by 86%, infant mortality by 73%, and under 5 mortality by 78%. The universal immunization coverage, which we are tracking through UN, has of course contributed to it, apart from a large number of initiatives focusing on maternal and child care. Yesterday was the World TB Day, and on this occasion, we have launched the second phase of intensified TB Mukt Bharat Abhiyan. For this, we used AI analytics to identify 1,58,000 villages and wards which are high burden or high risk. And this time we are focusing on these 1,58,000. What really took the TB Mukt Bharat Abhiyan to the second level was the private sector notifications that added value to the whole exercise. So the drugs and diagnostics are fully sponsored by government, but people who go into the private sector, when you alert us, it is a very important step in TB elimination. The other aspect is, of course, supporting TB patients under the Nikshay Mitra Yojana. Government does add to the nutrition kitty by way of 1,000 rupees per day per month, but a large number of volunteers, and I'm sure some of you have also volunteered as Nikshay Mitras, who have adopted TB patients and providing them both nutritional support as well as psychosocial support, or encouraging the members of your organization or through you if we could do outreach for that. I would request all of you to just download or have a look at the TB Mukt Bharat app, which got launched yesterday. So there are several measures that we are trying to take to ensure that we also have an e-mitra for the TB patient through this app. We had the Swasth Nari Sashakt Parivar Abhiyan last year, and many of you supported us in this endeavor. Of course, Guinness Book of World Records did recognize this initiative on several counts, but more importantly, it generated large-scale awareness about non-communicable diseases and vaccination, and so that really helped. When Honorable Prime Minister gave the clarion call to reduce edible oil consumption by 10%, many of you came forward to support this national effort to combat obesity and the prevention initiative. So for that I'm grateful, and I would like to request all of you to also examine ways to contribute to the strengthening the preventive system. I'm really like reading out a list of all the things that I want to say. So I do hope it doesn't read like a laundry list, but I just wanted to share all these thoughts with you. The antimicrobial resistance endeavor that we have taken up, I think you can suggest ways to how do we improve the outreach to that, because the situation is getting scarier. I haven't had a time to study the AIMS study which was reported in papers, maybe Dr. Paul would have, or some of you would have, which also says the effectiveness of blood thinners is going down. But what I mean is that as we are coming up with newer solutions, older solutions are not just getting phased out, are getting phased out because of things like antimicrobial resistance. So this is something that you can tell us how. We have a national antimicrobial action plan which we can always share. Some of you have participated in it, but your support for AMR would be invaluable. During the AI India Impact Summit, we launched the strategy for AI in healthcare for India, as well as both, which is the benchmarking open data platform in health AI, for proper testing and benchmarking of AI tools. So I would request those of you who are involved in research and in developing AI solutions, do help take us help us take forward Sahi as well as both, because these are the two initiatives that we have taken, realizing that it's very difficult for startups or other people who develop AI solutions to really try them out, get them vetted, and get them incorporated into the public health system. So I would request. This year, NATHEALTH also participated in the pre-budget seminar, and we have had a number of announcements for the healthcare sector. One is, of course, setting up trauma and emergency care centers in all our district hospitals, then strengthening mental health services, including setting up another NIMHANS in northern India, and strengthening of allied healthcare professionals. So I'm very happy that NATHEALTH has organized a special session on this. We have been given the absolutely very challenging target of 100,000 allied healthcare professionals in the next 5 years. So this is something which certainly government cannot do alone, and we do need all of your support for this. Regional Medical Hub has been announced. DPIT is taking the lead in designing this, but your inputs would obviously be key to how to go forward with this. Last year, government had announced that we have to step up PPP in social infrastructure. And a number of states have come up with projects for which they have approached Department of Economic Affairs for VGF funding. So I just wanted to flag this, that this is another sector which is now looking up because government is giving the push for PPP in social infrastructure. Many of them have been cleared, and we look forward to seeing how they evolve. So indeed, when I looked through the theme of the session, the theme paper, I almost felt that I could hear you speak, your voice will really shape how these government initiatives can be taken forward, and for that I'm very grateful to all of you. I look forward to hearing more from this entire summit, and I will closely go through the proceedings. So do share those with me at the end of it, and I wish you productive and very useful deliberations. Thanks a lot.
Thank you very much indeed, ma'am, for your insightful address and for sharing the government's vision for strengthening healthcare delivery and advancing the goal of AROGYA BHARAT as India progresses towards Viksit Bharat by 2047. I would request Ms. Amira Shah to kindly do the honors of presenting a memento as a token of our gratitude to our guest of honor. Thank you very much indeed, ma'am, for sparing your valuable time and gracing this occasion. And now, ladies and gentlemen, to set the context for today's discussion, we now have an important overview presentation titled Swachh Bharat se Viksit Bharat, Why Investment in Health is Central to India's Journey Towards a Wealthy Nation by 2047. And ma'am has an important meeting to attend to. Thank you once again, ma'am. Let's put our hands together, ladies and gentlemen, once again to thank our guest of honor. And now for this important overview presentation, it is my pleasure to invite Mr. Parijat Ghosh, partner and head of APAC Healthcare and Life Sciences Practice at Bain Company, who are also the knowledge partners for the session. Mr. Ghosh brings deep expertise in healthcare strategy, policy advisory, and sector transformation across global markets, and his insights will certainly help frame the opportunities and priorities for India's healthcare sector in the coming decades. May I now invite you, sir, to kindly deliver the overview presentation.
Thank you very much for that, and good morning everyone, and welcome to NATHEALTH 2026. It's an honor and a privilege to share a point of view on how a Swasth Bharat can actually contribute very, very meaningfully to a Viksit Bharat. Before we dive into healthcare, and just to recap, since 2019, India is really going to enjoy 35 years of a very benign dependency ratio And you can see that it's come down from about 78% to about 50% before it again starts to increase in 2053. What this means in layman terms is that we will really have more working age individuals than dependents. And this is really a very structural opportunity, comes once in 100 years in this instance, to become a developed nation. And what does that mean? I think the words on the right really lay out that for us. It's about becoming a 30 trillion economy, and importantly, and Madam Secretary referenced that, increasing healthy life expectancy from 60 years to 70 plus years. Now, are these two things really two different factors? I would actually say that these are not. These are not unrelated outcomes. As the old truism says, health is indeed wealth. And when you see this chart, and we looked at data across 190 odd countries, GDP per capita is very positively correlated to health outcomes, and measured in here by the metric that the NITI Aayog had put out, which was health-adjusted life expectancy. This shouldn't be surprising at all. When people are healthier for longer, there is just more economic activity for a longer period of time, and that results in higher GDP per capita. What was interesting, however, and was this page, and this is a subtle but more important aspect, which is that countries actually get healthy before they get wealthy. So again, when we looked at the same data for these 190 countries, here, and we actually took a phase lag of 5 years, we saw that investments in healthcare that happened translated into a higher GDP per capita with a lag of 5 years. This is really the case for investing in healthcare, improving health outcomes, and consequently seeing that translate into better economic outcomes for us as a country. Now, India has been on this path since independence. I'm not going to go into all of the details in here, but this has been a journey that we've been on as a nation. And initially, it started with activities which were done by different state governments and a huge emphasis on public health and public health infrastructure. Over time, we had the private sector come in, and we saw the entry and the expansion of the private sector on different aspects, whether it was in terms of the provider space, whether it was the diagnostic space and the insurance space and so on. And over the last 20 years or so, we have seen a redefined and a growing role for the state and the central governments, including the start and the gradual expansion of universal health coverage. Now, these initiatives over the last many decades have led to very crucial and critical improvements in financial protection, in health system capacity, and population outcomes. So if I look at the chart on the leftmost side, and I know it's a bit of an eye test for people at the back, what it shows is that OOP as a percentage of the total health expenditure, that's been continuously decreasing. And over the last couple of decades, it's actually decreased quite substantially and is now at 44%. Similarly, if you look at the chart in the middle, which really talks to health infrastructure, here you will see that both in terms of just the health and wellness centers and the density of those, as well as the number of doctors per thousand population, all of those have again increased. And importantly, if you look at the chart on the right, some foundational health outcomes, like mortality, like immunization, these have increased very, very substantially, and we've made tremendous strides as a country over the last many decades. This is indeed something for us to be very proud about. But at the same time, the journey is definitely not over, and the problem is far from being fully solved. Our disease burden, whether we look at NCDs on the first row, or communicable diseases on the second, or actually more foundational health parameters like mortality, and we see that there is a lot of ground that we still need to cover up. And this is not only when we compare ourselves to upper income countries or high income countries. It's also when we compare ourselves to upper middle income countries. And that's where we need to get to if we really aspire to become a Viksit Bharat. What all of these indicators really translate into is a health-adjusted life expectancy of about 61 years. And that is really 7 to 10 years lower than any of the other comparable countries. That's the gap. That gap of about 10 years of health-adjusted life expectancy is what we need to bridge. This has a fairly significant cost to us. And we took a stab at measuring what that cost might be, and this is absolutely something that should worry all of us. The disease burden from all of these elements, in terms of dropping out from the workforce, in terms of lower daily productivity, in terms of just lower productivity over lifetimes, this translates into an economic cost of about 0.8 billion to 1 trillion annually. This is a very significant cost and something that we cannot afford. So we dug deeper into what have countries, this hypothesis that really if we increase health-adjusted life expectancy, we are able to drive higher growth. How does that really play out in practice? And we went back to the data set and looked at what has actually been the experience of countries, and not for short periods of time, but for decades at a time. And we looked at these two groups in here, countries that have been able to drive improvements of 8 to 10 years of health-adjusted life expectancy. And we saw that they actually saw on a sustained basis, they saw a higher growth rate in terms of GDP per capita. And this was actually over a period of 3 decades. Now that coincidentally is also the time frame that we have from 2020 to 2053. That's really the 3 decades that we have to transition fully into a Viksit Bharat and realize the potential of our demographic dividend. I won't go into the details again on this page, but when we looked at what some of these countries have done, the themes are very clear. And the themes are some of the things which Amira referenced, some of the things that Madam Secretary referenced. And these are really around, how do we drive access? How do we drive affordability? How do we drive infrastructure and make investments in infrastructure? And importantly, also with the changes that we see in the broader technological landscape, how do we make sure that we are able to leverage that technology and make sure that we are actually prioritizing systems of prevention over systems of cure? These are really things that other countries have done. We have also done these substantially, but not wholly. And again, when we look back at the National Health Policy of 2017 and looked at progress that we've made since then, we've again made tremendous progress. Our total fertility rates have improved significantly. The disability-adjusted life years, that tracking has now been fully established. Some of the points that I was mentioning earlier around maternal and infant mortality, we've made tremendous strides on those. There was a mention of the TB program. We've already eliminated things like leprosy, TB. We have our arms around that and very much are on track for improving on that. So there is progress that we have made. However, there is a lot more for us to be done. And at the highest level, I would say that as this group of the public and the private sector sitting together, there are 2 things that we really need to do. One is about making sure that we are able to increase investments into healthcare. And the second is to make sure that we are able to bring this increasingly complex ecosystem where each of the different parts are working on different topics. We are increasingly able to bring that together into an integrated governance system. On the first one, on investments in healthcare, we looked at the World Bank database and our current health expenditure. Think of this as the total health expenditure minus all of the investments that go towards capital outlays. Now that as a percentage of GDP has remained by and large constant over time at roughly the 3.5% range. Now this is actually materially lower than some of the other countries that we would actually, where we've seen that investment happen and we've seen those improvements in health-adjusted life expectancy. So the first priority is to be able to drive in more investments into healthcare, both public investments and private investments. This is not about the public sector doing all of these on its own. The public sector has been investing, and naturally, a lot of public sector investments will go towards the bottom of the pyramid, will go towards public health interventions which have a very high ROI. But given the tailwinds that we see in India, whether it's the mixed private-public healthcare system that we have, whether it's the upward economic mobility that India as a country is seeing and will continue to see over the next few decades, or frankly the massive potential of new technologies to get rid of some of the constraints in access and affordability and adherence that used to plague us in the past, there is a lot that the private sector can also do to invest more behind healthcare. So this is the first one, which is about how do we increase our investment in healthcare. The second and arguably equally important priority is around how do we organize for unlocking this potential. Healthcare, and all of us in this room know that it's a very complex topic. Multiple different stakeholders, and each of us are almost touching different parts of the elephant. We need to make sure that there is somebody who's actually being able to see the full picture and bring all of the different parts of the jigsaw puzzle together. There is a lot of accumulated experience in this room, in the private sector, in the public sector, in terms of learnings from other countries, etc., around what the technical solutions are that need to be put in place, for providers, for insurers, for diagnostics, and so on and so forth. I remember 10 years ago, with NATHEALTH, we had published a report called AROGYA BHARAT, which actually had laid out all of those technical solutions. I would say actually that at this point of time, it's less about the technical solutions, but it's actually about taking those technical solutions with a view to actually putting together all of these pieces together in a way that it is coherent, in a way that it is self-reinforcing. That's the second thing. Now, I'm sure that there is a question on everybody's mind around, this is a lot of effort. The real point is that all of this investment in healthcare, all of the efforts in terms of improving the health system, are they really worth the while? Now, as I had mentioned earlier, the objective that NITI had set out and what we've seen from other countries also is that we need to increase health-adjusted life expectancy. That should be the goal. It's not just about life expectancy, it's health-adjusted life expectancy. And as we had shown again earlier, if countries are able to increase that by 8 to 10 years, then there is a significant acceleration in the GDP per capita that we see. So we took all of that data and we went back and modeled what is the impact of this. And the data is very clear. This suggests that if we are able to make the right investments in a coordinated manner in healthcare, then this will translate into an improvement of 8 to 10 years in terms of health-adjusted life expectancy, and it will translate into a 5x in terms of the GDP per capita. So this transition, where we are really looking at doubling the investments in healthcare, making sure that we are increasing the health outcomes by 10 years in terms of health-adjusted life expectancy, and in turn seeing an economic outcome where the per capita GDP goes up from 2,800 to 14,000. That really is the journey that we should be all signing up for. That's the call for action. Thank you very much.
Thank you very much indeed, sir, for that insightful overview presentation for highlighting why strategic investment in healthcare will be fundamental for India's journey towards a healthier and more prosperous Viksit Bharat by 2047. Ladies and gentlemen, our guest of honor, Dr. V.K. Paul, Honorable Member, NITI Aayog, Government of India, is a globally respected medical scientist, pediatrician, and a public health expert, whose contributions have significantly shaped India's healthcare policy and the reform landscape. served on the faculty of Department of Pediatrics at the All India Institute of Medical Sciences, New Delhi from 1985 to 2020 and led the department of head for nearly a decade. In August 2017, the Government of India appointed Sir as the Honorable Member of NITI Aayog in the rank of Honorable Minister of State, where he leads the health, nutrition and education verticals. So let's put our hands together to welcome Sir for the special address.
Thank you very much. Good morning. Namaskar. Respected Ms. Amira Shahji, Dr. Sangeeta Reddy ji, Himanshu Banerjee, Parijat Ghosh ji, Vishwa Gupta ji, Varun Khanna ji, and distinguished leadership of health, healthcare industry, innovation ecosystem, present in the room and representing the very best of our health system, stakeholders this morning in this room. And thank you very much, NATHEALTH, for creating this wonderful convening today. And as has been stated by the President, this meeting, in many ways, like other meetings, but this meeting for sure is coming at a point when there is a very special discourse around the future of healthcare and what we all can do together as partners. I'm very impressed with the presentation made by Parijat ji just now. This is the kind of work that really helps us, particularly at NITI Aayog, but helps the government in general to look at pathways of improving the policy ecosystem, the program ecosystem of the country. And in this case, with regard to the health sector. So thank you for bringing out these wonderful reports, and I'm privy to several other inputs that NATHEALTH you have provided. So a big hand to the members of NATHEALTH and the leadership of NATHEALTH. It's a gratitude, statement of gratitude. Thank you. We are enlightened by the very impressive presentation made by Secretary Health, Madam Punya Salila Srivastava ji. And you can see that the nation, the last 11, 12 years, has seen transformative changes in the healthcare ecosystem. Focus on strategic spending, focus on universal health coverage, focus on health assurance, focus on primary health care, human resources, digital health, and so on and so forth. So amazing times that we are living through, and God bless us all for being part of this very transformative phase in the history of our great nation. Let me pick up from where Parijat ji left us thinking. As I said, I truly appreciate the kind of work that has been put together. It's a great trigger for this meeting. I think you laid down a very strong case for focusing on healthy lifespan and not just a long lifespan. Point taken. You also brought out examples from other nations to make a case how investments and efforts in this regard can be truly transformative, not only for health per se, but also for national development. Let me add here that the Viksit Bharat goals have a specific target for both life expectancy at birth and also health-adjusted life expectancy. Just as we have the Viksit Bharat goal of India being a $30 trillion economy, or translating into 18,000 US dollar per capita, adjusted for prices by 2047, the health indicators are the following. 1, achieve a life expectancy of 85 years or more. Currently 70, 71. Let's say 71. So we all will keep in mind, because Nat Health is about bringing that power, resources, ideas, energy to achieve the national goals. So journeying from 71 to 85. The healthy life expectancy target is actually 75 or more. So 71 is a little bit of a lower aspiration. We will raise it and we will discuss what it takes to reach there. So we can work backward. So you have put 71 here, which is fine. The reason these two numbers came up, 85 and 75, is because that's where the world's most of the advanced nations are at the moment. 85 is the life expectancy in much of the Europe, or Northern Europe. Japan is 89 perhaps, which is at the top. By the way, US is a little bit lower at about 83, that's my information. And healthy life expectancy benchmark of 75 to my mind exists in some of the nations that we need to perhaps correct some numbers here and there, but it exists in the nations where healthcare is good, longevity is good, and healthy longevity is good. So 75 and 85. That's what we are going to work with. Keeping in mind the conditions that cause reduction in lifespan or healthy lifespan, how they will change, because we are living in a world, in our country, in a world where we have the problems of the past and in the future issues as well, stating the obvious. So we have the agenda of eliminating communicable diseases and improving child mortality, reducing maternal mortality ratio and so on, and at the same time we are challenged by non-communicable diseases, and because of the biology and environment and everything else, that impact is more than the impact that you would usually expect if you take world as one cohort. We seem to have that extra risk, and this group knows that part. So we have the non-communicable disease challenge, which actually is the most important to be addressed, because we need, I would say, refined approaches, if not even new approaches to address that, and I'll come to that in a minute. So we have a mix of problems that we have to take care. And some problems more in some states, and less in the other states, and vice versa. So we will have to keep in mind how we strategize, but the core of this increasingly is the challenge of non-communicable diseases, the hypertension, the diabetes, the renal failure, liver failure, and problems due to road traffic injuries, and so on and so forth. We'll keep that in mind for our discussion. So we need to charge ourselves to move in that direction. So I endorse this endeavor in this meeting. That's why I say every meeting is special. So this meeting is special because for the first time, in a very emphatic way, we are saying that it's not only about survival and longer life, it's about good life. And we want to meet the benchmarks of the best in the world, and we aspire to do that. So this changes the discourse in some ways. I am privy to, in my journey, a free focus on child survival. So the whole endeavor for my generation of stakeholders, pediatricians, and so on, was really mortality कम करो, बच्चों की mortality बहुत high है, newborn mortality high है, and we had the impetus from the national health policy, impetus from the MDGs and now SDGs, and we all, as nations, as professional groups, we moved, and providers, we moved in that direction. I'm also conscious, with a little bit of guilt in a way, that quality of survival was talked about, and when it was talked about, it was more like a gross quality. So newborn can relate it. So we say, okay, no gross intraventricular hemorrhage, no ROP, and a little bit of, lackness for nutrition, lagging or something. वो इतना focus में नहीं था. That we have to save every IQ point of a newborn baby was not today's an aspiration. It wasn't. Gross IVs तो नहीं है, PVL तो नहीं है, ROP तो बच गए. So survival and therefore longer life was the goal. Let me just tell young people here that at the time of independence in 1946, the Bhore Committee report estimated life expectancy of our nation as 27 years. 30 years, less than 30 years. And the life expectancy in UK at that time was 58 years. So that's a gap of 20 points, right? And who cared? 30 years was the lifespan. Today we are 71. So a lot of things have happened within the health sector and beyond the health sector to see that change. So today we aspire our life expectancy to be 85 or more, and we aspire for healthy life expectancy to be 75 or more, and that becomes now the mantra, the impetus point for all of us to rally around. Having said that, I'd now like to pick up first from the point that Madam Punyaji made, and that's about the budget announcements. So very quickly, to reiterate the fact that we please rise to the occasion. We have a commitment for training 1.5 lakh caregivers. Scaling also has to happen in the ecosystem that you represent, at least partly, if not hugely. What is it that we can bring? Because these caregivers have to have clinical exposure. They draw upon the tools that you have developed, we have developed for doctors and nurses, because the core happens to be those knowledge and skills. So what can we do for that? Second, I mentioned about improving emergency and trauma care services at all our districts. It means better infrastructure, better services, trained human resources, perhaps injection of a few more human capital into the system. It's about, of course, then a larger ecosystem, strengthening the ambulance system and the triaging system, the pre-hospital care. So let's start thinking about where you can come in. It's largely committed for the public sector, but where is it that we can bring the synergies in this regard? Connected to this is BHARAT program. As you know, now we have 1.5 lakh coverage for 1 week of care for any victim of road traffic accident, any victim, Indian or foreigner, to be provided care through the network of PMJ institution as of now, but hopefully it will expand. Please start thinking about how you can play an important role. Imagine, you're talking about UHC. This is UHC. And the most profound need that emanates in these situations. Allied health professional, I am already mentioned. A huge commitment has been made by the government. We need total support from you, huge support from you. But please do not compromise on the quality. Skills, not only knowledge. Knowledge is only entry toward competence. That path passes through very high quality skills. It's a challenge because we're rapidly expanding our human resource training and quality, skills quality, mindset quality, empathy. The 3 domains of any health professional are knowledge, psychomotor skill, things that you do with your hand, and then the attitudinal skills, which is communication, empathy, care. All these are equally important in a training program, so I urge you that please bring the resource, but also think about how we can bring in extra quality of it. Regional medical hubs, 5 regional medical hubs have been announced, and this you have a huge opportunity. In fact, this work has emanated from your colleagues at the formative work, and I'm so happy that it is now going to take shape. It's about integrated system where there is tertiary and quaternary care, where there is health and wellness and Ayush systems, where there is rehabilitation, where there is a whole lot of technology, where there is also the care of domestic patients as well as international patients, so visa facilitation and things like that will be important. And technology will play a very, very important role. This is truly, a lot of it is all private partnership. So be ready for it, bring your ideas to the system, and I think it's an exciting time. And for this, the clock is already clicking. In my second segment, and the last segment, I like to highlight a few issues on critical building blocks that you all have referred to one way or the other. Firstly, beds. My colleague Dr. Rajiv Sen and his team have estimated that in the country we have about 19 lakh beds, let's say 20 lakh beds, right? And the country, even if you use different benchmarks, we have a deficit that's staring at us. I'm triggered by the mention in your background notes about 1 lakh more beds are ready to be created through an investment by 2029, and I applaud that. But let me just show the mirror to all of us. So we have 20 lakhs, let's say 18, 19 or 20 lakh. The NHP, National Health Policy, aims at 2 beds per 1,000. The current beds translate to 1.4 bed per 1,000. 1.4, 18 to 20 lakh, and National Health Policy, 2.6 cut deficit. This itself calls for 8 lakh beds by 2025. तो स्कोप है, प्लीज, और उसमें भागीदारी प्राइवेट गवर्नमेंट दोनों की होगी, वो मैं समझता हूँ. If you take the LMIC benchmark, it is 2.3, and then we need 12 lakh beds. That's what Dr. Rajiv Senji and his team has said. If you go to global average, it is 2.9, 20 lakh more beds. Okay? You can see how to pan out. And if you go to high income countries of the day, the average is 5.3. 5.3, which is about 50 lakh more beds. The point I'm making is huge expansion for infra will be needed to make a change that we are aspiring for. Healthy life expectancy cannot come without infrastructure. And this is one top indicator of the infrastructure. We need infrastructure. The speed will hasten as more resources come up, as economy is not going to jump from 4 to 30 million in 47. It's going to be sloped like this. So with time, there will be increasing resources available to the nation to invest in all this. So we should have a plan. Acceleration, more acceleration, and then super more accelerations. Keep this in mind, that there is a whole scope, big scope. You know this game better, where to establish tier 2, tier 3, and I would love to also add to this that small nursing homes, please think about them. Small hospitals, please think about them. That's where the bulk of beds are. Please, constant reminder to the leadership here that think about that bottom of the pyramid. Today, even today, in PMJ system, we are dependent hugely on that ecosystem. I want to appeal to you, kindly expand your inclusion and their concerns and bring them to the table. Even in Delhi, can I talk about Delhi a little bit? Again, analysis done by Rajiv ji. Delhi has about 56,000 beds. 47% of them are in the private sector. So about half of the beds in Delhi are private sector, broadly. Now, our current ratio of beds in Delhi is 2.5. So average is 1.4. It has to be, because we are capital, we are a city-state, etc., etc. But then, if you compare the bed requirement for, say, top nations, then I've already mentioned you some numbers, 4 or 5. Delhi always will have much more. So let's say 4 per 1,000 in the next 10 years, because Delhi not only caters to the capital territory, but beyond, and from very, very far beyond. So if you pitch for even 4 by 2035, we will need about at the least 15,000 beds in Delhi. आप कितने बनाओगे? सोचिए. और इसके बारे में I'm happy to state that Delhi government is in dialogue with NITI, and we have some thoughts around it. So think about Delhi-centric ideas also, or the NCR-centric ideas, because we will need these beds. They need to be affordable, they need to be high quality, they need to be include the PMJ system, then only it will serve the larger population, the needy population. That's my first point. Second, insurance. We need to remind ourselves that private voluntary insurance ambit has to increase, and we are stuck here. We are making very little progress. About 10% Indians, 8, 9, 10% of us have private insurance. There is that age-old story of missing middle of about 30 crore to 40 crore people, potential market for insurance, GST removal helps the cause of insurance. We need some smart ideas around insurance, how private insurance gambit can be increased, and this discussion must happen. Can there be good insurance products which can provide reasonable coverage, let's say equivalent to the PMJ coverage, for a person whose monthly household expenditure, for a family with household expenditure of about 25,000 rupees, because that's what the 60th to 70th quintile of our nation spends. So 25,000 जिसकी income है, उसके लिए कोई इंश्योरेंस प्रोडक्ट हो सकता है जो 5 लाख को कवर करे उसकी फैमिली को. सोचिए जरा, ये अभी एनिग्मा क्रैक नहीं हुआ है. Perhaps technology can reduce the cost on the part of the insurer. Perhaps there can be insurance products which are really serving mid-sized hospitals where the economics may be different. Why are we talking only about insurance products or XYZ kind of hospitals? What about smaller hospitals? And so on. So we need innovation in that area, and please guide us in that regard. I want to remind us that among the unfinished agendas, before 30, but let's say before 2029, the nation will eliminate TB, leprosy, lymphatic filariasis, Kala-Azar certification will happen, and measles and rubella will be eliminated. Please, we all have to put, might into it, and malaria, we should be in the phase of ready to be certified, which will happen 2030 as a goal, SDG goal. But all this, so I'm repeating the diseases on which your focus should be, please. The old agenda: malaria, leprosy, lymphatic filariasis, Kala-Azar certification, TB, measles and rubella. We will all keep this in mind. I'd like to now mention 2 more points. One, the time has come that we increasingly talk about quality of care in a formal sense, in every place, public hospital, government hospital. अभी भी करते आए हैं, अपने तरीके से करते हैं. But can this be a national movement, and you can be a partner in your own ways? Private sector has had a paradigm of quality assurance, quality management in a certain way. A lot of this is at the institutional level, not necessarily visible. But then quality of healthcare has to become a norm, because longevity, with healthy longevity, will require that the services are not just there, but they are of a quality, and the outcomes befit the effort, and the outcomes befit a Viksit Bharat. So forward movement on quality is one very important area. We are looking forward to your partnership in this regard, and our team is trying to find pathways how to work together in this area. My last point is that for the non-communicable disease, being the major challenge, the path to address them based on science, based on understanding of physiology, pathology, epidemiology, clinical pathways, the real path passes through primary health care, and primary health care. Please apply your mind how India's paradigm in that regard could be different. They may not have done it, we don't care. But when we are facing it, we keep in mind that primary health care is the key. तो अगर ये commitment हम सबकी है, तो आप सोचिए कि आप primary के लिए क्या करोगे, primary care के लिए. Why am I saying this? Let's take example of diabetes. Can it be prevented? Primordially prevented? Yes. Obesity, reduction, lifestyle change. Challenge here is at individual level, all this can be achieved to an extent. We have to demonstrate that we can have primordial prevention on scale. And that's a very different ballgame. That in a district, today there are 11% diabetes. And then when we go after 2 years having worked, they drop to 7%. This is still to be demonstrated. Can we work in that direction? And the science is available for us to build on. If not primary prevention, secondary prevention. which means you screen and then you know that you have it, you take action. Several of us in this room, I'm sure, are in that kind of a paradigm. And you address by either changing the risk factor, surely, otherwise using medicines appropriately. So secondary prevention, huge scope, because that's how most of the, shall we say, well-off people have at least access to that system. And then individual counseling, an individually developed program that addresses the need and so on. The third is, a difficult case. When the events happen, how you address them, we are creating a net for that. But the real journey, the real essence, and the real approach is, can you prevent primarily or secondary prevention? Therefore, please help us how primary health care, to which Madam made a reference, 1,80,000 Ayushman Arogya Mandirs, which have been loaded with this responsibility. What can we do about it? And that, I think, should be a serious debate coming from the leadership present in this room, because otherwise, when you're addressing it there, all the GDP estimate that you're showing will get disturbed because there's so much more spending to be done. And then I think there are staggering calculations if you have to address NCD at that point of our journey. So I urge you, therefore, please think about primary health care. I urge you, please support the cause of family medicine specialists, general practice specialists who can look after, every age group, including the elderly population, to which again the reference has been made, and so on and so forth. So please endorse and think about what specific things you can do for primary health care. It may be technological solution. It may be partnership at that level. It may be a behavior change that you may like to mount, which you have done to an extent. But we have to go to a stage where it demonstrates impact. It demonstrates that there is a population with diabetes on treatment and their sugar, their HbA1c has been controlled. So I urge you to put your ideas behind the fundamental part of, and perhaps the most important part of the health system, namely primary health care, because India's journey for universal health coverage and for healthy life expectancy goals, the Viksit Bharat goals for the health sector, pass through primary health centers and primary health care. Thank you very much. Jai Hind.
Thank you very much indeed, sir, for that insightful and informative special address. Ladies and gentlemen, today we are honored to present a series of thought leadership publications and knowledge reports developed in collaboration with our esteemed knowledge partners. First, we have the release of NATHEALTH's flagship publication developed in partnership with Bain & Company, titled Swachh Bharat Se Viksit Bharat. The report highlights a crucial message that investment in healthcare is central to India's journey towards a Viksit Bharat. May I also invite on stage from Bain & Company, Mr. Parijat Ghosh, Mr. Dhruv Sukrani, Ms. Bhavini Malhotra, and as well as Mr. Siddharth Bhattacharya, Secretary General NATHEALTH. And I would request our guests of honor and esteemed dignitaries on the dais to kindly do the honors of releasing this report. Let's put our hands together, ladies and gentlemen, for the release of this very important publication. And we now move to the second publication released by NATHEALTH, developed in partnership with Praxis Global Alliance, our thought leadership and knowledge partners, titled Health Financing, Critical Enabler for Patient-Centric Care. And I would like to invite on stage from Praxis Global Alliance, Mr. Ariman Tandon, Managing Partner and Co-Founder, and Mr. Akhil Puligada, along with Mr. Siddhartha Bhattacharya, Secretary General NATHEALTH. I would request our dignitaries to kindly do the honors of releasing this report. Ladies and gentlemen, this report focuses on the critical theme, alignment and convergence of payers and providers to enable more accessible, efficient and payer-centric healthcare delivery in India. And a round of applause on the release of this report. Finally, we move to the third and the final publication released by NATHEALTH, developed in collaboration with AdFactors PR, a thought leadership and communications partner, titled India's Healthcare 2047. This report presents a forward-looking vision for building a symbolic payer-provider-patient ecosystem. May I invite from AdFactors PR, Mr. Mihir Bhosle, Senior Accounts Manager, AdFactors PR, and Ms. Chehek Mishra. And of course, we have on the dais with us Mr. Siddharth Bhattacharya, Secretary General NATHEALTH, requesting our dignitaries to kindly do the honors of releasing this report. Thank you very much indeed. This report will serve as a valuable reference point for policymakers, healthcare providers, industry leaders, and innovators as we collectively work towards building a stronger, more resilient and future-ready healthcare ecosystem in India. And ladies and gentlemen, as we approach the conclusion of this session, it is my privilege to invite Dr. Sangeeta Reddy, President-elect, NATHEALTH and Joint Managing Director, Apollo Hospitals Group, to kindly deliver the concluding remarks.
Good morning, ladies and gentlemen. Namaste. Dr. Paul, Amira, senior colleagues on the dais and in the audience, such a pleasure and a privilege to be here to see the immense potential of what we have ahead of us. A vision has been outlaid. Amira began, this Punya gave us such an amazing list of all the outstanding things that the government is focusing on and literally invited us to partner. And Dr. Paul, in his inimitable style, with his deep knowledge, tremendous capability, and openness, literally inspired everyone, from primary healthcare to infrastructure and beds to partnership across many realms. And finally, Parijat, no one is going to forget the tremendous capability that every single one of us in this room and many beyond are going to be working on a very important aspect. We join the Prime Minister and his vision of Viksit Bharat. We join the country's ambition of a 30 trillion economy, but we play a significant role in that the health comes before the number, and we are potentially saving $1 trillion because we are bringing forth a healthy population. How much more inspiring can anything get? So thank you very, very much for everyone who came ahead. And thank all of you in anticipation for this renewed vision, vigor, to make this possibilities a reality. I think that's what we're here about. We've heard the most fantastic session so far. I'm not going to reiterate the tremendous things that we need to do, because all of you know them. I am going to outline very, very briefly just 5 points to say how we can help make this come together. And the first one is really the vision, the dream, the possibility. Never in the history of the world have we been able to say with the same conviction that yes, we can. We can dream and deliver universal healthcare. Never in the history of the world has the world needed us so much as now. Because earlier you could influence small pockets. Today your sphere and realm of influence is literally limitless. And therefore, this ability to take the challenge and the vision and the potential and the capability, the first step we have to do is coming together. Coming together as private sector, coming together as providers and payers, coming together as government and private and policy and implementers, as large hospitals and small hospitals and clinics and family physicians, and science and innovation and startups and large manufacturing. That ability to come together, asking, a few years ago I would have said there is only one question to ask. Is everything that I'm doing or anything that I'm doing making the patient's life better? But today we have a different question to ask. And that question is very simply, is everything that I'm doing keeping my population healthier? Because the realm of our responsibility has moved beyond sick care. We have to do the most advanced sick care. We will continue to do cardiac transplants and bone marrow transplants and innovation and advanced surgeries to the level that the world is coming to India for care. But along with the responsibility of sick care, along with the responsibility of amazing pharma and manufacturing and devices, is now this responsibility of keeping the population healthy. And I reiterate the beautiful point that Dr. Paul picked up, that this is the stage where for the first time we begin to speak not just about life expectancy, but about health-adjusted life expectancy. And please make that note, make this point. This is going to take the history of India's health policy and health delivery forward. So whether we're doing it with dynamic screening, whether we're using the government policy of health access, our Ayushman Bharat will expand in its scope, the missing middle will get covered, health insurance will have greater reach and capability. All these points will come together. And then the data. We use the data for more insightful, targeted approach to customers proactively. We use the data in partnership with scientists to find new cures, to build new solutions. We're working with an amazing company on ultrasound so that you can screen with AI embedded, NAFLD. We know how many technicians we have who can do a good ultrasound. Imagine if the ultrasound machine had an AI to pick up NAFLD, 40% of India's adult population is at risk. The number of liver transplants required in this country are growing every year. If we could pick it up at that early stage. So Dr. Paul made this point. I'm bringing this point alive for all of us. This is primary care. This is proactive preventive care. This is partnership with science and research and the use of AI, all converging towards that single question we have to ask ourselves every day. Is everything and anything that I'm doing helping to keep our population healthy? That is our new mantra. That is the new challenge. That is the power of what we have ahead of us. So whether it's diagnosis of eclampsia, figuring out how we prevent doing joint replacements because we figured out stem cell replacement, finding cancer early, averting cancer, building vaccines for preventative care, working on antimicrobial disorders, the realm of the need of this country, this population, and this world is incredible. But in the same breath, the realm of the brain power, the vision and the mission that we have, and the capability, and maybe even the jugaad and the innovation, all put together, can make India not just the pharmacy of the world, but the health provider of the world. Can make India stand up to say that we created a new, reimagined health system which can bring this vision into reality. We once dreamt of saying no child should go to bed hungry. Today, can we say that no individual should be denied care? Can we go beyond saying that to say it's not just we've invested on the health infrastructure, we've worked together, the government has put policy, we have enough nurses and doctors, we've built a framework of continuous learning so that science is embedding into day-to-day care. We've connected the ecosystem with the primary health care all the way up to tertiary and science so that we are bringing these alive to the customer and to the patient faster than any other health system in the world. We've done all these. That is the vision for the next few years. And then we go beyond. To say the way we do it is more empathetic, more kind, more respectful than any other health system in the world. The cost at which we do it is lower and more creative than any other health system in the world. And the methodology that we do it will include not just what happens within our institutions, but will include what happens outside, because health begins at home. And the movement of the empowerment of the individual. For the government was responsible fully for care. This became a shared responsibility with doctors and hospitals. This is now a shared responsibility with corporations and insurers. It's now a larger shared responsibility and a primary central responsibility of every individual. So the education towards a healthy environment is validated, and not just Instagram posts that we receive on drink this and do that, but this knowledge is validated and encapsulated into our policy and rewarded for good behavior. Each one of these lines has a policy, has an operations, and has an implication. So I want to end by saying that I believe that we've come very far. When I told my father, Dr. Pratap Reddy, that I'm going for this program and this is this thing, I'm going to be president-elect, he said, okay, we started this 14 years ago and everybody's come a very long way. But please tell them not to be satisfied with what has been achieved. Please find a way to communicate that there is so much more to be done. There is still many people who are not getting the care. There are many members of population who don't realize what good has been done, and sometimes the negative talk is larger than the power of the positivity of the lives that are being saved at the cost that India is delivering healthcare. And more importantly, science has opened up so many realms. So let us repledge to do more. Let me thank Amira for the great work, my team members for the potential of what we're going to achieve together, the Secretariat for everything that's happened, and most importantly, Dr. Paul, for being responsive, for being a guide, for being a mentor, for being an inspiration, and giving us the strength to dare to dream that we can work together, that we will break the silos of our own institutions and build true partnerships, because we have done it before and we need to do it once more and many, many more times to achieve that vision. So thank you all very, very much. I will end by only saying that let's take this conference and these dialogues back home, back to our offices. Very often we sit in conferences, we love it, we're inspired, we have intellectual debate, and then we continue to do what we used to do yesterday. Please let us ensure that the power of the vision, the potential of the capability, and the fact that the world is moving so fast. Some of you may have realized it, but from February 6th to March 17th, something incredible happened in the healthcare world. You're wondering what? All the 5 major AI giants, all of them, announced their healthcare positioning because they realized that every single day 40 million customers across the world were querying their AI engines, whether it was ChatGPT or Claude or whichever one they were using, all of them were being queried on health. Health is actually becoming the single largest question in people's mind. ChatGPT announced ChatGPT Health. Claude and re-emphasized their health positioning. Every other Perplexity said Perplexity Health. So this is the power of the position that we are in and the power of the potential that we have. So please, don't go home and do what you were doing yesterday. Find your way to find the answers to the question, what am I doing? What can I do to make the population healthier? Thank you all so much. Namaste.
Thank you very much indeed, Dr. Reddy, for concluding this session on that wonderful positive remarks from you. I would now request Ms. Amira Shah, President NATHEALTH, to kindly do the honors of presenting a memento as a token of gratitude to our guest of honor, Dr. V.K. Paul, Honorable Member, Niti Aayog, Government of India. And I would request all our dignitaries to kindly come forward for a group photograph. So ladies and gentlemen, with this inspiring start, we now move forward to our next important session. I would request everyone to kindly remain seated as we straight away move ahead with the proceedings of Session 2, Viksit Bharat, Healthcare Sectoral Reforms. Thank you very much indeed. Ladies and gentlemen, while we are getting the stage ready for the next session, I once again take this opportunity to extend our sincere gratitude to all our sponsors and partners, our gold partners, gold sponsors, Apollo Hospital, Indian Capital, Polymed, IQVIA, Peerless Hospitals, Philips Harrowcare, Test You Can Trust, Maringo Asia Hospitals, Humane by Practice, Jupiter Hospitals, Patient First and Roche. Heartfelt thanks to our silver sponsors, Afford Plan, Quality Care India and Metropolis, bronze sponsors, BD, BPL, Shamrock Hospitals, Dr. Lal Path Labs, Fortis, Wipro GE Healthcare, Intuitive and PD Hinduja. Our session sponsors, Agilus Diagnostics, Ambuja, Neotia, Khaitan and Company, Mediversal, RAT 365 and Striker. We would also like to recognize our knowledge and thought leadership partners, Bain & Company, Praxis Global Alliance, Convergence Foundation, Gates Foundation, Price Watercooper House Services LLP, Indium Capital Advisors Private Limited, and Ad Factors PR. So ladies and gentlemen, warm welcome to Session 2 of the NATHEALTH and Annual AROGYA Bharat Summit 2026. This session is supported by the knowledge partner, the Convergence Foundation, and will focus on exploring how deregulations and policy reforms can unlock private capital to accelerate growth, innovation and accessibility in India's healthcare sector and ensure that quality healthcare reaches every citizen. And may I now invite once again on stage our distinguished session chair, Ms. Amira Shah, President NATHEALTH, Promoter and Executive Chairperson, Metropolis Healthcare Limited. Warm welcome to you once again. And ladies and gentlemen, it is also my proud privilege to invite a distinguished policymaker who has been closely associated with shaping India's development agenda. Let's put our hands together to welcome Shri Rajiv Kumar Sen, Program Director at Niti Aayog, Government of India, who brings with him rich experience in public policy governance and strategic program implementation, contributing significantly to the key national initiatives. And I would request Ms. Amira Shah to kindly do the honors of welcoming Shri Rajiv Kumar Sen ji with a floral bouquet. Requesting everyone to kindly be seated, please. All those standing in the front are requested to kindly take their seats. The session is in process. Thank you very much indeed, ma'am. Very, very warm welcome to you, sir. And now, ladies and gentlemen, I hand over to Ms. Amira Shah to kindly lead the conversation on reimagining healthcare regulation, government reforms, and the road ahead. Over to you, ma'am.
Hi everyone. Can everyone sit down, please? We have a very important guest with us here, Mr. Rajiv Sen, who
has been working very closely with us on solving many of our problems. So if you want to know what our solutions are, you have to sit down. So this was originally supposed to be a speech by me and then by him and then the panel, but we thought since we're running a little bit late and we wanted to keep it tight and quick, we thought we'll turn it into a fireside chat, more into a sort of a question and answer. So just to set a little bit of the context, we created a compliance report, which we've identified few hundred areas of bottlenecks that all industries in healthcare face. And we took this to Mr. Rajiv Sen and to Dr. Paul, and we said, sir, how can you help us with this? Because we need to start to solve some of these issues to really enable productivity and investment back into the industry. So they were very gracious and they said, you know what, we want to solve some of these issues for you. So we identified top sort of issues, about 10, 20 of them. And they have been working with us and with the high-level powered group to sort of say, how do we solve this? And this goes across 10 to 12 ministries. This is not something which can be solved just by any one ministry. So it's going to require a great amount of work. So thank you for being here. So just to start with it, I mean, when you saw the compliance report that we came out with, and with the hundreds of challenges that are sort of being faced, what was your initial thought? What did you feel is a role that you and your team are able to play in this to solve it? And I'm sure our teams here would love to know, do you think all of them are solvable?
So thank you very much, Amira ji and NATHEALTH, for inviting me. I think you all have heard the illustrious speakers in the earlier session, Sangeeta Reddy ji, Amira ji herself, and then of course Dr. Paul. I think the overall vision has been laid, which all of you are aware. Now, coming specifically to the issue of regulation, what we realized is that many of the things that we had taken for granted, building a hospital, we thought it's a matter of money, it's a matter of having the person, and then the equipment, and then the hospital is built. When we looked at the regulation, we realized that it's not so. There are many, what you call wheels within the wheels which need to be sorted out. There are issues in the legislation or in the rules themselves, and then there are issues between states, among states, and within the central government also. So when we saw, it was not that we were not aware, but when we had the report, we could understand that how things are interrelated. One building, what a fire license can, how it can stall. Intentions were always good. However, the way it was spent and the way it was being implemented, there was a necessity to look at it afresh and see how things could be made simpler. So with that objective we started, and then of course I'm just taking fire license as an example, there are many others. I would just like to say that now Government of India has set up what we called the high-level committees. That is under one of our honorable member, Dr. Rajiv Gauba, who was earlier the Cabinet Secretary. So 2 committees have been set up. They have been named. One is the Viksit Bharat, HLC on Viksit Bharat, and the other one is HLC on NFRA, Non-Financial Regulatory Reforms. Under this, most of the health, medical and pharma-related issues that have come up, that was a part of the report, and then other organizations have also come to us. We have had several stakeholder meetings. And we are trying to address those. Many of those have already been recommended. Some are in the process of discussions. And I'm sure that with these, these regulatory reforms being done, it will go a long way in helping the medical industry in being more efficient and more streamlined.
Thank you, sir. One of the points, which was at least few hundred, was around the PNDT Act. And that's been something which has, I think, troubled the industry now for many, many, many years, right? The criminalization of it, the kind of strong penalties that are there. So I think the idea is that, obviously investments will be made in the industry if there is a sense of some sort of a trust and managing to exception, where the people who actually are not following the rules and the compliances certainly must be penalized. But generally, you don't want sort of a rent-seeking behavior through it. So how do you think this can be changed as we go forward to really sort of make this, because as we know that sonography can actually do early diagnosis in a very significant way. And only to solve the sex determination issue, this has actually come to a standstill for many other things. So if you could talk a little bit about it.
So it's a very pertinent point, but as many other things, it has two sides. As you know, why the Act came, of course it had a very noble purpose, it still has. So having acknowledged that, I think what we need to do is to look at how it is being implemented. So the fact that something bad is happening always, or something wrong is happening, doesn't always mean that the rules are inadequate. Sometimes it is a matter of implementation. I think this is what we need to understand, and we are looking at the PCPNDT Act also, and we are in discussions with all the stakeholders, and I'm sure that we will come up with some solutions. As of now, it's still in the process of discussion, but yes, there are issues. So when we talk to some of the stakeholders, they say, no, we cannot change anything because, this is. So we are telling them, you see, that it's not the Act is wrong or there is something missing in the Act. What we need to do is to look at the implementation. Suppose we put a blanket ban on all USG instruments, because all those are not being used for fetal detection, sex determination and all. So I think these are the things which we need to solve, but let me tell you that this is a difficult area, especially the PCPNDT Act. We are working on it, but it will take some time. And I'm sure there are many advantages. I don't have to tell you. There are issues. The stakeholders have had meetings with NITI Aayog also. We are aware of those, and we are trying to see how much we can progress. But let me see, it will take time. However, there are other areas like National Medical Commission and all, many of the things. I'm sure within the next few months you will get very, very positive news on those fronts. And I think those will be a game changer as far as our medical capabilities, setting up of hospitals and regulations are concerned. I think that those are going to be game changers.
The two areas that he's referring to on which we have seen progress and we are hoping to see some outcomes. One is where the diagnostic companies we struggle, because according to NMC, according to state judgments and according to NABL, the rules around remote authorization are all different. And therefore, we all get caught in a tangle of what is really what we are supposed to follow and not follow. The other area which came up, which has again seen, we are going to see a lot of progress with this one, but we are also seeing a lot of progress on the potential building code for hospitals. That's right.
So just let me say, it's already happened. The recommendations are already there, and I think some of the members met and we have discussed also. So, what we were thinking, I am talking from the medical side. Building laws में ये है 30 feet high इसको बढ़ा दीजिए. ये जो basement में ये allowed नहीं है इसको. So we were thinking on those lines. But the view that has been taken is a much broader and much better than what we would think of. So now the thought process or the recommendation is that it's not changing minor things here and there. It's a whole change in the mindset that you cannot have these types of specifications. You should have as in developed countries, everything related to the functionality and everything related to outcome. So it's not that you cannot have a 60 floor building. If you have a 60-floor building, what are the other things that you do? So from an input-based type of a regulation, we are planning to move to the opposite, where it will be based on outcomes. And in the process, all the issues that we had will be sorted. So this is the broad brush type of a thing that we are looking at as far as regulations are concerned, and definitely specifically for the medical sector also.
Thank you. One of the things I think that we all struggle with is that there's unfortunately a large, because of lack of enforcement on the ground or a lack of sometimes clarity of rules, people are sort of, or organizations are doing what they want, right, in many ways. There's a small percentage of Indian organizations who are sort of following whatever rules they can find, but there also may be a large part who we don't know the rules are not following. But often we find the rules are made for stopping the wrong things, but not necessarily to facilitate innovation or new things, right? And therefore, sometimes when people want to progress, you are stopped because of some other law which is created for somebody. So in a situation where we are in India, where state and center have different points of view, where you have very small and you have big, how do we look at this landscape and actually create a situation where, yes, you're stopping people doing from wrong, but you're also facilitating people who want to run forward?
So again, this is a very classic case, and let me tell you, this state versus center is not always because of the political issues. Sometimes there is a matter of appreciation. Just to give you an example, again on the NBC, many states thought, even I for that matter, didn't know that NBC, the codes are recommendatory in nature. So what happened was, states picked up sections, some sections, put it in their act and made it mandatory. Whereas the spirit of the act was that it is recommendatory in nature. States may or may not follow. So I think a lot of things, states, what they do when they see center doing something, they take it as a gospel truth, or you have to do it. I think this is what we need to break. And then of course interpretation is another issue where, if the law says something, it could be interpreted, and the interpretation varies from state to state. So to do that, also, it needs that clarity in the actual act or the spirit of the act. So in the NBC, what we are doing, we are writing the new version that will come, will have very clearly written that this is our recommendatory set of guidelines. So I think sometimes, even the way we write the laws or the acts, it needs to be made simple and be very clear as to what it purports to do. I think that is happening slowly, but yes, there are issues. And once the central laws are made simpler, more streamlined and decriminalized, many of the acts are being decriminalized, I think it will start that virtuous cycle where states will also follow suit, if not in words, but at least in the spirit. अभी क्या है, Pharmacy Act में ये है, so कुछ भी हुआ उसको जाके जेल में डाल दो. I mean, this type of a thought process, hopefully, with this spurt of decriminalization that is going on and the simplification of laws, that outlook will change, and the states and even the bodies lower than the states will realize that the purpose of this is not to put someone in jail, but to look at the fact or ensure that the activity doesn't happen. I think this is what needs to be done, and it's an evolving process, but it's happening.
Absolutely. But it's quite amazing to see that when we went to NITI and said that, look, we have so many problems which are spanning so many industries. In so many ways, they are acting as a one-window bottleneck clearance, across multiple industries. So the opportunity here is large because we have some few hundred in the document, and we've already only picked up right now 15 or 20. But if we continuously stay at this, I think we can really solve a lot of these issues over the next few years to come. But one of the recommendations that was in the report was around self-certification. Today, obviously, the government of India cannot have the bandwidth to go and enforce laws and rules on the ground in every small town and location of the country. So does self-certification become a real option?
It is very much a real option. You see, how it is becoming an option, I'll tell you. In many cases, as on date, the rule is that you need to have what you call a permission. What the HLC and the committee is trying to look at, that many of these, you need not wait for a permission. Suppose you have built a hospital and you have to, so you have to just notify. So what we are trying to say is that, instead of seeking and waiting for a permission, you have to notify. Then of course, if it is your clinic or something, the authorities always have the right to come and inspect. But you don't have to wait for a permission. You give a notification, you self-declare that, this is what we are doing, please be aware. And then it will be up to the authorities whenever they want to come, and if they want to inspect, they are free to do that. So these are the types of things. This is also a nature of self-certification. We are trying to bring in, the HLC is thinking on those lines, and these are being done not only for the health sector, for many other sectors also.
One of the things that came up in the panel earlier was about somebody who's running ambulances, said how today there is no regulation that requires them to run ambulances. And as long as they run one ambulance, they can run as many as they want for like one day. And how therefore, in the hyper-competitive spirit of India, you have all kinds of players, right? You'll have players who don't have even basic paramedics. You have players who are not doing, the minimum standards because it's not defined. It's the same unfortunate reality in our diagnostics world. My colleagues are all sitting here, right? So part of it is unblocking regulation, but part of it may be actually in clarifying and creating regulation. What is the road to that journey so that you're able to uplift the whole quality of the whole industry?
Yeah. So I think, I heard from the last gathering here only, someone said that the medical industry is in a very peculiar state. Some part of it is over-regulated, whereas the other parts are not regulated. So this is an issue, and this is of course not being immediately dealt through the HLC, because this is a much bigger issue of the health sector per se. So that also we are aware, and under Dr. Paul's guidance, and of course with the in consultation with the Health Ministry, we are looking at that. And I mean, I think no one of us can deny that there is regulation required in many areas in health, in terms of quality, pricing, and also in terms of how things are happening, process. So I think this is again something which is evolving, but right now, I acknowledge there is an issue, but right now I don't think we have immediately solutions on ground, but we are looking into it.
So one of the things that came out in the report, which was actually very scary, that 25 to 30% of compliances change every year, right? Which is quite insane for all of us here as leaders to think of. And that Pan-India Healthcare Organization can face over 29,000 compliance requirements annually, including 1,400 licenses and approvals. I mean, some of these numbers are just staggering, right? And I mean, based on this, probably nobody sitting here can be compliant at any point of time. So, this is obviously the reality of situations on the ground today. And because of this, sometimes organizations get stuck in all kinds of operational challenges, because your board is pushing you to be compliant, but you don't always have clarity. Guys on the street sometimes, who are at the district level, at the state level, are using this as an opportunity because things are grey. So how should private organizations at this point navigate this till we get to a space that things are more sorted?
So I think again here what the HLCs are doing, the recommendations that are coming will go a big way, because again, as I said, in many cases restrictions or rules and regulations were input based. So we are trying to remove, the HLC is trying to remove those and make them outcome based. I think that itself will be a very big boon to the industry. Many of the things where you had to say 30 feet or 30 and a half feet, those things will go. And you will have a broad, and once you make it outcome based, the scope of misinterpretation or interpreting in a different way will come down drastically. So that will also bring in some sort of, I'm not saying 100% uniformity, but a lot of uniformity among the states also. So this process of, facing each rule in a different way in every state or in most of the states will to a large extent be removed. Is that what I think? And of course, beyond that, we are working towards it. There are many other issues, so we will be taking it up. But I think this in itself will be a lot, bring in a lot of relief to the industry.
No, but really, we really appreciate the energy and time that's actually going into supporting the industry on this, because it really motivates all of us that if we are stuck with issues, we have some place to go, which unfortunately was not always the case earlier. But is there anything else you would like to add that I've not asked?
So, I mean, in the budget, as you know, Secretary would have mentioned, and then Dr. Paul said, I think one area is these medical hubs. I think others are medical, but this medical, mostly medical in nature, the allied healthcare and all. Medical hubs, I think, is an area where, the private and the public sector needs to work really in tandem. First thing is, this was a concept which has been there, but specifically the word medical hub and the report that we did with FICCI was actually the brainchild of our earlier CEO, Mr. Subramanian. And there was a specific, idea in mind, and he kept on saying that, this medical hub is not going to be a cluster of hospitals. It is not going to be a cluster of, health clinics or something like that. It has to be a very, very organic thing which has a life in it, and it should be integrated and integrable in a larger plan, because NITI is also working on the city development plans. So it should be done in such a way that it should be a self-sustaining structure. You know, it's very easy to say these things, but when you actually design, you have to be very, very careful. So that is something where I think even I would say today, you know, we don't have a full idea, and how it looks will also vary from states to states. We are trying to come out with a policy as to how to choose who to give those. So I think in that we, like others, here we require a lot of cooperation with the private sector, just to give it the right push and the right feel that it is meant for. So I think this is an area where we would seek your cooperation, and I'm sure the ministry would be reaching out to you. We already had the webinars where a lot of things were discussed. But that is something I think it should be really made financially viable, because it has huge potential for the country, not only in health, but in the economic field also. Thank you.
Thank you. And just a request to all the operators sitting in this audience today, please do go through the compliance report. And if you find that in your industry or in your business, some of the challenges that you're facing have not been picked up in that report, I'm sure we'll go through multiple versions of this. Please give your inputs back to the Secretariat, and we'll be happy to take it forward. But thank you so much. Really appreciate it.
Thank you. It was a pleasure.
Thank you for the work.
Thank you very much indeed, sir. Thank you, ma'am. I would now request Ms. Amira Shah to kindly do the honors of presenting a token of gratitude to our special guest, Sri Rajiv Kumar Singh. Thank you, sir, for all those insightful perspectives on the future of healthcare regulation in India. Thank you very much indeed. May I request Ms. Amira Shah to kindly stay back with us on the dais as we welcome on stage our guest of honor, Sri Manoj Joshi, Secretary, Department of Pharmaceuticals, Government of India. Sri Manoj Joshi is a senior Indian Administrative Service officer who began his career in 1989. Over the years, he has served in several important roles in both the Government of Kerala and the Government of India. Prior to his current role, he served as the Secretary to the Government of India in the Ministry of Housing and Urban Affairs and the Department of Land Resources. I would request ma'am to kindly welcome sir with the floral bouquet. Sri Joshi ji has been instrumental in strengthening India's pharmaceutical ecosystem and promoting the country's position as the pharmacy of the world. May I now request our guest of honor, Sri Manoj Joshi ji, to kindly deliver his address. Let's once again put our hands together to welcome sir.
Ms. Amira Shah, friends, you had since morning a lot of discussion on different aspects of regulation. We have I think a unique problem in India in terms of regulation. We have a lot of regulations and we don't implement them. Very complicated. I think if someone from outside India comes and looks at our health sector regulations, it's very perplexing. I don't think they can really understand that we have very complicated regulations, but when it comes to actual examination and testing and all, we do very poorly. And I think medtech is one sector which really suffers from that. Mr. Baid was just now telling me, I think the biggest problem for Indian manufacturers of medtech is how do they sell their product. We find it all over. We look at it in a PRIP or any of the government schemes. We find large number of people have ideas. They are able to develop products also. I keep meeting people who have developed various products or reagents or diagnostic kits or equipment and they want to sell and they don't know how to sell it. Very innovative products. You would wonder when you look at in a PHC or in a field setup, these products would do very well. But I think neither private sector nor government are too willing to buy from any of these startups or small producers. I think, in my view, I think lack of or poor regulation is, I think, the biggest reason. So medtech doesn't really suffer from, I think we have over-regulation and probably a slower regulation in discovery side in pharma. But when it comes to older drugs and medtech, I think we have very little regulation. And the industry, in my view, suffers because of that. When you sit in a hospital or in a state government, whether private or government, and you are going to procure some equipment or medicines, you are not sure of quality of the people who participate in tenders, or who, in a case of private sector, you come and try to sell your products. They are not into a business of detailed testing. So you can argue, Mr. Vaidya was arguing that why don't the hospitals check the quality, or why doesn't government check the quality when they are procuring? They are not into the quality business. Their procurement in any case is getting delayed. Something they should buy in 2 months, 3 months time, it takes 2 years or 1 year to procure. And they don't know how to test the equipment, they don't know the methodologies, they don't know, they are not used to of it. So I think the next thing they do is just remove all the small suppliers, all the new suppliers, to the extent possible, whoever has not taken CE certification or some other certification, remove all of them, so that only few people are left and they are able to buy the equipment. And that's not just by the government sector, private sector, hospitals also keep doing that. So making goods which are not very advanced, like we are not talking about linear accelerators and MRIs, but lower down the stuff, it's not very difficult to produce it. Yeah, it's difficult to produce every part of every component. You need to procure it from India or abroad. You can get design also, but selling that in India is something that's very, very difficult, and I think we need to improve our regulation to enable people to do that. The regulation would benefit, a stricter, tighter regulation would benefit Indian companies, Indian small companies, because then the quality assurance would be there. And probably the US FDA is not really the right model for us. We would need to involve a lot of certification agencies, private agencies, because even if we try to build capacity in government, regulator, it would take many years. And probably 5-10 years, or I don't know how much other countries, those which we call as a regulated market, their regulators, how long they took, I don't know. But it's a long journey from where we are. And I think so, evolution of a model where we involve certification agencies in regulation is, I think, very, very important, be it the diagnostic kits or equipment, probably even in pharmaceutical products. I think till we really develop a capacity. So we need to develop the right model as to what would suit us, considering the way we work in our government, what exactly would suit us, and a much more tighter regulation, much more testing after you make the product, and reliability of that testing, so that procuring agencies could procure it without thinking too much about whether the product would work or not. I've seen hospitals, government hospitals, where doctors say, नहीं हमारी मशीन तो अच्छी नहीं है, तो ऐसे वो मेक इन इंडिया में खरीदी हुई है, जेम पे खरीदी हुई है, आप बाहर जाके टेस्ट करा लीजिए. Now that speaks very poorly of our regulation, and we need to address it if we want Indian suppliers to do that. We are willing in government to provide a lot of grant now to industry to do their prototype development, do their testing, do their, in case of pharmaceuticals, all the clinical trials. We are getting a lot of proposals, but the only concern I have is probably a partnership between larger companies and smaller startups is required, because none of these startups, even if our regulation improves quite a lot, have the capacity to market their products. So I think there are a lot of innovations happening around, but they need to sell their products. Whether they are developing reagents and all, I think it's difficult to market the products, even when the quality is pretty good and our certification system regulation improves. Other thing which I wanted to talk about is, a few days back, with Dr. V.K. Paul and ICMR, we were having a discussion in one of the meetings where he was saying that there are large number of India-specific diagnostic issues or equipment or kits which we have not been identified. We have not been able to discover or produce in large scale for different diseases like dengue and all type of diseases. And what do we do about it? So we had a discussion as to between health department and ICMR, if they prepare a list of 10 or 20 such tests or equipment which we require or a delivery method which we require, we could put it in the PRIP scheme as something, a separate bucket, and invite Indian companies to, we'll give this much of grant or whatever grant you want, we can give. You come up and produce that product, do the trials and testing, and then you would be able to market it. It was an interesting idea because we have never done that. We keep saying these type of tests are not available in India, but we don't really spend, and we are now giving a lot of grants for research in India. We do take a bit of a time to process all the applications. In case of PRIP, we had received applications in November. After 4 or 5 months, now we started giving grants. We have done it for 10 companies, 10 or 12 companies, and I hope in next 3 or 4 months we would be able to finish more than half the applications. But yes, this is one complaint one keeps hearing about the government grant giving, is it takes almost a year or 2 3 years for a scheme to fructify after announcement, and another 1 year for processing the applications, and another 1 year before the money comes to their account. So we are trying to address that issue, and we would welcome any other proposals coming from the industry. Other area which is quite interesting developments happening is what was announced in this year's budget about Biopharma Shakti Mission. And there are 6 or 7 areas we are working in that. The first one is almost similar to PRIP model. We would like to give grants for the entire discovery to clinical trial phase. Let's say 35–40% grant we give. And what we got feedback from industry is about, I think 100 crore cap probably is adequate for discovery side clinical trial. If industry needs more, probably we can increase that. So one is a PRIP model, both focused on discovery side, as well as development of medical equipment, devices which can be used in biopharma, biological area. Even we find all the insulin pens are imported, different products, different delivery methods, they are imported. So we look forward to providing discovery and prototype development testing grants for that. So that's one phase on the supporting research. Following, I think, whatever we have done in PRIP, we would like to do a similar thing, but focused on biopharma. The second bucket we want to focus is the large-scale production of biosimilars. Probably a plant nowadays costs almost 500 crore rupees. If it's a three-line biosimilar manufacturing plant. Most of the equipment comes imported, except for some drums. Most of the media comes imported, or the bags or reagents or all the chemicals, everything comes imported in India. So the entire supply chain, we would like to provide a grant-based support of say 30% grant or something, 20%, 30%, I think someone was saying 40% in industry interactions, but we would like to provide grant for the entire value chain of biosimilars, where India people have started producing, not too many, about 5-7 people are doing it at a larger scale, but I think we need to bring our costs down, more manufacturing. At present, since if you are going to import everything, from all chemicals to bags to all consumables and all entire plant, the cost is going to be high. So I think we need to indigenize things in that, and we are willing to provide support for that. The third area in biopharma which we are interested in providing support is fermentation drugs. We done one round with the PLI for bulk drugs, had some successes, we learned our lessons, and we want to provide more support for fermentation-based pharmaceuticals in that sphere. There are a lot of Indian companies which are interested, so it has to be a combination of government providing grant, some import restrictions, I think some fast tracking of regulatory approvals so that Indian companies are able to shift from whatever they are importing to whatever gets produced in India. So the entire value chain of fermentation-based drugs, we would like to provide support in biopharma mission. The other area which speech talked about was clinical trial sites. We don't have too many clinical trials in India. I think they were growing very fast, and then the civil society and I think came back saying it's not being done properly. I think the patients are being taken for granted, and then we applied pretty tight regulations. Our regulatory approvals do get delayed there. So phase 3 clinical trials, I think big pharma companies are doing. Indian companies, the entire discovery phase trials they are doing, but that number is very small. I think about 200, 250 phase 3 trials take place in Indian hospitals. And so there is a lot of regulatory delay in that. And the data issues or SOP issues are there. So along with ICMR and I think the companies who are doing the trials and the hospitals, we would like to work on that, provide training and some of the equipment or other support, provide accreditation by ICMR and development of SOPs, publication of SOPs, but providing hand-holding support is what most of the hospitals require, both government and private. So that's another area we look forward to improve the clinical trial site systems in India as part of biopharma mission. Other area which we had announced was, FM had announced, was about improvement in NIPERS and their focus on biopharma education. That's one area we have not really done well till now. India has been known for being traditionally very strong in chemistry, but biology is something which we have not really taught so much. We need to improve that. So we were thinking of focusing on few NIPERs and developing with the private sector few pilot plants which can work as an incubation center. We would provide the funding and partner with the private sector say CDMOs or different players, they could set up the small plants and operate them on a revenue share or a profit share basis with us. They would run it on the way they want and provide service to the private sector in making materials for different aspects of biopharma. That we would like to run on a commercial basis, and the NIPER staff and students and faculty could get trained and work along with them in those plants. So we want to shift a government education model a bit by involving private sector, because we do realize in NIPERs we have done a lot of infrastructure development, buying a lot of equipment, but they are not really used by the private sector. So, and that's true not just the NIPERs, I think the entire governmental scientific setup. The interaction between industry and academia or research institutions is very little. It's interesting to hear what industry says on that. They find that there is no accountability, there are a lot of delays, and the research institution would keep doing what they want to do and not what the industry wants to do, even when industry is funding it. That's the industry side complaint. The academia side complaint is that industry wants very specific results. There is a system, it has to work, and they don't have faith, and they don't interact. They don't even come with the funding. Most of the time it is the government funding on which research institutions work, and the private sector never comes really with the funding. Once in a while some companies try, but so this partnership doesn't really exist in India. Compared to what we see in US and other countries, I think one reason why we are not doing well in some of the high-tech areas is the lack of that partnership. So I think the more bringing in private sector to run government institutions systems probably is a way out. We will try that in biopharma mission, along with the large number of NIPERs and other institutions providing biotechnology or biopharma education courses. These are some of the areas we would like to work on a biopharma mission. But we are, I think from next week onwards, we are doing a large round of consultation with industry to hear what do they want. Because I think our experience in last few years of PLI and others is we listen to industry a bit, then devise a government scheme. Then industry comes back and says, no, this scheme is, government scheme is not very practical. So then we go back and to the drawing board and revise it. And PRIP, we have done that. So in the biopharma mission, we would like to change that and do a far more industry consultation before we bring the scheme. One more area I wanted to talk about is probably since this is one of the few forums in which hospitals are there, there has been thinking about and talking about trade margin rationalization in pharmaceutical areas. I think between trade margin rationalization or price control, probably addressing malpractices in the system is much better than doing a price control. But I think one of the biggest players who would get affected by if we do fixed trade margins, let's say 30% or something, in say anti-cancer drugs, would be the hospitals. We have not really heard from hospitals till now. We keep hearing from OPPI, IPA, IDMA, and different pharmaceutical players. Retailers, difficult to listen to them. There are too many of them. Not easy to do a dialogue with them. But hospitals, we have not done the dialogue. We would like to hear the views of the hospitals also, this area. And I suppose number of hospitals would be a member of NATHEALTH. So it's a good organization, NATHEALTH. In a way, you bring entire supply ecosystem. That's one part of the ecosystem we have not really interacted, and we would like to hear their viewpoint on this entire issue of trade margin rationalization. So if NATHEALTH could organize that, I think that would be good, because without hearing them doing something like that is not very good. One more area I think I was told by Mr. Baid was that the venture funding and industry is also part of NATHEALTH. That area again is biopharma mission. We want to work with the venture funding industry so that the larger amount of funds could go to startups in biopharma area. And that we can do actually in other than biopharma areas, also in entire pharmaceutical, medtech area or diagnostic area. We can do that. So if we are doing a one round of discussion next week on with private equity and venture funding. But if NATHEALTH can bring together all the private venture funding companies or funds who focus on healthcare area and biopharma area, biological area, may not be doing biological alone. The entire healthcare area, they must be doing it. So that would be quite useful, and we would like that ecosystem to develop further in India, and we would like to co-fund these type of investments or provide funding to these venture funds so that there is a larger kitty available to startups. I think I would stop here. Today, I think I generally don't like giving speeches, but prefer listening to industry. Today, that opportunity is not there. But yeah, my office is welcome. Any of you want to convey your views and explain the industry's perspective to us, so you are always welcome to come. Thank you.
Thank you very much indeed, sir. May I invite Ms. Amira Shah to kindly do the honors of presenting a memento as a token of our gratitude and appreciation to our guest of honor, Shri Manoj Toshili. And let's put our hands together to thank sir for his insightful address, for sharing the government's perspective on strengthening India's pharmaceutical sector and the healthcare ecosystem. Thank you, ma'am, for doing the honors. So, ladies and gentlemen, with that, we now move to the next segment of the session, a panel discussion on unlocking healthcare growth, deregulation and reforms to catalyze private capital. Thank you once again, sir, for gracing this occasion and the insightful special address we had from you. So, ladies and gentlemen, moving ahead with the panel discussion, may I invite our distinguished session moderator, Mr. Piyush Doshi, operating partner at the Convergence Foundation, an organization committed to driving impactful policy governance and reforms. Mr. Doshi brings over 25 years of experience in consulting, private equity, and strategy, having previously worked with organizations such as PwC Strategy and Faring Capital, Booz Allen, and BCG. Let's put our hands together to welcome sir. Also have the privilege of inviting our eminent panelists. I invite Mr. Raghavendra Rao, VS, Chief Operating Officer, Distribution Wipro, GE Healthcare South Asia, who is a seasoned healthcare technology leader with over 2.5 decades of experience in building and scaling commercial and operational ecosystem. I invite Mr. Mohit Khullar, Managing Director and Leader, Corporate Finance India, Alvarez and Marcel, who has over 21 years of experience in private equity mergers and acquisitions and structural finance transaction. I invite Dr. Rajiv Yaravdekar, Provost, Faculty of Medical and Health Sciences, Symbiosis International, Deemed University, who is a distinguished medical academic and healthcare policy expert. And I invite Mr. Abhishek Kapoor, Chief Executive Officer, Regency Health, who is leading the growth of one of Uttar Pradesh's largest hospital networks, overseeing multiple healthcare facilities across the state. And ladies and gentlemen, may I now hand over to our session chair and moderator, Mr. Piyush Doshi, to carry forward the proceedings, beginning with his presentation on deregulation in the healthcare sector, which is an important topic in the context of enabling reforms and improving the efficiency of healthcare delivery in India. And ladies and gentlemen, especially I would request Mr. Doshi, as we are running behind schedule, I would request you to kindly keep an eye on the monitor in front of you. Over to you.
Thank you very much. I had prepared a 1-hour presentation. That's the bad news. Good news is that I'll just use it in very quick 3 to 4 minutes to set the context so that we can hear from our esteemed guests on the panel today. I think we all know the importance of reforms. We talk about it. We have heard this morning why reforms are needed. Here is just some data which highlights it on the key parameters like hospital beds, maternal mortality rate, and physicians per 1,000 people. We have a long way to go in terms of catching up with the world and our own aspirations. So really, this is the thing I wanted to say in terms of context setting. Regulation is needed, but it is a double-edged sword. The cost of regulation on one side, which includes the high cost of setting up, cost of operating, impact in terms of reduced competition and affordable healthcare services. We have to weigh all of that against the benefit of regulation, potentially in terms of setting up a level playing field and a minimum level of quality which the population deserves. So where should we be on this spectrum, and how do we achieve balance is the question which we will be exploring. I will skip this. We all know how deregulation or ease of doing business is important for economy to progress. When the panel explores this, I just wanted them to think about 3 areas of regulation which impact a business. One is just what is called the stroke of pen thing, the policies which have a material impact on business. For example, when you need an NOC, when you have a certain height restriction, these are the kind of things which can be changed through stroke of pen. And what are those policies today which are hindering our businesses? Second thing is processes. How do you get the required permissions? You know, we have had single window systems, we have had very mixed views around those, so how do we fix those? But the third and most important thing often is just the culture. You know, once the system wants you to get the permissions and operate, then they always find a way, and if they want to stop you, there is always a way as well. So how do we fix the culture which is more supportive, which acts like a coach, not a referee? And this is the final thing I want to leave with, and then we will dive into the panel. Regulation is not costly, as we know. We tried to put some number to it. Now, not every business will face entirety of this cost, but let's say if a business were to go right from the beginning to the end, medical education, let's start with that. Our medical education can get expensive because there are restrictions on what should be the minimum land size, what should be the faculty ratio, what kind of infrastructure is needed. So that makes the cost of producing a doctor high, and that increases the cost of the medical professional. Then there is the hospital infrastructure itself. The land requirement, the FAR, what is the allowable FAR, and hence the amount of investment you have to set up to actually build a hospital is high simply because of the extensive regulation. Third is just the licensing and approval delay, which adds to the working capital cost. That can add another 6%. We've done detailed calculation behind it. Fourth is just the compliance around things like diagnostic, the PCP&DD Act, the paperwork you have to fill in, the delayed courses and licenses. That could add another 5%. Fifth is the administrative compliance. you have to have, if you have 3 pharmacies in a hospital, you need separate licenses, you have to fill separate paperwork, blood bank, etc., etc. So all of that cost adds up. And finally, the workforce rigidity, the norms around, for example, one technician can only operate one lab, etc. So when you add all of it up, a patient could end up paying 40 to 45% more for regulation. And hence, it is very important for us to discuss. Are we going overboard, or are we actually getting the worst of both worlds? Somebody said that in India, everything is possible, nothing is permitted. So we need to be in an environment where we do things which are essential seamlessly, where we trust our businesses. People are not proven out, deemed to be guilty right at the beginning. First, people should be treated like they're acting in good faith, they're innocent, and if somebody is caught doing something wrong, then the punishment should be exemplary, rather than the process becoming a punishment. That's all I wanted to set as the groundwork on this very important question of regulation. We can move away from the presentation now and hear from the panelists. Can you just turn off the presentation and just go to the panel? Or we can leave it? That's fine, yeah. All right. I just want to start with an that's for the presentation. Thank you very much. Okay. All right, fine. Why don't we start with one question for every panelist? Because we are very lucky to have panelists from different aspects of the healthcare ecosystem, from hospital to actually medical devices. I think you have all experienced the impact of regulation in your own businesses in different way. First question, each one of you maybe take 2 to 3 minutes to say, what are the top 1 or 2 regulations that you have seen which adversely impacted, and then if you have any recommendation to simplify it, rationalize it. Maybe I can start with you, with Dr. Mr. Ra.
So, morning. So, little bit of a background before we, get to understanding, what's the challenge that we are facing. I think predominantly we are going to soon be the 3rd largest economy, right? Our India market size would move from $12 billion to close to about $13 billion. The share of our market in the global contribution is less than 2%, slated to move all the way to about 10 to 12% shortly. The PLI-backed investments have led to a business generation of close to about $1.5 billion of sales and about $700 million of exports. So if you look at all of this, there is a decent amount of capability that is already built. There is evidence of growth. But what is really challenging all of us is the trust advantage that we all share. In many ways, the products that are made in US or in European Union have a global acceptance automatically. But when you look at the Indian certifications, they do not carry the same weight as some of these products do. So in many ways, that to me is the biggest challenge. How strong is our certification to ensure competitiveness for our products, both for scaling up the demand in India as well as for export, is in many ways the cornerstone of what the regulation should solve for. The other most important thing is the fragmented nature and the multiple regulations that all stakeholders have to deal with. In many ways, this is spread all across the state government, central, export regimes, and at each level, as you have pointed out rightly, adds a great deal of cost, but also increases the time to market. Both erode competitiveness significantly. In our view, as one digital single window of clearance, which integrates all the global compliances and the national compliances, like CDSCO, state, central, export regimes, helping stakeholders do something like uploading of all the files one shot, one time, in many ways would solve this. More than anything else, it will also bring in a great deal of consistency to the national approval process and the audit process. That to me probably are two important things that we have to build on, more than really going specifically into what policies would really impact.
Thank you, Mohit. I would come to you next. The same question. In your opinion, let's just stick to one. What is one important regulation that you have seen which we need to change?
I think India needs to ease out regulation related to medical education. Medical education. We are seeing severe shortage of clinicians in India, paramedical staff in India. We are seeing the capitalist world willing to invest, create larger infra, but not having the right talent to serve the patients. While the number of doctor seats have increased a lot, we now have close to 1.3 lakh medical seats, I'm told. But at the current phase, India will take 30 years to fulfill the gap that exists today.
Any particular aspects of medical education regulation? One or two things?
And public-private partnership, easing out and formalizing the better evaluation criteria. We have 3 different regulators which govern Indian medical examinations. And there is always a synchronization challenge in that. But being able to set up better medical colleges at a faster pace, increasing the number of seats, is first criteria in my view.
Dr. Rajiv,
Yeah.
same question.
Well, I would like to echo what Mohit said just now. As a medico academician representing one of the largest private sector universities in India, Symbiosis International University, and having been on the board of the governors of the then Medical Council of India, I would like to allude to what Mr. Mohit said, that A, infrastructure norms, 2, equipment norms, and third one is the manpower recruitment norms. All 3 are important. You require norms, you require regulations, otherwise the quality of medical nursing, healthcare, and allied healthcare workforce, NCHP Act being introduced is a welcome sign. But we need to also understand there has to be an ease of doing business, EADB, by way of not relaxation of the norms, but by taking a considered view, which are culturally specific, which are geographically specific. And when you talk of manpower, and if I were to give a prototype example of the TEQ, Teachers Educational Qualifications, which the NMC prescribes, there's a lot of gaps between who can be appointed and what would be the eligibility qualifications and the career progression. Can we look at some flexibility of the career progression to an outstanding person, and what are the parameters? We can always debate on that. And as Mr. Mohit rightly said, the availability of this faculty to be a clinician. Please don't forget that the teacher in a medical school or in a teaching hospital attached to a medical college fulfills a dual role of being a teacher as well as a clinician. And the adaptability of this teacher to learn newer trends and at the same time adopt newer pedagogies of teaching, classical example being simulation, leaves a lot to be desired. I'll stop at this for brevity of time.
All right. Mr. Abhishek,
Hi.
your views.
So I think I'll take it from where Mohit left. I think Mohit was talking about having more doctors and more nurses because people are building institutions and buildings can come up, but where are the people? But I think we need to take a step back from there as well. And a lot of hospital operators are sitting over here. The quality of manpower that is coming out, I think that is where the most regulation is actually needed. When it comes to doctors, most of the hospitals are eyeing for the top 5, 7, 8 government medical colleges because the quality is still great and you can pick a doctor from there and put it on floor and you don't have to worry about it. The sad part is that a lot of private medical colleges that are operating in the country, sometimes we are scared that who's going to take care of us when we actually grow up. And same thing with nursing, right? Most of the nurses that are coming out, most hospital operators are running their own nurse finishing schools, diploma schools, because when they employ these nurses, it takes at least 2 to 3 months of training, everything extra before you can even put them on floor. So I think more nurses, yes, doctors, yes, but I think the quality very, very important. And that's where the regulation is needed, that, you know, who's regulating what's coming out the output. I think we've spoken about licenses, we've spoken about infra laws. There are multiple things around it, but, you know, as a hospital operator, I can just give you a very, very recent example. To start a hospital, you need to take so many sequential licenses, and a very, very recent cost to us, just the time, because they all after the completion of the building, the cost was pegged somewhere around 8 to 9 crore rupees, per setup. So that's the kind of cost.
How long does it take to get all the licenses in your experience, recent experience?
It can take any number of days. The bigger the hospital, the bigger the regulation, the bigger the requirements.
So any specific, like if you were to address one or two things, what would be your top recommendation?
So I think if a hospital is ready today, it will take you at least 6 to 8 months to get at least the licenses in place. So when hospital operators, they build the hospital in 3 years, but they never budget. Most new hospital operators, they don't budget. It will take 6 to 8 months to get the licenses in place, and the costs associated with it, because so a lot of people are taking hospitals on rents, buildings on rent, doctors have come, salaries are being paid, but those licenses, you can just keep waiting for them.
So if I were to speak on your behalf, because we have been researching it, I guess what we want is a system where licenses can be given based on trust, that I am self-certifying that I will follow the law of the land, I will not violate anything, and you can get going, and then at any time inspection can happen. If you are putting patient health at risk, then action can be taken. Rather than, until a business has started, what is it that somebody can check for 6 months, frankly, right? So I guess we need to consolidate our recommendation.
Thank you. So we've just been informed that we need to close the session.
Okay, I guess we will finally out of time. I think we don't have time, as I'm told, for further comments. So.
So regulatory approvals can be broadly put into two buckets. One is the regulatory approvals or the permissions for the service sector undertaking for the hospital, and then for the medical education, the nursing education, or the allied healthcare professions. And in each of them, you've got, as I said, infrastructure, equipment, manpower, and other regulatory approvals first, and the subsequent renewals. And some of the regulatory approvals, they are necessary considering the social demographic implications, such as the PCP entity. But the deterrents for a small error are draconian.
It's crazy.
That's too much.
Also, I think the brunt of all the regulation comes to the organized players and not to the unorganized players, which is literally 5% of the market right now.
Thank you very much indeed, sir. May I request for a group photograph of the panel. Ladies and gentlemen, requesting everyone to kindly remain seated. In the interest of time, we're extremely sorry we had to cut short the proceedings of the discussions of this panel, and we are straight away moving towards the proceedings of the next panel. We'll just request not even a minute to set up the top table for the next panel. Ladies and gentlemen, I would like to the next session is on healthcare innovations, digital and AI, from R&D to scale innovation, and matters as a scalable health system partners, Gate Foundation. This important conversation, as we said, is supported by a health systems partner, the Gates Foundation. Which is supported by the health systems partner, the Gates Foundation. I would like to invite on stage our eminent dignitaries, Session Chair Dr. Sangeeta Reddy, President-elect NATHEALTH, Dr. Ashutosh Raghuvanshi, past President NATHEALTH and Managing Director and Chief Executive Officer Fortis Healthcare Limited, and our very special guest for this session, Ms. Debjani Ghosh, Distinguished Fellow, Niti Aayog, Government of India. And ladies and gentlemen, For the opening remarks and setting the context of the session, may I invite Dr. Sangeeta Reddy. Over to you, ma'am.
So, ladies and gentlemen, I'm standing between you, lunch, and Devjani, and Dr. Ashutosh. I'm going to be really brief. You've heard me this morning. I'm not going to repeat. You understand the imperative. You appreciate the situation we're in. But also, I believe all of us are inspired by the opportunity to use the tools of the new age to combine the various aspects existing in the ecosystem and build and create something new in terms of a paradigm shift in healthcare, in terms of a wellness focus, to build and create operational efficiency at a different scale, because we connect seamlessly, not just between government and private, but we connect seamlessly between insurer and the hospital. And the hospital is no longer just the hospital. It's the primary clinician, it's the nursing home, it's the hospital, it's home care, it's elder care, and all the way back in. And this is a seamless ecosystem. And the last point is, we appreciate the fact that if we get our data right, if we use this data for insights, we can create a flywheel of better care by enabling the ecosystem to be smarter. In this stage, in this context, with this fabulous audience and these lovely speakers, I hand over to Devjani.
Ladies and gentlemen, let's put our hands together to welcome our guest of honor, Ms. Devjani Ghosh, who is a distinguished fellow at NITI Aayog.
Thank you very much, Dr. Reddy, and good afternoon, everyone. It's such a pleasure to be here. So for those of you who don't know what I do, or who might, basically the work that I do in NITI Aayog, and it's a very new setup within government, it's to understand the patterns that are emerging out of the movements we're seeing in technology, various fields of technology, right? So it's really following the movements to understand the patterns, which will give you an understanding of the core sort of leverages that are driving these shifts, and therefore future casting where these tech shifts will go, what will be the next big tech shifts, and how will they impact India. So, I mean, there is no crystal ball, but it goes back to good old maths and statistics and data science, which is really about understanding pattern recognition and understanding patterns and what they tell you. And at this point in time, the patterns are going crazy. There is just so much happening geopolitically. And all of it is sort of interconnected with technology. It's just fascinating to see what's going on right now. And when you look at sort of declutter it a bit, take away the hype, take away all the noise, and you just start looking at what the patterns are telling you, there is sort of core truth that's emerging. You know, till now we used to call AI and other technologies the enabler of influence, enabler of power. What we are now seeing is the shift towards specifically AI becoming the central axis of power. It is no more the enabler. It is becoming the axis of power that is reshaping geopolitics, that's redefining economic competitiveness, and transforming how societies are functioning. And there's a very important underlying shift that is fueling this change from enabler to becoming axis of power. And that shift is, today when we talk about AI, we are not talking about just the technology or just, you know, the algorithms, the machine learning that goes into it. Today we are talking about integrated systems. So when we talk about AI or AI strategy, we are talking about energy. We are talking about data. We are talking about compute, talent, R&D, applications. All of this is now coming together. It's basically the convergence of science, industry, and market that is beginning to happen. And what that results in is very, very powerful multipliers of growth and national resilience. And when this happens, this is why the patterns are showing that technology today is becoming the axis of power. And when this happens, it fundamentally, once again, changes the rules of competition. For now, till now, we were competing on infrastructure. Who can build the best models? That was what the AI race was defined by. If you follow the money and you look at the investments that have gone into it, the AI race was pretty much defined by who can build the best infrastructure and how fast, right? But I do believe that too is changing. And if for those of you who were at the India AI Impact Summit, I think you would have sensed that change. You would have felt that change happening in the conversations. And the change is, what I think is emerging is that the winners in this new race, or the race going forward, not new, but the race going forward, will be those who can translate intelligence into economic-wide capability and national resilience the best and the fastest. So frontier capabilities will still matter, but on its own, alone, it's not going to be enough. And when you think of it in this context, I think healthcare becomes almost one of the most decisive sectors. Because ultimately, the most critical infrastructure any nation has is its human capital. And the strength of that human capital is defined by human capabilities. And a healthy population is it's the foundation of productivity, innovation, long-term economic growth, resilience, etc., etc. And I'm not a domain expert. I look at everything from a tech lens. But when I look at it from a technology lens, when I look at this sector, I see that the foundation is not as robust as we need it to be in order to drive the kind of growth we are thinking of. We have a healthcare system that needs to cater to nearly 1.4 billion people. But there are increasing structural constraints that we are facing. Delivery is fragmented. Data is in silos. Uneven access, especially between rural and urban. Rising burden of cost, and I think the last panel had great insights that they brought out, resulting in increasing cost of care. And at the same time, very interestingly, we are entering a phase where our lifespan is increasing. If I'm not wrong, I think the average lifespan is now 72 years or so. We've crossed 70 for sure.
Today on this platform, we declared a very important thing, that we are tracking healthy lifestyle.
Perfect. So that's the point. That's the point, right? Because if your lifespan is growing and your health span is not keeping pace with it, then you have a huge problem in hand, especially at a country which is slowly moving towards aging population. And I think that cost of a silver economy, which is not very healthy and which has a high disease burden, is going to be tremendous for India. So from a tech perspective, when I see, the challenge is, it's frankly a fantastic challenge that we have in front of us, which is how do we ensure that India's lifespan grows with a health span, with healthy growth? And I think this is the biggest role that AI can play in terms of improving capabilities, productivity, national resilience. Now think of AI. For AI to really provide the outcomes that we want from it, if the underlying architecture is fragmented, the outcomes will always be suboptimal. And AI will just amplify the fragmentation. That's the bigger worry. It will really amplify the fragmentation. So if data remains siloed, AI will be constrained. If workflows are broken, AI is going to be constrained, not going to deliver meaningful impact. And I think this is why we have to move beyond thinking of solutions and dashboards and all the different metrics that the numbers that we count when we look at AI success, to really measuring outcome in terms of what is this resulting in for each sector. And to do this, we have to pretty much re-engineer the system, re-engineer the tech system that is going to drive AI in healthcare. Now imagine a secure government national platform where anonymized consent-based health data from the entire ecosystem, hospitals, research labs, public programs, wearables, electronics, whatever have you, the entire ecosystem can come together as a unified national asset. Imagine the value of that. Technically, absolutely possible. I think the problems are more to do with mindsets, regulation, lack of understanding, etc. And if this vision has to come true, at its core is what we are calling, as we are building this vision out, we are calling health data universe, right? And around it is the entire ecosystem, the startups, the researchers, the healthcare workers, the industry, pretty much the entire ecosystem that is coming together that can use population intelligence for prevention, response, and pretty much reimagining the entire health ecosystem and its outcome. Now this kind of an infrastructure, again, from a technical perspective, is highly possible. On one side of it, you require a world-class data infrastructure that is based on standards of interoperability, open standards, privacy, consent framework, secure, scalable storage. I mean, these are the things that has to come together. And on the other hand, you have the analysis and applications and the development, so whether you're building models, diagnostics, it sort of all connects. But today the challenge is, it's not just absence of data, right? The data is there, but it's fragmented. The quality is severely lacking. The research that we are doing is not flowing into practice. Public data is not fully leveraged. So there are all these siloed problems, and that's why an integrated, robust health commons or health data commons, whatever you want to call it, is ultimately, I think, what India will have to think about, which is not just about bringing data together, but which is about re-engineering the entire health ecosystem, health tech ecosystem, that is bringing all the stakeholders together. And we have tremendous structural advantages to do this. We have the rails. If there's any country that has excelled in diffusion of AI or diffusion of technologies, it is India, and thanks to the DPI infrastructure that has already been built. I think structurally we have a huge advantage. We have the rails. Structurally, we also have a huge advantage where even a small difference can make a huge impact given the size of the problem that we deal with and the diversity that we deal with. And I think the third structural advantage we have is we are a digital native country, and I would say we are an AI native country. Everyone gets it, and no, we are not scared of it. We want to build it, and I think that makes that's a tremendous advantage to have. So I'll just end by saying that, the AI race, I know it's not a race, it's really a never-ending race, it's an infinite race that we are in. But in order for us to compete and to emerge a winner in this race, it is not about catching up. In fact, catching up will actually hurt us, it'll take us back. I think what we have to think about is how do we build a population scale AI plus system, integrated system, that will turn technology by bringing together all the different elements into measurable human and national outcome. And if we choose to lead I think healthcare has to be at the forefront of this transformation. Thank you very much.
Thank you, Jebdani. Most inspiring. I'm very happy to call upon Dr. Ashutosh Raghuvamshi. He's been a thought leader, and his gentle and subtle style speaks volumes all the time.
Thank you for the kind introduction, Sangeeta. I don't speak a lot. Yes, so I will take very little time, but it's a pleasure to be here. India's healthcare system sector today stands at a very crucial junction. You know, we have been recognized as a system which has very good clinical outcomes and processes, but now we are also recognized for the innovations which are happening in the technology field, both in terms of the research and innovation in digital health models and other things. But I think one of the most important point which Ms. Devjani made was that, you know, the data we have, but it is very fragmented. So technically a lot of things are possible, but practically hardly anything is happening. So the innovations which are happening in technology are not really getting translated into real care. And it is not having that kind of impact on the outcomes as it should have. Many of the startups and these innovations end up becoming just glorified search platforms or discovery platforms. But I was very heartened by some of the recent and on the other hand, the research environment, the basic research environment in India has lagged quite a bit. But there are some of the things which have happened recently. Two of the things which I would like to mention: Anusandhan National Research Foundation with 10,000 crores of budget, and Biopharma Shakti. These two areas, I think they are going to make a lot of difference. And as you heard from Mr. Joshi, that the government is very, very supportive of this, and what is very heartening to learn from what he said is that the government is willing to address the real questions and talk and partner with the industry. One of the weaknesses which has been there and which he also mentioned is that academia as well industry partnerships are almost non-existent. They just happen on a very episodic basis, and because of various factors, they don't really lead to any major outcomes. And that is a great weakness, and there has to be some kind of a sustained effort in that direction in order to get some good outcomes and implement these innovations and research into real life scenarios. And I think that's where the role of the providers come in, and the large healthcare networks can really help to bind these industry academic partnerships and form these kind of groups which can have these solutions go directly to the patients. But at the end, I would say that the goal of innovation and technology is not for its own sake. Unless it makes an impact on the patient outcome, it would be meaningless. Thank you.
Thank you very much indeed, sir. I would request Dr. Reddy to kindly do the honors of presenting a memento as a token of gratitude to our guest of honor, Ms. Devjani Ghosh, who is a distinguished fellow, Niti Aayog, Government of India. Thank you very much indeed. Thank you, Dr. Ashutosh Raghuvamshi, for the wonderful keynote address we had from you. I would request Dr. Sangeeta Reddy and Ms. Ghosh to kindly stay back with us on the stage as we move on with the proceedings of the panel discussion session. which will explore how innovation, digital technologies, and strategic investments can transform healthcare systems at scale. I would like to invite our eminent panelist, Dr. Shankar Prinja, Professor of Health Economics at Department of Community Medicine and School of Public Health, PGIMR. He is a leading expert in health policy and financing. I invite Mr. Rahul Guha, Managing Director and CEO of ThyroCare API Holdings, who is leading the expansion of one of India's largest diagnostic networks, now operating 31 laboratories and serving over 570 districts to more than 10,000 franchisee partners. I invite Mr. Atul Grover, Managing Director for India and South Asia, BD, that is Beckton Dickinson Company, with extensive experience in healthcare technology and medical devices. I invite Mr. Harish Iyer, Director Health R&D, Digital Innovative and AI, Gates Foundation. And ladies and gentlemen, moderating this important discussion is Mr. Suhail Vidani, Lead Digital and AI at the Gates Foundation, who works extensively on leveraging digital technologies and AI to strengthen health systems globally. And may I now request Mr. Suhail Vidani to kindly take over the proceedings for this engaging discussion. So ladies and gentlemen, before we go ahead with the proceedings of the panel discussion session and I hand over to Mr. Vidani, Dr. Reddy has a few slides which she would like to share with the August House.
I'm doing a slight change in program because this thing, and that is, I just wanted to show this to you. Debjani was so inspiring. She said, you know, let's bring all our data together into a data common, and there were many things we could do. I just wanted to share with you these two slides which show what can happen if we implement some level of AI. So, can I have my first slide, please? I'm good? Okay. So this is a list of licensable clinical AI that we have put into API calls. So anybody who wants to work with us, partner with us, or share, you have disease progression risk scores, you have image and signal management to look at clinical pathways, you have acute care augmented pathways. So if you're in an ICU and you want to pick up early signs of sepsis, we're finding sepsis 24 to 48 hours earlier because we put the AI on top of our system. Next slide. I'm going to go really fast because I know I'm grabbing time. These are BSI certified. This is the system that we started working on 6 years ago using 8 million records. The AI cardiovascular disease platform predicts cardiovascular events. We now have 3.5 million usages within our ecosystem and 6 external partners doing API calls. We're seeing an above 90% accuracy rate in the prediction of reoccurrence of cardiovascular problems or occurrence. This is a laparoscopic cholecystectomy patient, 39 years old, comes in, and then if they have a heart attack while they're on the theater table, your patients are going to be very unhappy. If you implement a cardiovascular risk scoring as a routine protocol for all eligible patients, you will save that life or save that embarrassment. Many, many other areas, but I just want to give you a broad overview of how you could look at this. High-risk group transformation. Here we've seen over 44% of high-risk individuals lowering their risk level. Medium risk, 96% of these either maintain or improve their status, and low-risk stability. Using the pillars of change and knowledge that we already have, using the methodology that most doctors are using in their clinical offices, but combining this into a platform ecosystem, that's the transformation. AI will enable us to get it right every time, all the time, irrespective of the location, the doctor, or the patient. That is the power, keeping the human in the loop. I'm not advocating AI replacing doctors, but I'm seriously advocating adoption of AI at every possible level. Sorry, I had to say this because after Debjani's inspiring thing, if you all want to know how do I go, what do I do next, There are applicable models. You don't have to work with us. There are lots of them out there. There are many freeware models. Have your team start studying existing AI models, experiment small, perfect your own internal pilots, and then scale across your organization. The value is really huge. Thank you.
Thank you very much indeed. And with that, now I hand over to our distinguished moderator, Mr. Suhail Vidani, Lead Digital and AI at the Gates Foundation, with a gentle request, sir, to kindly conclude the panel. We also have a presentation after the panel discussion by Mr. Harish Iyer. So together we have about 17 minutes to conclude this. Over to you, sir.
Thank you. I'll try to be as fast as possible. Good afternoon, everyone. I think we've been hearing since morning, and maybe some of you also yesterday, in terms of the momentum that India has been carrying, and especially in terms of the policy push, the AI work. Thank you for sharing just now, Dr. Sangeeta Reddy, and the private sector innovation. But for this panel, I just want to focus on very specific one question each, relevant to the work that you are responsible for or the mandate that you carry. And I will start with Ms. Devjani Ghosh, fully appreciative. I then have an opportunity to come back to you in case I can. So very clearly in terms of the significant public investments in R&D that we are seeing now, and we've heard some of it, what will determine whether these translate into scaled solutions? And you referred to the summit and also the great work in terms of pulling out the AI commons. Where do you see is the real challenge in terms of scaling up some of these things and the impact that we keep talking about? What more can be done here?
If you're going to talk R&D, then it's 17 minutes for the whole panel is totally not enough. But I mean, in very, very short, I'm just going to, I think India needs a complete, I talked about system re-engineering, right? I think we need a complete re-engineering of our R&D systems, our R&D mindset. We have to think about R&D, translational R&D. We have to prioritize translational R&D. We have to prioritize lab-to-market processes. Incentives have to be given for R&D that results in commercialization of whatever the research versus just converting into papers and insights. I think these are some fundamental changes. See, ultimately it boils down to how you incentivize the system, and it also boils down to how you fund the system. So if you're giving funds, especially to the institutes, etc., which significantly diminish risk-taking appetite, then you're not going to have translational work coming out of it. So I think there's some fundamental structural problems that we have today, which everyone is aware of, but which really has to get addressed.
Appreciate it. Thank you so much. Rahul, if I may come to you now. So the diagnostics is scaled remarkably in India, right? I mean, that's at least my view. What are the key lessons from a thyroid journey perspective that others in the healthcare innovation can learn from?
Sure. See, it's my belief that while diagnostics has scaled rapidly, it's not enough. It's actually far away from that. I was just looking at some information this morning. So 500 million people have an OTT app. Okay, less than 1/10 of that would have done a preventive health checkup. So when Dhurandhar 2, The Revenge comes out, most people will be able to buy it and watch it on their phone, but probably not be able to buy and book a preventive health checkup. You know, so that's the state of where we are, and it's generally in the backdrop of what I was reading. Almost 800 million Indians between the age of 16 and 62 are declared completely inactive. Completely inactive. So as in no exercise, nothing. Right? So I think there's a long way to go before, you know, we can say we've scaled this sector enough. I think just to give you one example of innovation, right? I think the vast majority of health checkups tell you, are you sick? Right? They don't tell you, are you trending sick? So what we've done is, in Janch, along with some of the work we've been able to build on AI models, is basically to say if you are a thyroid patient, if you are a heart patient, a combination of markers which not only a 0-1, but an analysis of that combination to say, are you trending sick? So yes, you have a heart issue, right? But are these markers indicating that something worse is going on in your body as a heart patient, right? And so that's some of the stuff I think on the innovation side we've been able to drive. And I keep that, preventive health checkup should not just say you are sick, but should also tell you, are you trending towards sickness? And that's one theme I'll leave with you.
No, thank you. And this is a great point for me to move to Dr. Shankar Pinja, because this is something you, from a health economic standpoint, you've been talking about for a very long time. And I also want to understand from an audience perspective, what does it mean when we talk about some of these incentives that are linked to the treatment and the whole prevention element that Rahul talked about, and the role of HTA in ensuring this gets delivered?
Sure, thanks. I think both the questions predominantly take us to the broader theme of how to enhance the efficiency of healthcare and how to drive value within the healthcare. We did see one of the important recommendations coming even in the opening report that was released on Swasth Bharat to Viksit Bharat, which was on incentivizing prevention and prevention-led healthcare. But I think that when you talk about prevention-led healthcare, there are probably about 4 different stakeholders who are important in this entire ecosystem, who are going to contribute and who have some individual roles and responsibilities. These include the government, these include the payers. And I differentiate between government and payer because government does perform the role of a payer also, but also functions as a financer and provider of healthcare also. And then we have the industry, and then we have the providers, and then finally the patients. Now within that, the government, of course, we heard the secretary talking about, and the honorable member health Niti Aayog also talking about expansion of primary healthcare through comprehensive primary healthcare services and the Ayushman Arogya Mandirs. But the payers, they also have a very significant role, and they have a significant role in 3 domains to incentivize prevention actually. The first is in the design of the scheme itself, whether it's Ayushman Bharat or whether it's voluntary private health insurance schemes. How do you design health benefit packages whereby there is, within the design of the scheme itself, there are packages specifically for prevention only. We currently have these schemes which are designed towards curative care. All packages are towards hospitalization services. A, do we incentivize primary care by inclusion of outpatient care? B, how do you incorporate preventive packages also? We also know that there is a committee that is currently under the chairmanship of the Honorable Member Health, Niti Aayog, which is looking at reforming the ESIS scheme, one of the largest social health insurance scheme in India, to incorporate the notion of prevention and how prevention can probably contribute to the overall cost savings within this kind of a insurance ecosystem. There is also the role of these payers in designing the payment systems so that it incentivizes prevention. And there are various ways to do that. We can't get into details of that, but reforming the provider payments is another big area through which prevention can be incentivized within the insurance-led healthcare service delivery. And the last is around how the payers can contribute to enhancing prevention. It's through monitoring. We looked at one of the indicators, and we're hearing this, one of the indicators called health-adjusted life expectancy since morning. We've been working with the National Health Authority to try and develop a monitoring framework where there can be a score like a preventable hospitalization. A preventable hospitalization is an indicator of that hospital episode that could have been prevented through better primary care, better preventive care. If that becomes an indicator of, that can actually, a higher preventable hospitalization rate in a district could become actually an indicator of poorer primary care provisioning in a way, if you put it that way. So that, I think, is the kind of monitoring arm of the payer through which you can enhance the prevention-led thing. So the industry also has a very strong role to play by coming up with these kind of technology applications that can enhance the outreach of prevention programs. And AI has a phenomenal role to play in that. Because one of the roles that I do see AI playing is not just improve the overall accuracy perhaps, but also the access that it can enhance, given the kind of geographical and financial barriers to accessing care that we have in large majority. And finally, coming to the point about health technology assessment. The last question that you posed, the second question that you posed to me. HTA, for those of you who may not be perhaps as well familiar, is a kind of an institutional norm that the government has created through which it is trying to enhance value within the healthcare service delivery. And what do we mean by that? Is there's a Secretariat of Health Technology Assessment within the Department of Health Research, which is trying to evaluate newer healthcare technologies, interventions, services, etc., on grounds of cost effectiveness. And interventions that are found to be really worth the value for money are the ones that are getting recommended to the government for taking up at scale in large public health programs or government supported insurance programs as well. So the point is that, and the opportunity for HTA, so how does the private sector come into picture in this, in engaging with the HTA? The nomination of topics that could be subjected for an assessment are things that are now open to the private sector also. And there are many other alternate mechanisms like MedTech Mitra, which has also been created through the ICMR and the NITI Aayog, which promotes innovation and which creates opportunities for developers of newer products and medical innovations to perhaps come within the broader healthcare market for scaling up. I'll stop here maybe in the interest of time. Thanks.
Thank you so much for sharing. And I have one quick follow-up request. How do people reach out to the HTA team?
Okay, so I think that there's a website of the Department of Health Research where you can Google for HTIN, Health Technology Assessment India. That's one option, and you can submit any topics and you can reach out. We also have a HTA Regional Resource Hub at PGH Chandigarh, so I'm more than happy to interact and have any conversation on that. The other is that the National Health Authority on its portal for the Ayushman Bharat PMJY also has an opportunity where you can submit topic nominations for inclusion within the health benefit package. Those topic nominations will also ultimately come to the HTIN for an assessment, and if found to be cost effective, those would be considered for inclusion within the PMJY scheme.
Thank you. Atul, I have to come to you. And this is obviously wearing the BD lens. So what will it take for India to move from being a large market to becoming a global hub for medtech, innovation and manufacturing both?
Thank you, Sohail, and thank you for the question. And I may not wear the BD hat here, but in this group, maybe I'm representing medtech, which of course has companies like BD, but of course there are other players. I think where I'm trying to structure the question is we have to first understand how medtech is different and what is unique there. And that will maybe give us some ideas about what to do there. So two unique things which work for medtech and how it is different as an industry are, one is the level of innovation, and the pace of innovation is very fast. So technology is evolving. Typically product life cycles are 3 to 5 years. Every 3 to 5 years a new innovation is coming up or advancement is happening. So it's a rapidly evolving, I'm talking global right now. So technology is still evolving, and that's where we need resilience coming in from there. Second, obviously, while it's not a diagnostics, because this is when these products have to be used on a patient, on a human life, that's where this is also an engineering aspect to it. So when we do the innovation, after that it is scalable and it is quality scalable. Right? So when we scale it up, maintaining the quality so every patient gets the same output, or the predictability of the outcome becomes important. These two things become critical for medtech as an industry, and that will define some of the challenges which are there as of now from it. Now, coming back to now India, where we have reached in India innovation is at this point, we have started with, let's say, a little bit of a lower end devices. That's where we have, our primary objective has been, even from government as well as industry, is to reduce the cost of medical devices, right? So get the technology and try to get the price point down so that it becomes more accessible or relevant from an India perspective. That's the primary thing which we have progressed over the last 10, 15, 20 years. We have not yet reached a level where actually innovation is coming out of India in the medtech at this point in time. And hence, the next question which comes in, what do we do about it, what can we do about it? I think the first thing is about a policy. So private companies, PE firms, all of them are investing all this innovation, and there are pockets of this innovation happening. But I think right now we struggle from a policy perspective that which is that one department in the government, if I may, whose job is that how do I participate in the global market. So in India, typically if it's a $100 market globally, we are only 3 to 4% India market, right? So it's not a large market from a global perspective. 95% of market is actually outside of India for medtech, right? So if I have to create those centers, we have to pick up those 5 or 6 areas which a country like India has to be good at, pick up those spaces, which typically will be in plastic molding, metallurgy, and electronics primarily, electronics/software, and pick up spaces where India will be in the top 10% from a world perspective at a price point and innovation. And these 2 or 3 areas which we pick up, then we fund. We meaning government has to fund it, industry has to participate, resources have to be created behind it, and then become best in class from that angle. So that's one part of it, which is the local innovation. Second, which is linked with this, is companies like BD or many other multinationals who have global R&D centers sitting here. Most of these global R&D centers are training engineers. Like BD has like 650 engineers, but working on global R&D projects. There are global capability centers being created in the back end. But there is no financial incentive right now for all these capabilities actually to be directed for India innovation, India-specific innovation. So if we can come up with policies which will be beneficial, that if some GCC starts working on Indian market, many of these resources were trained people bringing in the knowledge for an India population. I think those are 2 ideas which we can think of, is what I can think, right? Please.
Thank you so much, Atul. My final question from a panel perspective to Dr. Sangeeta Reddy. You've heard some of this. As a provider, if you have to call out one thing, or maybe 2, max, why some of this does not scale beyond the big metros and cities to tier 2, tier 3 cities, what would you want as a change to make that happen?
Within the government or?
No, from a provider standpoint. As opposed as you take some of these innovations.
So honestly, I find no reason why it shouldn't scale, so I'm sorry about for being a dissenter to the question. It's a matter of the ecosystem that you've created in that village. So if you take, our village that we've created a hospital, put trained doctors, they have to operate at the same quality level with the same protocols as what's happening in the city. They may do social adjustments, may not have AC in the waiting rooms, their toilets may be Indian toilet, not Western toilet. That's customization. But in terms of quality, there should be no compromise. And I believe that in most cases, whether it's using devices or it's implementing AI solutions, these are enablers towards the larger vision of quality care, accessible care, population health, preventable health care. So each of these are steps. When we said, Rahul made that point about Durandar versus booking a health checkup, very, very critical point. But imagine if we change the dialogue to say that the first thing we want to do is implement on the telephone an AI-enabled health risk score. They don't have to go and buy any test. It's completely free. Ask them 20 questions, ask them 9 questions, and improve their awareness level about the risk they have. If you talk about preventable hospitalization and admissions as a measure of quality, I think it's fabulous, but then the debate and the discussion around that is very complex. Because if you say this was preventable, the doctor will say you don't realize that their risk scoring was higher, and therefore which risk scoring have you implemented? It's a complex dialogue. But if we as a country said, I don't want to find cancer in stage 4, let me spend money, use private sector, use government sector, but implement cancer and cardiac screening. I should never have to replace 5 vessels in a cardiac environment. Why are we doing 5-vessel angioplasty? Where was that man when his first vessel started getting blocked, or where was that woman? If we change the narrative to saying proactive, preventive, personalized healthcare, enabled by connected ecosystems, AI embedded, and education to bring this awareness, education to primary doctors, education to specialists, and education to public. Then our goals have changed, our focus has changed, but our impact at scale will be higher. And then it's not about city or district, it's not tier 1 or it's not tier 2. It's where did I put the ultrasound, where did I put the treadmill, where did I put the testing mechanism, where did I train my doctors? That becomes your baseline infrastructure irrespective of geography. Then you put the systemic approach which says screening, education, prevention, emergency care, advanced care. Based on these steps, you decide which infrastructure gives you ROI, that's fine, or return on impact to life, which is the next one that we should be looking at in healthcare. And that way you completely re-engineer the health system to think on these lines. And we can all do it, I'm very, very sure about it.
Well, this is,
and I invite all of you to our village, please. 68,000 people from birth through life, infant and maternal mortality 0. In the study done by the collector of that area, it's this cluster, it's a mandal. The incidence of non-communicable disease is 16% lower than the neighboring mandal.
I can vouch for it. I've had the privilege to go
exactly.
and see it.
And I want to thank the Gates Foundation for the work they do at grassroots level at many, many, many areas. Thank you for being on this panel and for doing the work that you do.
You so much.
Thank you.
I just wanted to add one more point to what Sangeeta said when it comes to rural, right? For our sector, 70% of people live in rural India, 20% of diagnostics is rural, right? And for ThyroCare, 80% of our business is tier 2 and beyond. I think scaling any innovation in the rural setting, if you try to do everything on your own, it never works. I think finding smart partnerships where you are able to own one part of the value chain and you're not too fussed about someone else doing something for you is when innovation really works in the rural space. And the other myth that affordability is a problem in rural. I have seen people spending much more on an HbA1c in a tier 3, tier 4 town than actually in Mumbai.
Appreciate it. And I see Atul completely agreeing. But thank you to all the panelists. This will be very useful. And, I know it's been short, but I appreciate. I hope people get an opportunity.
Thank you, sir. Sir, can we request for a quick group photograph and then request Mr. Harish Iyer for
should we just finish the group photograph and then Harish will?
Yes, sir. Yes, sir. Ladies and gentlemen, let's put our hands together. And while they are taking this group picture, may I inform all our participants about the hashtags. Hashtag Viksit Bharat 2047, hashtag Arogya Bharat Summit, hashtag Annual Summit 2026, and hashtag NATHEALTH for your benefit when you would like to post on social media, on LinkedIn, Twitter, or Instagram. And I will now hand over to Mr. Harish Iyer for his presentation. Over to you.
Is there a clicker? Is it starting up? Hello everyone. I think I'm standing between you and lunch, so I have to go. I've been told I have 5 minutes maybe to go, but if the presentation can come up. Yes. Hi everyone. So I think I didn't fully have the whole context of today. I think you've heard a lot about this, about how healthcare needs are evolving globally and in India. Aging is a significant problem. And the foundation is really focused on the bottom 500. How do you get to a healthy India? How do large numbers of the population get to be healthy? And how can we innovate to make sure that this healthy India is possible? So obviously, in my mind, there is plenty of innovation happening in India, which I think could be a good debate. mRNA therapies, dramatically lower cost, the changes in molecular design. We are now moving things at a molecular level, right? CRISPR, You're able to slice and dice what you need to do, and this can be actually made very inexpensively, so it could dramatically transform. We've talked a lot about monoclonal antibodies over the years. I used to work in monoclonals quite a bit. But if you did monoclonals with mRNA, you cut the cost by 100 times. Right? How do you get people across the country be able to access it? Antimicrobial resistance, which many of you are familiar with if you run hospitals. How do you make sure that next generation drugs can be done with AI? I think the diagnosis is a key part, molecular diagnostics. How do you get diagnostics to work at the grassroots level, but also help many of you in the companies that you're running? There is a great deal of capability to do this. There's nothing fantastically unique about developing these kinds of tools. I think from a digital and AI perspective, how can AI be used to triage? We heard Sangeeta talk very nicely about it earlier in the morning, about the kinds of data that she has in her hands and what she's doing, even at the grassroots level. How can this be accessible to a much wider set of the population? I don't think we will feel particularly good if we had 300 million of the 1.4 billion people doing well, and then the rest of the folks are doing so-so. You heard about 800 million not having their regular checkups and not having any idea about where the diagnostics world is. But I think the good news, and I'm going to sound optimistic here, is that there are multiple initiatives that are happening to transform the country into greater innovation. There is public funding. You heard a little bit from the member from NITI Aayog. We are actually quite actively involved as the Gates Foundation in funding several such startup companies, and to understand in the deep tech space, this is not making a stethoscope again, but really in the deep tech space on some of the things that I talked about, AI, molecular design, engineering, devices, trying to do push funding to make sure people can understand, to get the startups going and going strong, to evaluate when startups work well and create products, to simplify the pathway, work with government, of course work with people like Shankar Pinjay in terms of what should it cost to do this. So reduce the entry barrier and therefore you can make it more affordable. And I think there are many such examples in the tech industry. Obviously this goes without saying, India has got a great advantage in this. We've got a large talent pool. I know some of us try to hire and we think it's so hard to hire the right person, but I have been to many universities within the country and there are some terrific people who are trying to do this well, great deal of talent. I think they just need to be guided, supported along the way, and we heard a little bit about the regulations that are important to support innovation. The numbers are here in terms of the multiple startups that are needed, the genetically diverse pool of patients that India has, and of course ABDM and the many digital goods and AI tools that people have to be able to do it. I think India has already started showing these green shoots on innovation. The number of innovative products over the last 10 years has grown 1.5x. The startups have grown up 10x. Investments have also grown up significantly, and you can see this, when you go around many of the startup ecosystem, you can see some extraordinary things that are happening. We are very close to the frontier in the world, right? This is not that we are 10 years behind, 15 years behind. We are close to the frontier, but frontier does not necessarily mean very expensive therapies or treatments or diagnostics. That's the key difference. Frontier means you can solve difficult diseases, challenging diseases, but make it much more affordable than the West. That's always been the India advantage. I think this can continue to be the India advantage. And again, from the foundation perspective, we certainly think about this as India for the world. It's not just India for itself, but India really for the world, and that's an important factor. I think the AI ecosystem with the Global AI Summit that just happened also provides tremendous opportunities. Again, I don't have to say too much on this because Sangeeta made a great point of how data has to come together. If it comes together, what can you do? Now, the trick is, how do you do it in the public ecosystem? The bottom 800 million, how do they get access to this? Very different disease profiles, very different nutrition profiles, different cardiovascular profiles. Also, while people are getting rid of TB and other infectious diseases, suddenly you have anemia you have to worry about, maybe metabolic disorders, God forbid, but very likely that can happen because of the genotypes and phenotypes that Indians are and the dietary diversity or lack thereof. We have the challenge of what's called the dual burden of disease. Could we become a wealthy country without being a healthy country? Or will we be healthy first? Are we likely to expand our lifespan before we get into middle income country status? So that's going to be, I think, a key competition as we think about reaching 2025. So I think, as an audience, you have a critical role in playing a lot of this. You continue to have a critical role. I would certainly urge everyone to participate in the national innovation journey. The foundation is certainly participating with the government on lots of these programs, including NRF and other such programs. We are helping to set up with the government, supporting the government in setting up sandboxes for AI and medtech. How can we test it? How can we make it interoperable, the right standards, which will of course help, I think, companies in India to both compete in India and globally. I think the data exchange, you've heard about it, interoperability, you've heard about it, this has been a mantra all along. I think individually private operators realize that this is important to do, but in the public ecosystem, because we work quite a bit with the public ecosystem, how does the public ecosystem learn from you all while you publish similar data? How can it work together in a seamless way and access the entire country? And of course, the whole idea of HTA, which again you heard about quite a bit from Shankar earlier in the panel, and I think he will have much more to say because he's been an expert. We have seen a lot of the work that they've done in areas of deep interest to the foundation, certainly more for the bottom of the pyramid, but I think there are many, many opportunities there for stake advantage. I'll stop there. I think I'm more or less on time. Thank you very much, everyone.
Thank you very much indeed, sir, for that wonderful presentation, and thank you for concluding it in before time. So, ladies and gentlemen, before we all proceed for lunch, I have a few important announcements to make. First and foremost, at the roundtable conference, we found some cash, which I think was left there by mistake. You can kindly collect it from Ms. Brinda of NATHEALTH Secretariat. Secondly, like already announced, you may kindly use your hashtags for all the social media updates that you would like to do on LinkedIn, Twitter, and Instagram. Hashtag Viksit Bharat 2047, hashtag AROGYA Bharat Summit, hashtag Annual Summit 2026, and hashtag NATHEALTH. So ladies and gentlemen, with that we invite you for lunch. We would like to inform the lunch is being served one level below at the Regency foyer. The next session will commence sharp at 2:30. We request you all to be kindly back in time. And for all those early birds who can join us by 2:20, we will have some very interesting quiz for you with some very, very interesting prizes to be won. So ladies and gentlemen, kindly be back in time for the next session. We are really, really running against time. Thank you. Enjoy your lunch and be back in time. So, ladies and gentlemen, while we are waiting for all the dignitaries, all our participants and guests to join, I would once again invite Simran to kindly take over, and maybe we can have few quizzes. All those who are here with us will be lucky enough to win those prizes. So over to you, Simran.
Thank you very much, Sapna. So once again, good afternoon, everyone. We are back with the exciting segment of the day. Let's start with the quiz part once again. And can we have the slide over here? So I request all of you to please scan this QR code, which is here on the screen. So that you can participate in this quiz session. I request everyone to please scan this QR code and join the quiz session. I can see there are a lot many people, but only 4 have joined. Okay, 5, 6. I request everyone to please log in. So once again, I request everyone to please scan this QR code and join the quiz session so that we can start with a question round. All right. Can we have the question, please? And here is the question, even on the mobile screen as well. Name any AI applications that help patients make better health decisions. Options are AI-based symptom checkers, personalized treatment recommendation tools, digital health assistants and chatbots, all of the above. Can we have the answers, please? Any guesses? All right. So since you said it first, what's your name? 1 second, let me come that side. What's your name?
Mandeep.
Okay, Mandeep. So you have to say it aloud. Not an issue. So let's wait for the answer. So it's 3, 2, 1, and the right answer is all of the above. That's correct. So team, can we have a giveaway for Mandeep sir, and can we have a huge round of applause for Mandeep sir as well? Can we clap for Mandeep sir? Thank you. All right. So let's have another question. How many hospitals have adopted NHCX? And there is a slider. You can also tell me the percentage over here, or the numbers over here, and click on the slider as well. Any guesses? The number of hospitals? Any guesses? Sorry? 200? 500? 150? Any other guesses? 550, interesting. 550, 300, only 19 seconds left. So, any other guesses? 210, 410, 450. Sorry? 450. All right. So the correct answer is, no, it's a slider, But yes, you're the nearest one. What's your name, ma'am? Tina. So can we have a huge round of applause? She's the nearest one, 600 hospitals. She mentioned 550. Can we have a giveaway for Tina, ma'am, as well? So we have the leaderboard over here, Mr. Vivek, who is leading in the scoreboard as of now. He's the fastest, fingers first participant in this quiz. All right, let's have another and the last question of this quiz session of today's. Okay, can we have the question, please? So the question is, when will the DPDT Act come into force? So here is the slider. You can lock your answer with the ear. Any guesses? 2027. Sorry? Interesting. So we are just, choosing the first one who speaked it out. Can we have the right answer in the next 20 seconds? I'm just waiting for the right answer. All right. So the right answer is 2027. And sir, what's your name? May I have your name, please? Okay. Dr. DP, sir ke liye ek bari zordar taaliyan. Let's have a quick round of applause for sir, and can we have a giveaway for sir as well? And let's have a final scoreboard over here. And the leader is Shambhavi in this house. Shambhavi. Vivek Yatharth, sorry, my bad. So the leader is Vivek Yatharth in this room. So can we have a huge round of applause for Vivek sir, and can we have a giveaway for sir as well? Thank you so much. That's all. And I would like to hand over this to Sapna as we continue with the rest of the program today, and the conversations there will play a vital and important role. So to shape the future of Viksit Bharat 2047. Thank you, everyone. This is Anchor Simran just signing off for today, and I'm handing over to Sapna for this entire event. Thank you so much, everyone.
Thanks, Simran, and once again, congratulations to all the winners of this small little quiz that we had curated just to get people together. And ladies and gentlemen, we are now all set to move ahead with the proceedings of our next session. And we hope you all had a pleasant lunch and some productive networking also, and you enjoyed the sumptuous lunch served to us by the hotel and our gracious host. So we move to session 4 of the NATHEALTH Annual AROGYA BHARAT Summit 2026, titled Provider MedTech Convergence Towards Viksit Bharat. This session, which is being supported by our knowledge partners PricewaterhouseCoopers Services LLP, PwC, will explore how stronger partnerships between providers, MedTech innovators and policymakers can drive innovation, support local manufacturing, and accelerate the adoption of cutting-edge healthcare technologies in India. And ladies and gentlemen, to guide this session, it is my privilege to invite our session chair, Mr. Himanshu Baid, Vice President of NATHEALTH and Managing Director of Poly Medicure Limited, to kindly come up on the stage. We also welcome our dignitaries, Shri Aman Sharma, Joint Secretary, Department of Pharmaceuticals, Ministry of Chemicals and Fertilizers, Government of India, and Dr. Rajiv Singh Raghuvanshi, Drugs Controller General of India, Central Drug Standard Control Organization, Government of India. So may I request all our three dignitaries to kindly come up and take their seats on the dais. Let's put our hands together to welcome Mr. Himanshu Baid, Shri Aman Sharma ji, and Shri Rajiv Singh Raghuvanshi ji. And I would request Mr. Himanshu Baid to kindly welcome our dignitaries with floral bouquets. We welcome Shri Aman Sharma ji. And we also welcome Dr. Rajiv Singh Raghuvanshi ji. And I would now invite Mr. Himanshu Baid to kindly deliver the opening remarks and set the tone for this very important discussion. Over to you, sir.
Good afternoon, everyone. I think a lot of people are out for lunch, and I request the NATHEALTH team to, ask them to join us for this very important session. We are the two most important people here. Shri Aman Sharma ji, Joint Secretary, Department of Pharmaceuticals, who helps in policy making, and he's our nodal for the medtech industry, to help this industry go. And there's a lot of policy work going on, and I would request everybody who's in medtech, connected to the medtech industry, to hear him out also today. Then we have Dr. Rajiv Singh Raghuvanshi ji, Drug Control General of India, CDSO. He's been a great champion for the medtech industry, and I think under him, I think today more than 3,000 plus medtech companies have been today granted licenses to make in India, and it's an amazing feat which has happened, in last three and a half years under his guidance. And I think today the trajectory of the industry is much different. When we look at the whole medtech industry today, where we are around $15–16 billion, and out of which 8 billion is import, around 4 billion is made in India, manufactured in India and sold in India, and around 4 billion is exports. So we have like a half and half ratio where half the production is happening in India, with some export related production also happening here. But today when we look at 3–4 years down the line, we are talking of 30 billion revenue by 2030. That's what the size of the industry can be in next, let's say 3 to 4 years. And why I'm bullish? Because today people are looking at India because it's a threshold we have to cross. So I think we have crossed the threshold where manufacturing is happening in the country, where there are now 3,000 units which are, in country more than 4,000 are, I think, regulating today in terms of manufacturing in India. And all these units will keep on, increasing capacities, adding more products. So that's we see the momentum getting created. And then export markets also, which we are almost at $4 billion of export. And I think as this, crisis is developing in West Asia, people are also looking at diversifying the supply chain. And India will get a big advantage. Also, US markets, the different FTAs which have opened up, especially European FDA, UK FDA, the trade deal with US, and of course the Australian FTA, and many other, which are in pipeline. All these will open a lot of opportunity for India, India as a country where we can bring in technology and also, export products to those markets. And especially we'll get advantage in terms of concession rates, or even in some cases zero duty in most of the products. I think when I look at Department of Pharmaceuticals, and we had heard Secretary Sir in the morning, and he talked about regulations which needs to be more stricter. Same discussion I was having with Raghuvanshi ji, that how regulations can be more stricter so that people trust more Make in India products. Today, there is a trust deficit on Indian medical devices, made Indian medical devices. How we can improve the trust? And I think the solution was in testing more products, whether at the manufacturing stage or even post-market surveillance, or even making regulations more stricter, so that companies comply to the stricter regulations and there is more trust from the user side. When we talk to users, a lot of users are today in this room, and I think they echo that same thoughts. Then of course, partnership between small and big companies. Today, a lot of startups today struggle to put products in hospitals. So how can that partnership build over a period of time? How large medtech companies can partner with smaller companies, help them, to go through that journey life cycle much faster, and they don't go in the value of that, which is happening with 90% of our startups today in the medtech industry. Then of course, the different schemes, especially PRIP, PLI, then the schemes for import substitution, and now schemes which are government has announced on biopharma, Shakti mission. So a lot of these new schemes are available for localization of products, for new technology, for R&D, for clinical trials. So a lot of today funding is available, and I think Department of Pharma is doing a great job in pushing those schemes to the medtech industry. We have seen some impact already created, and in future also we'll see more impact. Also, there's a funding, there's a partnership available through NIPERS, whether for biopharma mission or even for medtech companies. There's a lot of partnerships available. NIPER Ahmedabad, which is a specifically dedicated NIPER for medtech innovation. There's a medtech curriculum there. So I think there's a lot of work happening there. Then, of course, sir also talked about very important subject, which took us by surprise, which is trade margin rationalization. And I think that's something industry is very about that subject, sir. And we have gone through that price control crisis of a couple of products. And I think today trade margin, I think, would favor some, would not favor some companies. And I think this needs a wider industry consultation. And I think what sir also mentioned today, that even the hospitals should get involved in that discussion, that how would that impact them, and what is their view on that. So I think a 360 review is very important, not only from the manufacturer side, but also from the user side, what they are, looking at. And then of course venture funding available, where Department of Pharma is ready to, partner with venture funds, for, and they also can bring out a fund basically to help startups, small sector SMEs or MSMEs to upgrade and to even do, grant them, funds for innovation. I think a few important things, I would talk about. One is on the GST side. For medical devices this year, in the GST, previous year, last year, sorry, GST was reduced to 5%, which is a great move because it reduces the cost to hospitals for products and also reduces cost to the patients. But on the flip side, companies which are manufacturing products in India, they have an inverted duty structure almost of 18%. Most of the products we use as raw materials have an 18% GST on them. I think that is where we need government to act faster. Also, pharma has got a job work rate of 5% on GST or on job work rates, whereas medtech industry has got 18%. So I think our request to the government is again, for rationalization of that GST for job work to 5%, so that we can outsource more products. Because medtech industry has a lot of ecosystem around that, because when you look at electronics, there are a lot of suppliers where you send out products for job work to other industries. Even in today orthopedic implants, or even in plastic molding, you send a lot of products for outside vendors to make it for you, as part assemblies, sub assemblies, and their job work rate becomes kind of an impeding factor. So I think that's what we need. I would also thank Department of Pharma to take initiative on taking away the QCO orders headache from us, because this was a big issue where most of the raw materials were falling under QCO orders. Even the equipment we were importing, machines and technology was also falling under that. And I think most of these QCO orders have been removed. So that's a big relief for the industry, because this clears the path for bringing new technology into India without any hindrances. And also critical raw materials which we are importing, also we see a continuous flow, because at some point of time the flow was restricted. Again, today we need to address fundamental question of provider and medtech transactions. Medtech co-creation anchored in patient outcomes, shared accountability, and national health priorities. As we chart our course towards a vision of Viksit Bharat 2047, we must recognize the providing affordable healthcare, high quality healthcare, and innovation-led healthcare delivery requires a paradigm shift. Again, we know that India's per capita spend on medtech is only $9. And if we translate into the population, 1.4 billion, so maybe it's around 15, 16 billion now. So there's a huge gap. Global average is around $60. Even a country like Brazil, spends almost $15 billion on medtech procurement and medical technology. And India, a country of 7 times the size in population, has the same spend. So we are far behind, and I think we still need to work on that. Also, when we look at other areas of focus, I think medtech must evolve from a product supplier to strategic partner in healthcare delivery, co-owning outcomes, efficiency, and innovation. I think we are working on that. I think today's session we will delve more on that area. And again, by leveraging data-driven insights, standardization, and process automation, medtech can reduce costs while improving clinical outcomes. And I think that's what we want to demonstrate today to the healthcare community fraternity, that if we go and data-driven insights, if we focus more on training, I think there could be a lot of savings coming into hospitals. Healthcare providers and medtech companies should co-innovate next generation technologies by jointly identifying clinical pain points and translating them into scalable outcomes. I think that's a very big gray area. I think if we work closely, a lot of solutions can come which could be frugal innovations on the existing products, but could be very impactful. Unified push by healthcare and medtech providers to expand insurance coverage for advanced technologies. I think that's very important. See, yes, we are talking of India's reliance on foreign technology, foreign products, but that will continue to happen because a lot of innovation happens in the West. We need those products. Of course, we also need to have self-reliance in some part of the industry. I think so. There, I think it's very important that important new technologies which are coming in India should be reimbursed. And especially like robotic surgeries and other high-end interventions which are required, should be covered by insurance. Then, of course, deeper collaboration between healthcare, medtech, and academia. I think that's where we lack focus. I think Sir also talked about it in the morning, that today academia has some other issues. When you talk to industry, there are some other issues. So there's never a conversion out there. There's no convergence. So I think we need to bring that conversion. We need to create some platforms where we can bring everybody together, and then of course accelerate our clinical trials, evidence generation, and faster adoption of innovation. Strengthening partnerships in education and training. I think medtech can play a very important role in enhancing clinical capabilities. So India can unlock global opportunities by offering integrated healthcare solutions, combining delivery, medtech, pharma as unified export proposition. The future of healthcare lies in partnerships, not procurement, where medtech and providers can co-create value, not just transact. Thank you very much.
Thank you very much indeed, sir. And ladies and gentlemen, it's an honor to have with us today Dr. Rajeev Singh Raghuvanshi, Drugs Controller General of India, CDSCO, Ministry of Health and Family Welfare, Government of India. With over 3 decades of experience in pharmaceutical regulation, drug safety and public health, he plays a pivotal role in ensuring the quality, safety and efficacy of drugs, vaccines and medical devices in India. As DCGI, he oversees the country's national regulatory framework for pharmaceuticals and medical devices, guiding approvals, regulatory reforms, and strengthening India's drug regulatory system. May I now invite Sir to kindly share his valuable insights on the importance of strong regulatory frameworks in enabling innovation and strengthening healthcare delivery with his special address. Let's once again put our hands together to welcome.
Good afternoon. Good afternoon. So, difficult for any speaker to take a session just after the lunch, but I'm sure you'll have some attention towards what I speak. So, I'll start with thanking the organizers for inviting me this afternoon and share some of my thoughts, especially related to regulations of medical devices in the country. How do we see what's happening? So, starting with the risk of repetition, just to set the context, some numbers, which I think Himanshu also spoke about. We are currently about 15-16 million medical device trade value in India, and maybe around 20% is exports, rest all is domestic. But when you see the global scenario, about $700 billion US is the trade value globally, and we are less than 3%, 2.5% contributing to global trade of medical devices. So these numbers are important because this tells us about the opportunity which we have when we look at the medical device industry. We can extend it to medical technology industry also. One of the issues which we currently are facing is the product mix, or we can say as the risk category mix currently being produced versus what we are importing. Majority of the domestic production is the low risk A and B, which is the low end when it comes to technology and when it comes to the value and the profitability. And I think everybody wants, as a country, to move to the high end, which would certainly bring more value to the whole medical device domain. And a lot of efforts are happening currently from the government side also. I'm sure Amanji will speak about those government schemes and how government is trying to support. But on my part, I would certainly like to touch upon a couple of areas. One of them is the innovation, which would actually very essential to basically when we have to move from this more commoditized products to more innovation-based products, which are the high-end, high-risk category C and D. And today, when I see the scenario in this country, and I keep traveling and keep talking to a lot of medical device people also, one good thing which is happening currently in the country is a lot of activity is happening at the interface of technology and life sciences. And that is one area which is going to contribute hugely when it comes to innovation and coming out with the high risk, high innovation products. And that is where we have to put more focus when it comes to the whole industry, development of the whole industry, and moving from the volume game to value game. And I can take some examples. There are many more. Today, if I see every IIT, if I go, everybody has a life science center, and all of them are working majorly in the medical device, medical technology area. They have well-defined, well-structured faculty in life sciences, which was not thought over a few years back. If you talk of Jodhpur IIT, Jodhpur AIMS, both of them have come together. They have started a BTech degree in biotechnology or med technology, something like that. And both institutes are actually collaborating very actively on the capacity building as well as a lot of innovative product development from the startup domain is coming from those kind of collaboration. Similarly, I have been to IIT Gandhinagar, if you see IIT Bombay, IIT Chennai, my alma mater, IIT BHU. All these places have either started a life sciences division in their college itself, or they have started collaborating with equally big and equally established medical colleges like AIMSs of the world or PGIs of the world. And when I talk of BHU, the Institute of Medical Sciences, collaborating with Indian Institute of Technology there. So just to say that there is a huge activity which is happening there, which talks of, I think this is important also from people who are in the investment domain, because they have to actually put some money there at that interface and help those guys scale up the products which they are conceptualizing, they are developing in the prototype form. And I was so excited to see when I go and interact with these teams, the startup teams, basically started by professors of these colleges, that so beautiful concepts, very small concepts, but actually developing product around that. And they would need a lot of money to scale that to make it commercially successful product. So it needs actually a good amount of money, and I know there are a lot of investors sitting here in this gathering. So that is one area which is potential from finance point of view, but it is also important from the country point of view, from the nation's development in the domain, from that point of view, to look into this area. Historically, IT has been our strength, and we should encash on that. And that is something important for us to keep in mind, that both these domains, life sciences and technology, we have been very strong in historically. The success of pharma, maybe in generic space, was mainly because of our strength in chemistry and ultimately life sciences. Here it is actually in the technology and the life sciences, and we are strong in both the domains, and I think we should not miss this opportunity to get on top of it and be the world leader. When it comes to regulation, see, a lot of things currently, people who watch, and I know most of you watch the regulator in this country because of one or the other reason, but this is one area which is currently so active because of the country's leadership looking into it, because they have understood that we have to change in all aspects if we have to be competitive globally and keep our leadership position, which we have currently in the generic side. A lot of things are happening to shift from this volume to value game, but when it comes to, specifically if I talk of the regulatory system around medical devices, so one of the main things which currently sort of holding us back is the manpower. We have a team of 21 people who are actually doing the complete application reviews, and with the help of the digital technology, whatever we have been able to do, I feel very proud as head of that organization that we have actually in last couple of years, if I talk, some 4,350 manufacturing licenses. It's not 3,000. It's actually Till yesterday, it was 4,350 manufacturing licenses have been issued by CDSCO for manufacturing one or the other product. The number of products will be much more than that. This is just the manufacturing license. And 12,000 plus import licenses, which is not, for me, a very good sign. We should actually, we'll have to do everything to flip this, that this number goes less than the manufacturing licenses which we issue, but that's the reality as on today. Long pending demand, we have started the meetings of MDTAB, the Medical Device Technical Advisory Board. We have had, I think, 2 or 3 meetings already. So that is something very good which has happened to strengthen this whole medical device system. Lot of deregulation, ease of doing business activities are currently happening. Some of them, if I can just quote here, we have simplified the application checklist from very complicated in the beginning to now we have rationalized based on the experience, and that has helped a lot in terms of, on our part, saving our resources from queries and continuous PRO engagements. And I'm sure it has helped the applicants also, the industry which is applying for the approvals. We have published the draft guidance for the SAMDs, the software and medical devices. We are open to get more and more feedback to keep on improving on that, but that is something which has happened good. The updated existing risk classification system, it is now on portal, the complete list of all the approved category-wise, which helps all the new applicants to actually decide on their own that what category their product would fall, which was an area of confusion earlier. I see less and less issues coming in that area. So that is an improvement which has happened. Operationally, the brand endorsements we have started earlier, it was not there. So if you have one approval, for the same product, additional brands can be endorsed on the same manufacturing license. Post-approval change system has been streamlined, and operationally, in CDSCO, lot of delegation has happened to the officers down the line, which actually is saving time of review and ultimately closing the applications. Lot of digital transformation has happened at CDSCO, which is helping in building that database related to the medical device industry in the country. And it also helps us keep a watch on how things are moving in medical device domain. To the extent that now we have like corporate systems where every morning we have our dashboard, where we, at my level also, that is actually effective at every level. But at the highest level also, I can look into it, that which file is with which drug inspector for how many days. So we have gone to that level of granularity, which is helping in deciding and fixing the ownership. And if there are issues, then there are people who are held responsible for that. So there is a cultural change, there is a mindset change which has happened at CDSCO. People say that we are more open now. If I say that I say, you may not believe, but I think the feedback comes from you only that we have become more open. We have in medical device these market standing certificate, then neutral codes. All these have been digitized. We don't do any intervention. It is auto-generated. You apply, you get the system-generated certificates. One good thing which has happened is that now every application is auto-allocated to an officer. Depending on how much capacity he or she has, when you apply, the system automatically takes it to the reviewing officer, whoever has the capacity. So that has actually equalized the, rather optimized the resource which we have at CDSCO. So nobody now has some skewed system of somebody who is a good worker has the maximum number of applications, somebody who is not working will not have applications. So that system has now been equalized by auto allocation. So similarly, We also did one good thing, is that now, some of you have applied recently, you will see that on application, when you fail because it's all 100% digital, you will see the tooltips pop up, which actually guides you about what is the regulator's expectation with this particular ask, which has actually helped a lot of people, both sides, regulator, in saving our resources, in every time responding to queries and justifying or explaining that what we mean by this particular phrase or this particular ask. The tooltip explains that when you actually fill these applications. So that is a good development which has happened. Beyond that, if I see not many application improvement have happened, but one thing which I also wanted to caution at this point of time, we are aspiring to become a global player in medical device, and our experience on the drug side, as well as the way the whole world is moving, we will not be able to a successful international player in the domain if we do not look at the quality and quality management system through which we work and through which we run our organizations. And it is one of the most important things from a regulatory point of view. I don't want to get into experiences which unfortunately we have had in the recent past on the drug side, which is completely unacceptable. The signals which are coming from the market, I can say, are not very positive in some of the cases where we get that the regulations are, there are non-compliances, there are shortcuts happening. So it's a matter of time. We are in the process of recruitment. 42 new positions will be recruited in maybe next 3-4 months. We are going to come heavy on non-compliances. As industry watchers know on the drug side, the way we have been doing the registration inspections and the impact of registration inspections on this country's quality of the product being manufactured on the drug side, we will replicate the same for the medical device industry. So it's good to be prepared, good to be compliant, not only because the regulator will come, because we have to win the world market, and that cannot happen without the quality. And one more thing, which since we are at a inflection stage, one more thing is important, I think, as a regulator, I should say. I can make thousands of regulations, but nothing will happen unless until our personal ethics works there. So, as the business owners, as system owners, we have to see that the DNA which we develop in our company is of the compliance and ethics and not the other way. So, this is important, and we have to, as I said, we have become more open, and one request from this community is also that give us feedback and be open, give us the areas of improvement. In fact, we need more areas of improvement from you, because you being the stakeholder and our customer, I think unless you give us the feedback, we will not be able to improve. A big initiative currently running in the under the leadership of NITI Aayog is on the deregulation part, and a lot of suggestions have come from medical device industry for from the medical device side, the people who are into that domain in the business, for deregulating. Some of them are possible, some of them are not possible. So whatever is possible, we have started working on that. But having said that, we need more of them. We need to know the systemic changes you want in medical device regulation. It's a new regulation, couple of years old, so it will take some time to mature, but that is the time where the feedback from the market would be more helpful to us. and we would certainly like to improve and give you the best in the world. And with this, I'll end here this afternoon with the hope that we keep our interactions, and your feedback would always be helpful to us for improving the situation. Jai Hind, Jai Bharat.
Thank you very much indeed. Sir, can we have it later during the panel discussions? Thank you. We are running behind time, and we have another very important speaker here on the days with us. So, ladies and gentlemen, we now move to the keynote address. And it is my privilege to invite Sri Aman Sharmaji, Joint Secretary, Department of Pharmaceuticals, Ministry of Chemicals and Fertilizers, Government of India. In his current role, Sir oversees the key portfolios, including the medical devices, information technology and media coordination, and parliamentary affairs within the Department of Pharmaceuticals, contributing to policy initiatives aimed at strengthening India's pharmaceutical and medtech ecosystem. And may I now request you, sir, to kindly give us the keynote address. Let's put our hands together for others.
Thank you, ma'am. Raghuvanshi sir, ladies and gentlemen. I am kind of new to this sector, just put in 6 months or so. So this entire 6 months probably has gone into developing some kind of a working understanding of the sector. And yes, I cannot claim that I know a little bit, but yes, some of the things I'm still trying to understand. But one thing I can say with a lot of confidence that I think the work of a regulator is very difficult. If you regulate more, you tighten the strings more, the industry will crack out. And if you leave it lax, I think the patients are going to crack out. So it is a very, I think, very fine balance that the regulator has maintained. And as we all know that medical devices is a totally new sector in the country, and in fact it has been brought under regulation very recently. And as a result, the regulatory capacity is still in the process of developing, and Dr. Raghuvanshi has just mentioned, they are working very hard to enhance the regulatory capacity of CSU so that the quality of the devices that is being manufactured and sold, I would say even that applies to imported devices as well, that should undergo a significant enhancement, I would say. And I think CSU is, and Health Department is totally committed to this work. And in the next few years, I think we are really going to see good results from that. Now, I put in close to 24 years in the government, and I can tell you that regulation of any sector has been difficult in this country. And as Dr. Raghuvanshi also said, that I think more than the laws that we make, ultimately it all boils down to what are the ethical standards being followed in the country by different sectors, different manufacturers. You represent the hospital chains. And as we all know that private healthcare is occupying a very, very important place in the country. And your sector, I would say, is kind of not regulated by the government. And in that we see mixed results. In sectors which are highly regulated, there also I would say that the results are mixed. We have good instances, bad instances. So it's very difficult to say how we should be actually regulating any particular sector in a country as complex as India. So it is, I think, always a work in progress, and I think this is a very serious challenge which every government department grapples with. I have been into public procurement for a pretty long time, and I was just applying that, some knowledge of public procurement onto the medical devices as to what is happening in the medical devices sector when it comes to procurement of such devices by, of course, the government. We do not know how much and at what price range the private sector is buying it. But yes, a a lot of transparency is there in public procurement as far as medical devices is concerned in the public sector, both central as well as states. And one thing I noticed that, for example, I did a study on coronary stents and orthopedic implants. And the price of these coronary stents is being driven down. Like you all would know, NPPA, Pharmaceutical Pricing Authority, has fixed ceiling price for coronary stents at around 38,000 drug-eluting stents I'm talking about. But when you see the rates, the prices which have been discovered by various state government buyers, they are as low as 10,000. Now, I really do not know whether that 10,000 is the actual price of that particular device, or some manufacturers there who are making some kind of a shortcut and selling these devices at such low prices. And of course, informally I have been told that the purchase price of many hospitals in tier 2-3 cities for these coronary stents is as low as 78,000 rupees. Now, I have visited several plants who are manufacturing these coronary stents. I can tell you it's a fairly complex device. And I really don't know whether it's actually possible to make it in 7,000 rupees. 7,000 is the offer price. There must be some distributor also in between who might be participating in that tender. The OEMs are not participating, I saw it. Now, he also must be having some margin, some business margin for the manufacturer also. So ultimately for 4,500 rupees, I really don't know what kind of stent are we making. Similar is the cases of orthopedic implants, trauma implants. I did a study of the manufacturers in and around NCR, in and around Pune, Gandhinagar. A lot of these orthopedic implant manufacturers are located in these places. And I can share you offline the names of so many of them. They are actually selling those implants and at a price value which is unthinkable. So this is an area I think more than the regulator, I think it's the hospitals which need to really look into it. Because as we all know in India, out-of-pocket expenses were as high as maybe 65% few years ago. Thanks to Ayushman Bharat PMJ, the out-of-pocket expenses have come down to almost I think 50% now, if I'm right. And with the insurance penetration going deeper, I'm sure the out-of-pocket expenses are really going to go down massively. And then what actually happens, because in countries which are health insurance driven like US, they will have 4-5 brands of every device or every implant that they will be actually using. And those will be the top ones. But here I think somehow our system is actually promoting the use of devices which start from the bottom. Now if a hospital basically wants to maximize their own profit, say for example under PMJ, the package price for coronary stenting is 87,000 rupees. And which includes everything. It includes the cost of devices, the balloon catheter or stent, medicines, service charges of the doctor, use of cath lab, whatever it is. It is a complete package that which is reimbursed to the hospital. Now, if a hospital is using a 5,000 rupees stent and maybe reusing many of the devices which are supposed to be single use, then that hospital is going to wind up the whole process in say 20,000-25,000 rupees. And the rest is the profit. So you maximize your profit and the rest goes to the patient. And we all know the per capita income in the country is almost 2 lakh rupees as of now. One person earning 2 lakh rupees a month, 2 lakh rupees a year, that is the per capita income. But if you see the normative graph, 80% people are still in 75,000 rupees per annum income group. So these are the people who are actually going to make use of Ayushman Bharat scheme. And they are totally at the mercy of the hospital. Now, before I came into this sector, I really did not know what Boston Scientific did or what Abbott did. is the difference between a stent made by, say, XYZ company in Faridabad and the stent which is being made in Ireland. I did not really know. So, but now I have a little bit of understanding, but I think 99.99% people will not know what it is. And so it's where the doctor and the hospital, they play a very crucial role. And I think if they are, their only motive is to maximize their profit, really it's going to be a very difficult situation for everyone. And then, you know, Raghuvanshi Saab is there now, then the regulator comes into play, they will regulate, and they will tighten the screws. And then the industry and the service sector like yours will say that, oh, Mardia. So I think best regulation is self-regulation. And I think this is where organizations like NATHEALTH have to play a role. You have your members, you represent such a big sector. I think this is where actually the focus on ethical practices has come. Profit maximization, I understand that a lot of private equity venture capital is now investing into hospital chains. It is a fact that there is no problem in that. That should happen. For the growth of the sector, it is required. But yes, I think on its own, the sector should draw a line somewhere. And I think this is where I think government will also will breathe easy, because we also find it very difficult to regulate most of the sectors in the country. It's a very difficult job. And in fact, my best wishes to Dr. Raghuvanshi on this. Thank you very much.
Thank you very much, Lisa, for that insightful keynote address. And may I invite on stage Ms. Amira Shah to do the honors of felicitating both our dignitaries. We would like to honor Dr. Rajiv Singh Raghuvanshi ji with a small memento as a token of gratitude and appreciation. And may we present a memento to Sri Anand Sharmani, Joint Secretary, Department of Pharmaceuticals. And I would request our dignitaries to kindly come together for a quick group photograph. Raghuvanshi sir, may I request you to join for the group photographs. Thank you. And ladies and gentlemen, with that, we are straight away moving into the panel discussion session. I would request our dignitaries to take their seats in the front, requesting Mr. Himanshu Baid to kindly stay back for the panel discussion to follow. We move to the panel discussion segment of the session, focusing on provider medtech convergence towards Viksit Bharat. And we are privileged to have with us an esteemed panel representing leaders of the medtech industry as well as the healthcare providers. From the medtech sector, we would like to invite, of course, we have them already on the stage, Mr. Himanshu Baid, Vice President, NATHEALTH. We invite Mr. Mandeep Singh, Vice President, Managing Director, Medtronics India. Warm welcome to you, sir. We invite Mr. Anish Bhafna, Chief Executive Officer and Managing Director, Healthier Medtech Limited. And from the healthcare provider community, we invite Dr. Rajiv Singhal, Founding Member, Group Managing Director and CEO of Marengo Asia Hospitals. We invite Dr. Upasana Arora, Managing Director, Yashodhara Super Speciality Hospitals. Dr. Vishal Goyal, Group COO, ILS Hospitals with significant expertise in hospital operations. We invite Mr. Prashant Sharma, Managing Director, Charnock Hospitals, Mr. Amit Singh, Group CEO, Yatharth Hospital Group, and moderating this session is Dr. Rana Mehta, Partner and Leader Healthcare, PricewaterhouseCoopers Services LLP, who has an extensive experience advising healthcare and life sciences organizations on strategy, innovation, and sectoral transformation. With that, I hand over to Dr. Rana Mehta to kindly lead this important discussion. And so you have about 25 minutes for the panel discussion. Over to you.
Thank you. I think it was was very inspiring to listen about the regulation because I think that's the most important piece as we go ahead. You can't be a world beater unless you have world-class regulations, and which actually builds trust. So I think we have a large panel, but we have less time, so maybe I'll ask everyone one question. One of the things as I was thinking about medtech, I think the biggest thing which no one speaks is the ecosystem. How many of you have heard about the Flexner report? So this is an obscure report in 1910. What did it tell in the US? It says, bring the delivery of care, bring the education and bring the research together. Make it an academic medical center. This was just a structural default issue they did. They brought in all the clinics, the Mayo Clinic, the Cleveland Clinic. After that, 80% of the Nobel players were existing for 20 years. So it wasn't something very difficult to do, right? Just put these three together and you put it. So I think one of the biggest things is the ecosystem which we need to play. Because it's just not the manufacturing which we're talking about. You need to have that ecosystem as we go ahead. The second thing I think is very important in this product is the data which needs to come out, right? If you don't have data, you don't have insights, you won't have medtech which is appropriate to us. So, you always reaching someone else's medtech. The third thing I think is that things change. If you look at automobiles, why was Germany so famous? Because the ecosystem was basically about precision in engineering and metallurgy. Today, with EVs, it's very different. It's about chemicals in the battery, and it's about software which makes you go another 50 kilometers. So again, this is a dynamic ecosystem. So let's not look at medtech today, how it's going to be later. And finally, I think we spoke a lot about the demographic dividend. Dividend is only when it's in the bank. Otherwise, it's always an opportunity. So I think that's something which execution obviously is key. So I'll begin with Manshu, and Manshu we heard a lot, but now I would say based on that demographic dividend, what is the reality check? Where are we going? Will it fix it hard? Will it be 2047? Will it be 2057? Or will it be when we are not there?
I'm sure we all will be there. But I think let me tell you the reality. I think you heard what she's saying that today almost 4,000 manufacturing units have been licensed in India to make medical devices. And I also mentioned earlier that the journey has just started. The industry just got regulated a few years ago, and before that there was no regulation, there was no capture of data. Today nobody knew how many manufacturing units are there, but today the industry is regulated. And I think on the flip side, when we see 4,000 units will produce medical devices, equipment for India and for global markets. And don't forget, India is not a market of 1.4 billion, India is a market of 4 billion. Why? Because all the adjoining markets, like when you look at APAC, when you look at Africa, when you look at Latin America, Middle East, all is where we can sell products made in India. There is a good acceptance there. And that's what I've seen in my 30 years of experience. And I'm not discounting Europe or US, but that's also a big market for all of us. So I think the industry is on the, when we see ecosystem, I think we have now seen a lot of raw material being available in the country which was not there. A lot of these large companies in Europe or US have set up shop in India, material is locally available. Then we have seen AMD as a model, where today is almost 200 plus companies operating in a cluster. And I think that is helping, the cross-industry participation is happening, which was not there earlier. We were all working in silos today. I remember when I started my company 30 years ago, we were operating in a silo. And where almost everything we had to develop in-house as a technology. But today we can go out and get this technology locally also. Whether it's electronics, whether it's different parts, whether it's injection molding parts, or whatever we call it. So ecosystem is coming in. In my view, I think from 15 billion, we should move to 30 billion by 2030. So 30 and 30, that's what we should push. And I think we are getting there. I'm pretty optimistic about it.
No, I think it's the building blocks are there. Also, I think we have an advantage because a lot of technology which now can be made better, faster. We're going to leapfrog, very similar to what we did in terms of we never had a desktop. You saw the internet on your mobile.
Anish, I'll go to you. I think if we were to make an international impact, so we have to have these Indian multinationals. And, to a large extent, you sort of represent that because you have global scale. You were telling me that, practically there is no thing in the world where some product of yours doesn't touch that. The second is the regulation, that's, and Dr. Arogya kept saying, unless we have regulation, we can't really go there. The quality management, which she kept saying people falter, but, as a multinational, you cannot falter on quality. So how do you see this? I think the last part that says you have a last mile access. If it's not accessible, it's only 20 cities, it makes no sense. Because, the last mile access becomes most important. So what are some of those building blocks you put in place, which others can replicate? Because, we have one LVM, but what will it take to have probably 100 of those? And what will it take the LVM to move from 1 to 10 billion dollars?
So, I think we need to give credit to it's you. I think the person who really treaded on this path way ahead of us was Himanshu. When he started Polymer, and the idea was to create products of very high quality and make them international. So there was precedence. And if you look at what is required for the medtech ecosystem to flourish, we have all the raw material. We have engineers, we have software, we have hardware, we have materials. But I guess the focus was a lot on the pharma side of things, and medtech took a little bit of time to evolve. Now, the two things that also were spoken about in the earlier session were focused around quality and compliance. Because without these elements, and probably the third one is precision, without these three elements, you really cannot create a scaled-up play, irrespective of what you try. So, when we started creating everything, the focus was that, whatever we are acquiring, we need to get to number 1, number 2 position, at least in India, and then aspire for a global position. And we get into areas which are complementary, where there is not a lot of global competition, and that allows us to harness the overall economies that we would get by operating in a country like India, using the clinical advantages that we would be able to build out here, and using the talent out here to build these products globally. So it's been an interesting journey. We started by being a sutures and needles company. We've now the largest needle manufacturer, suture needle manufacturer across the globe. And over a period of time, we've added sports medicine, we've added wound management, and we keep on adding new products to the portfolio. So, A is you have to create economies of scale within your own country, because then that gives you the arbitrage and the leverage to go and play the game internationally. You have to be ahead of the curve in terms of investing on certifications like UMDR and US FDA, because you cannot go and become a large-scale company by operating in markets that don't have the pricing power. So if you have to be successful, you have to get into the Europe, Latin Americas, and the USAs, and for that, any compromise on quality or compliance is not going to allow you to prosper out there. India is a great engine for R&D, so we also, all our R&D centers, all our manufacturing centers are based out here. That allows us to leverage the locally, not only the local skills, but also local manufacturing capabilities and take these products internationally. There's a lot of work that you have to continuously keep on doing in this particular field. So one of the areas that we are looking at is trying to become a solution provider to large multinationals, where we are approaching them, asking them to give us problem statements that they have related to the field that we are associated within, and then ensuring that we do R&D for them, we create products for them, in lieu of them giving us manufacturing rights. So I guess we are initially at a position right now where you have to build economies, you have to have a CDMO and a branch model, you have to be extremely compliant and focused on quality, and ensure that you have enough clinical data around your products that you can bring to the fore. Then comes the step of doing differentiation and building products that are unique either to the market or to the patient, and then scaling those products internationally as well as in India, and keep on adding new verticals of growth. This is a bit of a complex business. You can't have one line that manufactures pretty much everything end to end. So we need multiple lines, we need multiple skills and capabilities, and we keep on harnessing them and we keep on building on that. So I guess that's the only way, but the fact is that with 4,350 companies, a lot of these companies will eventually scale up. A lot of them will eventually find foothold internationally, and you make larger businesses out of India and supplement the Indian business to keep on reinvesting in R&D or manufacturing or scaling.
Thanks, Satish. And I think you brought up a very important point, and that's why I think this is both, the provider and the medtech together on the same platform, saying that, and Marshall had also told me, see, looking at solutions, because I think what in India we have high-tech potential, but we have a low resource reality in a way, right? So you need to look at both. We're able to do it, but at what cost? Prashant, AROGYA, and we discussed this. See, in India we talk a lot about frugal innovation. We talk about the innovation of the product. But even with the innovation, you still need some financial innovation to happen. This has happened across all the industries. Right? So today, whether you buy a car or a TV, there are 100 ways of buying it. But today you buy a medtech product, it's either you buy it or you lease it. So isn't this going to be an impediment as it comes over? And how do you think we can get over this?
Thanks, Anna. So if you see all the advanced imaging equipment, all the heavy equipment that any hospital service utilizes is all imported. Our pitch is buyer to maker, OEM's pitch is smart is not maker. This setup will continue for quite a while if it carries on in the same fashion, because the market scale is not enough to manufacture. And for us, it is always going to be costly. One is better service, second is airport, utilities, and others materials. But I guess we can take learnings from other sectors like what auto has done. So auto had very high usually, again, very high ticket item. And then auto companies started different sort of mechanisms. What they started doing in CKDs, they started assembling here, gradually shifting a lot of components to the Indian suppliers, and then shifting the weight from a completely 100% assembled model to a semi-assembled, and now more and more assembly is happening within India. That is one way where the heavier equipmentation, which will continue to be a challenge for us as we go as the bet model will triple in the next 4 years to come. That will always be a challenge. So perhaps that is one learning we can take from there. Also, what the auto industry was very interesting because if you remember the car, loans which used to be there were a flat system, but the aspiration of the user to buy enabled the car companies to bring in their own NBFCs which were very flexible in their financing models. They started with low EMI, they started with ballooning, they started with bullets and all that. The whole concept being making it convenient or possible for the buyer to buy at their cash flow prices. Same issues with healthcare because initially in the first few years for the hospital, the cash flow challenge and a flat system of equipment will not serve it very well. So it has to be a step up, sort of hill, sort of ladder sort of thing. Second, I think that even if you look at the high cost equipment like for example airlines, they ultimately stopped selling planes and they went to leasing models. So perhaps as more technology evolves, as MRIs, which at one point in time used to cost $2 crores, now costs upwards of 10, 12, 15 crores depending on what configuration you're taking. If you take a planning machine, it can go to 20s and 30s of crores. So similarly, as and when the healthcare costs of the white goods or the larger equipment increases, leasing model, more flexible, more cash flow friendly leasing model, they have to step in. Otherwise, it becomes very difficult for the buyer to buy and etc.
Exactly. And I think the financial innovation, and we see it in every service, every product in India. So, Prashant, I thought that was a very important point that we need to also, it's just not making the product, delivering the services. How do you make it accessible over a period of time? So, Dr. Singh's explanation of the table, so I'll ask you something which I think keeps getting repeated. See in high volume Indian clinical setting, success is a race between time and cost, right? Patient is there, you save it. Now the whole thing is, for medtech to actually be there, it has to have a meaningful clinical outcome. A lot of people say you're putting a stent, you're putting two stents. This is the best. Where do we get that data to say that this was the best intervention for you, it was the most cost effective? How do you tell that to the family? Because once that trust grows, I think it will also create exponential growth in the medtech space.
thanks, Dr. Raman. I think one of the key points which you mentioned is like how do you build trust around the medtech, which is evolving much faster than what people are thinking about it. And I think since yesterday we have spoken enough, and I think it's going to be a never-ending topic in times to come for something on startups, innovation, and medtech. Having said that, but from a clinician perspective, all the people who are here, even in healthcare, clinicians and non-clinicians too, when you are utilizing some product or you want to introduce some product, your major focus is on what is the clinical outcome and whether it is going to bring the data in the clinical outcome. How it can be measured from multiple angles, the efficacy, the accuracy. These are the two most important aspects of it. How accurate the data will be, whether if you put a sensor today, the most important component is whether I am going to miss the readings on that. When we started working with one of the medtech devices, what was our first concern? When they said, you will be able to prevent the witness cardiac arrest. The question is, you are actually trying to challenge something in a setting, clinical setting, whether that device will actually miss that. So I had an interaction with those guys and I asked them, how are you sure that it will not mislead the heart rate and they will not miss out? They said, if they miss out, they will show error in reading, it will not throw the data, but at the same time, the one thing which is confirmed is, it will never give you wrong data. That you will never have a difference where the heartbeats are getting missed and you are actually not able to read the bradycardia for that matter or lower in the heart rate. So it means it gives you assurance that you will never ever miss the beat and you will never misinterpret. If there is a device fault at a particular level, it will not throw the data. So you are not depending. So once you get an assurance that the data which is coming from the device, you will be in a position to take a clinical intervention at that time. And over a period of time, we saw and we experimented and we put this for the last 6 months. I said this earlier, yesterday also, that we were able to prevent cardiac arrest in a clinical setting for 3 months in a row in one of our hospitals. So it means today we can say the device worked well, the data is accurate, the clinical efficacy part that we were able to create an environment of assurance where patient is not going to be an episode of a witness cardiac arrest in a clinical setting. So that's one part of it. The second part is when you are doing an intervention, what is the impact on the cost? Whether it is going to lower the cost of the treatment, will it reduce the average length of stay? Whether this intervention, in what form it is going to benefit the healthy patient. My point is very simple on that. If anything which you try to introduce in the healthcare ecosystem, if the ultimate beneficiary is the patient, that thing will succeed. That will become the trustworthy thing which people will adopt. It will have the impact on the cost, it should bring efficacy, it should bring accuracy, and patient should feel that whatever intervention is taking place is scientifically relevant and is going to stand the test of time over a period when the data is analyzed. So I think coming back to the point is, whatever data or intervention we do, the data should be accurate, it should help the patient in the clinical outcome or something which we can actually count over a period of time, and it should help in reducing the cost. It may not happen in the initial stages. The cost will come down over a period of time when the mass production takes place, when the utilization improves. And we have seen over a period of time that when the mass production takes place, more number of people basically start utilizing. There is obviously the economy of scale which actually helps you. So I think somewhere down the line, our endeavor as a healthcare provider should be to create the ecosystem, give enough chance to the medtech companies to basically test their product in the controlled setting so that you are not compromising on the clinical outcomes, and somewhere down the line we will be able to create that trustworthy medtech ecosystem coming out of India which world can adopt.
No, I think because it becomes important, and I think the words ecosystem should start with is obviously trust, because the more trust you have, more people feel if I do this intervention, it's going to add years to my life and valuable years to my life. That becomes very important. Secondly, I think the medtech's device's ability to, like you said, switch off. One of the cardinal principles of medicine we know is to do no harm. So, if you cannot do good, let's not do any harm. So I think that becomes, and that builds trust over a period of time. Mandeep, I go next to you. So, if you look at the way the government is moving in the last 10 years, the Indian government is predominantly moving from providing care to becoming a payer. So today we have the largest cohort, 500 million people in the world where insurance is being paid. And healthcare is about three things. It's about putting in the infrastructure, it's following the process, but it's at the end about outcomes. Now, as the government moves away from becoming a provider and payer, it will start looking at outcomes. Today, I think you do the process, okay, it succeeds, doesn't succeed, to a large extent, it's the patient's stuff. But we need to transcend that if we actually went to exit. So how does a company like Medtronic, which has been here for decades, actually capitalize this and set the new benchmarks for the exit?
No, thank you, Dr. Anand. Thank you for that question. There was one thing that somebody spoke in yesterday's AGM of NATHEALTH, which was that we know Viksit Bharat, if there is no Swasth Bharat. So I guess from that perspective, if we have to get to 2047 Viksit Bharat, the focus on outcomes is imperative, and the government leaning in that direction is a very positive sign. I think we also heard Dr. Raghuvanshi and Mr. Aman Sharma speak about quality control and standards. I think that's great. I think where we are adding to that, we're also adding to it in terms of really enrolling registries and producing good quality data. I think one thing that our healthcare system lacks today is good quality published data or transparency with which democratize access to healthcare can be provided. If you're not able to eat out of Rana or anybody on the stand, right? You go to a district or a dino or whatever, I have hundreds of reviews to trust. But if I need to get medical advice, I'll be calling Gautam Khanna or Ras Khanna, or if I need an interpretation of the report, I'll be calling Dr. Harshmajan. But it's not that you can walk in anywhere and everywhere today, right? I think that is the standard that we need to move to. And that will only come if we are really publishing good quality data and outcomes in a transparent manner. The other thing I would say, not only Medtronic, I represent all the multinationals in India, I think we need to be seen as an integrated part of healthcare where we are pulling innovation and driving patient outcomes. Maybe just a question to the audience. How many of you have had 45 years plus of work experience in India? We have. As a company, we have. And there are companies who have had much more than that. So that means we are not only here for just being presented as a commercial opportunity, we have been a part of the way the healthcare system has been shaped. As an example, yesterday in the parallel program, we had a stroke summit. Ms. Punia was there, the Secretary of Health. She had started that move last year. And yesterday, J.P. Nadda joined virtually, and Shri Pratap was there in person. We actually identified and have built over the last 2 years the pathway for stroke. How can we improve outcome for stroke? For people who are not very much aware of that, there's one death happening every 4 minutes. So since the time this panel started, 5 people have already succumbed to stroke, right? And there have been hundreds that have been diagnosed with stroke. I think that's the role that we need to play in terms of, and as Medtronic we are playing, in terms of having effective coalitions. A stroke coalition has a government, the state government, has an imaging partner, and has a clinician who is providing good care at the end of it. So I think that's the way we need to be seen like. Also, I think companies need to invest a lot in technology. I think you also mentioned that, be it Indian or a multinational. Last year, we invested about $2.5 billion globally. 500 million of that came into India for R&D to our engineering and innovation center. I think that's how kind of, really needs to grow. Once we can invest in the real technology, what makes sense for the government, I think that's where, the real movement starts. And that's how kind of, we should be looking at it. We are committed, I think all multinationals and all, he's also, complimented the quality vision. We are all about quality, we are all about patient care. We've talked a lot about cost effectiveness, but I think that somewhere we lost the impact of effectiveness. It's good to see that coming back. It should be effective, good value, and democratize access to healthcare.
Because I think in India we do run a problem. We are, while we talk about the demographic dividend, by 2030, 1 out of 5 people will be about the age of 60. We also run that most countries have actually become developed or rich before they become old. We could be one of the countries who become old before we become developed. That is if we don't, like you rightly said, if you don't have a source of blood, you won't have a mixed blood. Vishal, I go next to you, and I think one of the things that because you presented here to tier 3 cities is often we look at medtech from a very narrow point of view. This is what the neighborhood can afford, this is what I need to get, this is what I deliver, and these are what my margins are. And the secretary also alluded to that. So we looked at the unit cost procurement, not the total cost procurement model. But any AI is beginning to change that, both on the clinical and the administrative side. And how can we really use that to leapfrog to the next generation?
So I think when we talk about the recent development and everything is latching on to the artificial intelligence tool, even medical devices, I think there's a lot to do with the device connected EMRs. If you look at the basic level, I think still a lot of hospitals lack EMR where connectivity is very good. Of course, some big corporates, major clients would have that. But I think a lot of, if you look at smaller towns or standalone hospitals, they would lack the EMRs which are connected. They would have some devices, but they would not be connected. So I think it pulls down the efficiency. Secondly is, when there is a medical device approvals, definitely the software which is embedded in the medical device, or what we call as SIP, is a part of the licensing process. But with progression now, you have a lot of software which is medical device. So SAM concept is catching up very fast, where you have, with all our mobiles, we have tools which are monitoring tools. Some of them are effective, I don't know what effectivity where it has been, whether it's been tried on Indian context, whether it's foolproof. So all of us use it. We feel that we are using and we are being health conscious in that direction, but I think it needs a lot of regulation. Coming back to the point of tier 2 and 3 towns, I think it's important that the cost consideration are streamlined because insurance is a player, even for major corporates. I think that's a concern when you get a technology and you don't get the payment out of it. You want to do a lot of use of advanced technology, otherwise the payer doesn't support it, and it's uniform for all the payers across. So I think that's a major concern which is there, which needs to be addressed. And I think we all already discussed many times that insurance sector as such definitely I think needs to work synergistically with the healthcare to bring about technological advancement, including medtech, AI. I think it will be becoming very, very crucial. Seeing it from a pure financing perspective, definitely I think it's a burden when for the hospital, especially a standalone hospital, when you have to invest very high in technology which the ROI is not going to make sense. And as Prashant told, the technology, especially the large ones, are really heavy and the ROI is a major concern. So that prevents hospital owner or standalone hospital to invest into the high technology. So I think that's a barrier that we all need to navigate as an industry need to navigate.
Yeah, and I think you brought up a very important point. I think the player needs to also know what to pay for. So it shouldn't be that robotics gives you much better outcomes, is much more precise, but you're doing the older one just for the simple reason that the payer is not paying for it. We have just one more balance and that goes down. So finally, I have to be honest, sorry, running against time. So I think the interesting point when we spoke was that we're looking at this whole value-based care over a period of time, especially again. And we're looking at how does medtech look differently. Today you're just looking at medtech from that. But how can medtech actually be a productivity multiplier? It gives you a differentiation in the tier 2, tier 3 city where you may not have the same clinical talent, but again, your outcomes are the same.
So, medtech definitely going to redefine the way that healthcare are being delivered now or in the future. Right? It's going to be a game changer, particularly for tier 3 cities or even for providers who are tested in working at tier 2 cities. Because if I able to solve the issue of A, accessibility of those high, doctors or without too much of infrastructure. B is it also reduces some kind of it brings affordability to the patient because I am reasonably competitive pricing at a particular reason. And third is definitely it's about the kind of life we save. I mean that is actually real impact. So medtech, believe you me, if you really, the issue is with the implementation as well. It's not that easy to do because it's just not only the medtech, it requires probably a local ecosystem, it requires a bit of policy and also about the financial modeling or what you do. But if you can have a better monitoring to your operational efficiency, your clinical efficiency through the various measuring of clinical indicators, and of course third is it's about the financials modeling. All these things are probably going to help a provider and ultimately you pass into the last leg of the beneficiaries.
I think that's important, and I think the tier 2, tier 3 cities are the new frontier. So I think just to conclude, and I'm sorry we won't be able to take any questions. So it's obviously a marathon to 2047, we need to keep running. But the way I did the panel, it was more like a 100-meter sprint. So apologies for that. But I think that if we get this right, I think we get boundless opportunities in the borderless world. So I think we need to get it right. I want to thank all my panelists for being patient and really bringing out great insights. And I want to thank all of you for being a wonderful audience. Thank you.
Thank you very much indeed, sir. May I request all our dignitaries to come forward in a group photograph. We will now straightaway move ahead with the proceedings of the next session, which is session 5, titled Financing Healthcare at Scale, How India Can Expand Access and Affordability. This important discussion is supported by our knowledge partner, Indian Capital Advisors Private Limited. And to guide this session, it is my privilege to invite the session chair, Mr. Varun Khanna, Secretary, NATHEALTH, and Group Managing Director, Quality Care India Limited. Let's put our hands together to welcome Sir onto the stage. Ladies and gentlemen, it is also my pleasure to invite Mr. Aryaman Tandon, co-founder and managing partner at Praxis Global Alliance. Very warm welcome to you, sir. We invite our distinguished speakers, Dr. Harsh Mahajan, Padma Shri Awardee from 2002, past president of NATHEALTH, and founder and chief radiologist, Mahajan Imaging and Labs. Warm welcome, sir. We invite Mr. Gautam Khanna, Governing Council member of NATHEALTH and Chief Executive Officer of PD Hinduja Hospital and Medical Research Center. We invite Dr. Ankit Thakkar, Governing Council member of NATHEALTH and Executive Director and CEO of Jupiter Lifeline Hospitals Limited. We invite Mr. Sunil Thakur, board member of NATHEALTH Foundation and partner at Quadria Capital. We invite Mr. Jayanta Rao, Managing Director at the Peerless General Finance and Investment Company Limited. And our moderator for the session, Mr. Nitish Agarwal, Managing Director and Chief Executive Officer of Indian Capital Advisors Private Limited. And to begin the proceedings of the session, I invite Mr. Varun Khanna, Secretary NATHEALTH, for the opening remarks. Ladies and gentlemen, let's welcome Mr. Varun Khanna for the opening remarks.
Good evening, everyone. So it seems the number of people on the dais and the number of people on the audience is almost the same. That allows us to finish the session early. Yeah, a lot of people have been telling me that if I finish the session early, then they'll fund my flight back to Hyderabad. You know, this session today, and we prepared a lot, by the way. This session today feels like we are the CFOs to the first session that happened in the morning. The first session, to remind you all of, to all of you, is Parijat coming here and saying that if we do it right, we can save $1 trillion, or rather increase the GDP of the country by $1 trillion. And then he gave us a plan of how to move the new concept of HALE and how to move the HALE up by 10 years. And he spoke about all the right things, got the applause, had a full audience. And then he leaves the thought of how do we bring the money to make that happen to all of us. So that is what today's session is all about, health financing. I think the second part that I want to touch upon, you know, it's a little bit of a moving goalpost. Why do I say so? 50 years back, and a lot has been spoken about this morning as well. 50 years back, the average age was, let's say, 27. So it was a no-brainer we'll get to 50. Right? Today we are 73, and by the way, mind you, I honestly believe that India has done a great job. By spending $70 per capita, which is 10%, 12% of what China spends every year, we've achieved the average age of 73, which is 2 years lower than the US, which actually spends $14,000. Everyone correct me if I go wrong with the numbers. I'm actually quoting much of it from this report. We spend, let me tell you again, this is a little bit of a magic, I don't know how it happens. The Indian system is so frugal and powerful and effective that what we are able to achieve in $70 per capita is 2 years less than what US achieved in $14,000. So I think that's what the power of healthcare is doing. And I think we should all start with a big round of applause for whosoever is here in the room, because we've done it together. Now I'll tell you a little bit of a dichotomy in my mind, and probably ask a question as well to the audience. How many of you know what the average age will be 10 years later? If you were to predict today, because the maths of healthcare, all of the funding piece that we're talking about will depend on how long will we live. Because the longer we live, the more we spend. Agree or disagree? The longer we live, the more we spend. So tell me, what will be the average age of this country 10 years from now? Do you agree? Do you all agree it's going to be 80, 85? Is it going to be 100? Are we getting to Japan standards? 90? 80, good. So I'll tell you something about it. Each year, try answering this question. Every year from now, and Rana, you'll do a great job of it, I'm sure. He'll figure out some maths around it, and a week later he's going to come back and we see I figured out the answer. With what is happening, there are two things that's happening in the world. One, pharma is changing. Who knew GLP will come in and do magic to the world? No one knew about it. And a large part of us have been talking about NCDs. I mean, last 13 years that NATHEALTH has been into existence. The previous secretary and the current secretary have been talking about NCDs, right? If you were to inject the GLP and take out diabetes from this country, you don't need to think. The average age will go up by 20 years. With what AI has the ability to do today, I would be surprised if the GLP formulations in many other diseases actually get scaled up much faster. I'll give you to understand that to develop a new molecule, which used to take 20 odd years in the pharma world, today you could do it in a much shorter span of time. So with 2-3 more interventions, and if NCDs can be taken out of our life, we'll all be living beyond 100. And we all, anybody who doesn't want to live 100? Okay, I knew there's one man who will raise a hand, he did. But we will not take cognizance of that because we want to live longer. If you were to live, then all of the maths that I've done for this session today along with Arun, I think we'll go for a toss. Because we've all imagined that we need $700 billion, or the industry will go from 300 to 700 because we're going to live X number of years. But guess what? Each one of us in this room, each one of us in this country, each one of us on this planet want to reach that number. Because no one wants to die young. Right? So with that moving part, we will try and assess today as to what we can do. A little bit of data points, and that is something that we intend to solve for today. So while the country has done enough, and I won't harp about that, let me get to what we are. We are about a 300 billion industry today. On a do-nothing basis, we'll go to 700 billion, which is fantastic. If I look at to achieve that 700 billion, we need 200 billion of capital expenditure. The industry needs $200 billion of capital expenditure. The industry needs 1 million more beds in the next 5 years. And I'm only talking curative healthcare currently. I'm not getting into diagnostics and wellness. The industry needs 1 million doctors, which I'm given to understand that we have 125,000 seats per year. So we'll get 1 million doctors. But let me go back to the number again. The capital expenditure number is 200 billion, and we have only got sight to about 40 to 50 billion dollars of capital coming in if we continue to pump in the amount of capital that we're pumping these days. Any change to that brings down or shatters the dream of we getting to 700 billion in the next 5 years. But there is also an optimism to each one of our thinking. That is that if we do another 5 more things, and that is something that we will debate today, we could get to $1 trillion also. So let me tell you what those 5 are. Our ecosystem today is quite fragmented. If we could do something about it, it will help. If we are able to enhance universal coverage, and today we were at a media briefing a while ago, and the MP was there, all of us were defending the same question. Every Patrakar's question was, हम इतना कम क्यों खर्चते हैं? And we were trying to figure out कि ज़्यादा खर्चे कैसे? Because the government can only spend so much. The missing middle is still not doing the insurance themselves. Insurance companies haven't grown. I don't know if many of you know, but the private insurance, the GI, has a negative growth rate on reimbursement in the last 7 years. A negative growth rate. If it was not for GIPSA, which is about 9%, the overall industry would have gone into negative growth. Right? So I don't know how are we solving for that missing middle, but we'll have to solve for that. And that's the efficiency of coverage. Another piece that we don't do, and I think there's much to be done about it, is enhancing the outcome quality. Now, a lot of us have spoken about it. Clinical outcomes need to get better. We are not still in a position as a country to report clinical outcomes. But there's one thing that I've been harping on, and I'll say it again. Do you all remember the campaign called Jago Grahak Jago? You don't? No, there's a campaign on eggs, there's an campaign. You remember the campaign on Agmark? You all remember? All of those campaigns did wonders to the country. It actually brought awareness. And today, what we haven't done so far in this country is create awareness of what patient rights are in this industry. I said this earlier as well, not many of us have the ability to go and ask a doctor, Doctor, how many procedures have you done of this kind in the past? What was the clinical outcome? Rajiv, I don't know how many people have walked up to you and said, how many surgeries performed and what's the clinical outcome that you had? Right? So I think that's another big need for the country, for us to scale up. And the last part is, let's figure out the financial infra. I think we'll have to continue to invest more to develop the financial infra so that we can develop the infrastructure for healthcare. So that's, I think, where we see the industry move from 300 to $1 trillion. I think I'll let Arun take the balance part of the panel, along with Nitish, our friend from India. So over to you to figure out how this $200 million funding and how an outcome of $1 trillion of the industry will happen over 5 years. So thank you so much and have a fab evening.
Thank you very much indeed. And now, ladies and gentlemen, I would like to invite Ms. Arun Tandon, co-founder and managing partner at Practice Global Alliance, to kindly set the context for this session. Over to you, sir. I would request you to kindly do it in 3 to 4 minutes.
Well, good afternoon everyone. Although Varun has sort of already spoken about all the highlights of this paper, but what I'll do is I'll try to set the context for this very critical session. Today we've already launched the report. It's been a very comprehensive piece of effort. Thank you for everyone who has actually supported to bring together these insights. I'll talk about a couple of key findings which sets the context for today's conversation. The whole moot point of this report is this. India today represents about 20% of the disease burden globally, but it spends only 1% on health of global expenditure. If we let that sink in, that's 1/20th of what the demand is. It only spends 1%. Whether you look at financing, whether you look at expenditure, we also represent, and we'll soon represent about 15% of the global elderly population. What we're spending is minuscule compared to what we need to spend. And also, Varun, you spoke about the $700 million ecosystem. We will be the third largest economy by 2030 or so, but we will still be the world's 6th or 7th largest healthcare ecosystem, far away from being the third largest. 1 trillion is no magic. At 1 trillion, you're only the third largest economy, healthcare ecosystem in line with the economy. Another critical thing to understand is, although we deliver cost-efficient care at scale, this model is getting challenged a lot. We're seeing provider costs go up at about 7 to 8% year on year. CapEx go up about again 7 to 8%. And what you see is health inflation has actually been lower or in line with CPI. So a lot of these cost pressures have been absorbed by providers yet. And this will soon reach a breaking point if we don't do anything about financing. Although this might look negative, but I think this is fairly a big opportunity for us. By the way, provider and insurer is not one of the most lucrative investment sectors for private or public investors. We compare the return on capital and investor returns for the largest listed players in various sectors, and we are far behind what the actual returns need to be. While we talk about financing, insurance is a major component of financing. We are extremely subscale when it comes to health insurance. The health insurance premium collected is only about 0.5% of GDP, which is even lower than countries like Kenya and Zimbabwe. We're not even financing as much as they are. While a lot of leading economies and mature healthcare markets do almost 4 to 5% of GDP of healthcare financing through insurance. And that also reflects in the key performance metrics of insurance, whether we look at medical loss ratios, we look at distributor margins. A lot of this value is not being given back to patients for health benefits. This is actually another very interesting analysis where we did. We compared the composition of total health expenditure by markets. And what you see, the red segment here, is mandatory insurance pools. Across all major economies and maturing as well as mature healthcare markets, we see that 50 to 70% of expenditure is pooled from mandatory insurance mechanisms. But in India, that number is only 1%. And if we let that sink in, two-wheeler TP insurance is mandatory, but the basic health insurance coverage for an individual is not mandatory. This is how far we are from unlocking health insurance as a truly big financing lever for the ecosystem. We looked at a lot of interesting markets. A lot of countries have solved this very intelligently, innovatively, through various mechanisms, and we can do it too. In the report, we also examined, we want to talk about 4 pillars in this session, which truly unlocks insurance: efficiency, access and awareness, driving quality of outcomes, how we publish those outcomes, and also doing that sustainably, both for the provider as well as the payer. And on top of that, how do you leverage AI, digital, and technology to truly be world class in how you're financing healthcare? We've seen and we analyzed a lot of international markets. Insurance has played an extremely pivotal role in transforming healthcare, from driving standardization of care, quality, data, digital interoperability, to a lot of accountability and publishing of outcomes by providers. That's what insurance has done, and that's why we have to treat insurance very seriously. I will not go into this detail, but the report is extremely forward-looking. We talk about 12 key recommendations which we want to move towards from payers, providers, and regulators, which will actually help insurance truly unlock the healthcare ecosystem value. Thank you, everyone, and I pass on my sincere thanks to all the contributors for this report. It will be out at the NATHEALTH website. Please do have a look at it. And I'll be happy to connect for any perspectives. Thank you.
We are very privileged and delighted to have the founding chairman, founding president of NATHEALTH. We call him affectionately Chairman, sir. Sir, thank you so much for taking the time and gracing the 12th AROGYA BHARAT Summit. We have Dr. Mahajan, Mr. Shivindran Mohan Singh. Sir, it will be our delight if you kindly come up and say a few words to the audience. Thank you, sir. Please put your hands together for Dr. Pratap Reddy. Yes, also the highest number of national past presidents in one conference today, ever in the 12th conference. Thank you.
I'm so happy to be here, to see this, and I had this vision, and today what you have done is something which I admire from my heart. Hearty congratulations for all this vast presence and each one of you, and we are together as one. As one soul, we are now one healthcare soul. We've got all. There are many things, people don't realize that health is very important. It is about sake. But what we need to say is, we want you to be healthy, we want you to make a significant impact for you, your family, and the nation. And today, we're talking about saying for the world. Well, in that way, thanks to all the participants in healthcare, I'm proud to say, as I registered the Prime Minister saying, we must declare India as a global healthcare destination. And gave me steps. He agreed for all that and changed the name to Heal in India. And then global workforce, India can give the doctors, nurses, the technologists, the pharmacists, the pharmacists, specialists, as member of former Prime Minister of UK saying, Dr. Reddy would have been broke, but for the Indian pharmacy. So I think this is why each one of you have played a very significant role. I feel so happy to hear this, that we have all come together to make a difference. And there's something difference were made in other people's lives. That is the biggest thing that we all have. This is my happiness to see all of you here from different sectors of the world. Like I read the pastors in Kosilla, who were married and the first the secretary that we had, all of you. I made it now and saying, we have come this far, but we won't stop anymore. So there are many, many things that are happening in transition, in transformation of things. It's not just changing, it's being healthy and happy. And that's what is different. And that's the kind that we all have. That we have contributed to so many different families, good health and happiness. And I can only say, I feel so happy to see this also. We were hardly 10, 20 people when we met first 2 years. And today, the healthcare together we made all the activities. We have a long way to go. We've done so many wonderful things. That means you know that you are very strong. So when you are very strong, there is no limit to the achievements that you can have. So let's plan that. I can go on, but all that I want to say is I'm proud of all of you. I'm proud to walk into this room. What I've been hearing from the past presidents, what they have done, and today sanitizer is the president. All of this together is not one person. It is ours. We are proud that we have done this, and we have made this difference to the nation. That is what we do. If you really walk in today, is to create Indian healthcare. As I said, they are so proud of people from all over the world are coming to us, and more are going to come. This is why you all made that difference. God bless all of you. I love you all.
May I invite all the past presidents to kindly come up on the stage. We have this opportunity of having with us Dr. Pratap Reddy, and we want to make full use of it to have this very iconic picture as already announced. This summit has the maximum number of past presidents present here. Ladies and gentlemen, what a pleasant surprise to have Dr. Pratap Reddy here with us, founding member of NATHEALTH, and who is also widely regarded as the architect of the modern Indian healthcare. And what maybe all of you may not be knowing, he's been awarded, he's the recipient of the Padma Vibhushan Award, the second highest civilian award in India. Thank you very much, ladies and gentlemen. A huge round of applause for Dr. Pratap Reddy. And we would now like to invite all our eminent panelists back on the stage, as we would like to continue with the proceedings of the panel discussion. Inviting all our eminent panelists to kindly join us back on the stage, and our moderator, Mr. Nitish Agarwal, Managing Director and Chief Executive Officer, Indian Capital Advisors Private Limited. I would request you all to kindly quickly take your seats as we have very less time left for the panel discussion. You have the timer in the front. Almost 18 minutes left when you can have your discussions. Over to Mr. Nitish Agarwal, sir, to kindly carry forward the panel discussion. And sir, kindly be mindful of the timer in front of you. We are running behind that. Thank you, sir.
Yes, what a pleasant surprise to see Dr. Reddy. We'll jump right into it. We talked a lot about healthcare, and we kind of always talk about what needs to be done, but what we need to keep one fundamental thing in mind, that healthcare is one of those industries that's like food and water, where the need will always exist. The question is enough supply to cater to that need, and can it be financed? So we have an excellent time to talk about healthcare financing and how people can actually take, finance their healthcare needs, as and when it comes up. Because of policy of panel, switch this around a bit. I think Dr. Mahajan needs to speak. I'm going to start with him first. Dr. Mahajan, I'm going to come to you from a OPD insurance point of view. A lot of people look at imaging and diagnostics as an essential part of treatment whenever you fall in OPD setting. A lot of people still end up postponing it, not doing it because there is no OPD insurance. It's totally out of pocket. And you see a lot of such people in Europe. On the other hand, provision of services, diagnostics, imaging is extremely capital intensive. You need to continue to advance it. It requires money. Making it affordable is not really that simple in the short term. What are your thoughts on how this can be done? Will OPD insurance take off in India? It's still a very, very minuscule portion, lower than IP. Or are there other needs of getting to this kind of financing in the OPD sector?
Thank you very much for that question. The fact that even for inpatient, the insurance is so limited, it seems unlikely that on scale there's going to be OPD insurance happening in this country, maybe in the next 3 to 5 years. Seems quite less likely. And considering that nearly 80% of all treatment decisions today are based on diagnostics, so there is no way that one can go away with diagnostics. The patient doesn't accept it because they want to know what problem do I have for which you're giving me medication. And of course, the coming generations of doctors are so dependent on diagnostics, and maybe rightly so, that they would also not like to treat without knowing what the problem is. So diagnostics will remain, at the center of healthcare delivery system. And hence, that's why mostly it is out of pocket today. It would be wonderful for the patient as well as for the sector as a whole if there was to be OPD insurance. And there is no doubt many people keep postponing a decision for diagnostics unless a disease becomes very serious. So it is a need, but frankly, if you ask me, it's not happening very soon.
That's unfortunately where we are. I'm going to just jump back to Varun. But on the macro level, we talked a lot about this. We have a really high share of the disease burden in the world, yet we spend only less than 2% of our GDP, etc. You could become a double or what have you. What are some realistic macro levers, right, that levers, providers, and ecosystem partners can really move to expand the coverage? Is it lower cost models? Is it expanding healthcare coverage far beyond what it is expanding at the rate? Is it employer coverage? Is it other sources of capital? What needs to be done? What are realistic levers to expand this many-fold?
Thanks. I think, let me first go back to your previous question and say that if we don't start covering OPD, we will never be able to meet with the burden. Right? I think we are at the curative phase today. And the curative burden cannot be handled by the country unless the wellness burden is addressed. And therefore, I come from the school of thought that we have to in terms of absolute numbers, go on to insure themselves. If it was not for the family floater and corporate cover, India would have seen a degrowth in terms of total insured populations. I think it's not working. It's not working. A lot of people are depending on the government schemes, and that cannot drive healthcare ecosystem. 3-4 things that one can think about it. There's a debate every day that NATHEALTH results. What can we do? Can we keep a small sliver of the banking funds and say, please invest in healthcare? And mandate the coverage for insurance. I'm saying mandate. I'm going to the extent of saying that somebody has to say, this is income tax for you. Right? You got to pay, figure out a channel to get it to right use. I'm not saying that wrong use should happen. But if we don't do that, all of what we're talking about is not work out, right? The second part is, I think there is a lot of CSR fund that's going to be deployed. I sometimes wonder, again, I'm no one, Dr. Mahajan is an authority on this, but I would think, चूहा जरा के पैसे तो बांट तो सकते नहीं, and healthcare to me is चूहा जरा. Every Indian's health comes first for everything else. Anything else. Can I use that money for it? Today, millions of patients are going undiagnosed of cancer because of no access. We did a remote UP project, huge success. So, I think there have been many ideas across here. I don't want to solve for it. I can't solve for it. But I think we have to start thinking outside the box, take difficult calls. Because this gap is 200 basis points on the GDP. The 3.8, if it gets to 6, I don't think we'll be able to solve that region, which is required to fall.
Thanks for that. I think the scale of the problem is still large. India healthcare has made a lot of progress in the last decade. Let me shift gears again a bit. Gautam, let me come to you. You've been leading meetings with us in Dubai for a few years. And as we understand, you have a very unique model where you, on the one hand, charge market rates to patients who come in. And then you use the margin that you make from there to address the economically weaker patients side. And yet you make sure that the quality of service for the economically weaker patients is almost as good as the one on the other side. That's a very unique model, almost not self-sustaining. What's been your experience? Is this model scalable beyond your hospital, hospitals, or in private hospitals that matter? What are the pitfalls in doing this? Or are there other ways to use this self-running engine to address the economically weaker sections without having, let's say, a significant expansion over your IP cover? What's been your experience?
Thank you, Nitish, for asking me this question. So, since we are a not-for-profit trust hospital, we really have no pressure on dividends. So that is one perspective one needs to keep in mind. So what we do is that we have 20% of our beds which are for free and economically weaker sections at professional rates. And the balance 80% is as per the ability to pay. And so the cross-subsidization model works. So the people who can afford a suite class and they want privileges and services for a suite or a deluxe category will pay as per that. And then we plow that back for the people who cannot pay free. So that model has been working. The unique thing why it works and is sustainable over decades is that there is no difference in the quality of medication. I mean, drugs are the same, the doctors are the same, the nurses are the same, the AC is the same, so everything is the same. So it's not that just because somebody is free is getting a shoddy treatment or, so that is one key difference. That's why people have trust in it, the patients rely on it and the system is working. The other challenge on this system is that since we want to make it a long-term sustainable model, you have to make it financially sustainable. So sometimes people might say that why are we charging market rates for BLS category, etc. But I think that's the way to go. But I just want to point out one thing you mentioned about the trust and what Parijat mentioned in the morning, and I don't know where it is, but I talked about is not going to happen only when the hospitals doing clinical delivery like how we are talking about. It also needs research, it needs funding for research, and sometimes the trust funds are the ones which help in putting some money for advancement of research and sciences, which is beyond the immediate objective of healing the patients today. So I think that model is scalable. Now it needs funding. Like Varun's suggestion about CSR, and I mentioned that earlier, that the way you have mandatory vehicle insurance, you should have mandatory human body insurance, so that you have, and part of CSR or majority of CSR comes, we can get more trust hospitals to grant, to focus on the delivery, focus on the quality, focus on the research, good for the future of humanity and
Thanks, Oliver. Let me come to you, Jayanta, next. You are the promoter and head of the peers group in Kolkata. I think you uniquely also have a perspective of both the financing side and the delivery side, because you are both businesses amongst others. So just want to hear your thoughts. We also know that, especially in the eastern side of the country, many patients rely much more on out-of-pocket spending for healthcare. And when such an so unfortunately happens, it's a big economic shock. So from your perspective, what kind of financial products do you see that side as well? Because actually work which would be scalable, which would prevent families from such devastating shocks, not just regular healthcare needs, what's been your experience? Love to hear that.
Thank you, Nitish, for the question. This is very real. And if I may simplify, medical shock is not just a health issue. It is a financial shock to the household balance. And this perspective comes from an earlier journey of helping protect a million lives while I was dealing in insurance intermediary. In healthcare, in my view, complexity is the biggest issue for the family, and therefore the protection must come here. First, comprehensive insurance, not just hospitalization, but the full journey in terms of diagnostics, pre-post care, and illness. Because the real cost is not the event but the continuum. Second is hospital cash and micro protection. Because a large part of the distress is non-medical cost. Attendant cost, their travel, daily sustenance, and small ticket SIP mutual fund products. I have seen in my experience while being a distributor, create disproportionate relief. In fact, it really preserves their dignity. And metaphorically, it is really mutual fund is sahi hai for them. Because alternative is unorganized microcredits. They will charge 3%. And third, I guess, is the public schemes like Ayushman Bharat, Shastri Shati or West Bengal, because they are the foundation for the vulnerable. So in a sense, we don't just need products. What we need is an ecosystem of financial resilience to reinforce the household financial balance sheet so that they can minimize the emotional shock and they can come back.
We have more time to go down deeper on that, but let me go next quickly to Ankit. Ankit, you also run Jupiter Hospitals. You are one of the best hospital care provider in the geography. As we've been discussing, medical insurance is often expanded beyond traditional models in UOB as well. In India also we are seeing employer-led health coverage become one of the faster growth segments, even though small ways. Varun mentioned CSR as well. Just want to get your views while you serve a lot of corporate and insured patients. Are these avenues which will or can expand significantly from a healthcare financing point of view? What is your view on that? Thank you, Nitish.
So, I think employer-led
coverage has made good beginnings, but I think there's still a lot more to be done on that front. Arun has been talking about the missing middle way, and Gautam also spoke about increasing insurance coverage. I think there are parallels globally which you can tap into. South Korea has done it very well, Taiwan also to some extent. Mandatory employer-based insurance, I think, would do a great deal in ensuring expanded coverage as far as India is concerned. Currently, it is just a perk provided by large employers. But I think a regulated, mandatory employer-based insurance would do a great deal. The government, to some extent, with Ayushman Bharat, has signaled an interesting intent, that is to move from being a provider to a payer. I think there is potential to double down on that. Maybe introspect a little bit that what are we doing as a country with the entire ESI framework and how efficiently that is being done. Can all of that transfer into a formal insurance system rather than continuing with these frameworks? And once a lot of these things play out, I think the math will just take care of itself. For example, telecom in India is the cheapest in the world. In India, we pay few rupees a GB, and US even now pays some 500-600 rupees a GB. The reason is the large denominator. We have power of masses and power of numbers. Once you have a larger pool of insured population, automatically the risk gets divided, the insurance will naturally get cheaper, which would then fuel demand from the retail and the individuals as well. So I think broadly speaking, an improved coverage is the way to go. It is a wrong aspiration to have to think of healthcare service being affordable. It is not affordable anywhere in the world. The only way to make it affordable is through coverage and through the insurance.
Thanks. So let me come to you. You've been a prolific investor in healthcare for the last decade or so, perhaps longer. A lot of your investments have been on the supply side, on providers. How have you discussed this, like I've said, for a long time? There's a big gap between, on one hand, private insured patients, on the other hand, government insured patients. There's a big middle. How can that be addressed? From an investor perspective, what are some of the models that can work? Where can private capital play a part in furthering some of these models? Do you see any opportunities there? Do you think that time is up for private capital to work on those? What are some of the constraints you see? I'd love to get across.
Thanks, Satish. You just had 8 seconds for me to respond. So quickly, for us, the two big models that we're going behind as a private equity investor is preventive care on one side and health financing on the other side. I always point that if you keep your population healthy, the chance of them getting to the hospital is less. And we see opportunity across the preventive and curative care. And I'll just share some examples of what we are doing, which most people may not know. So on the OPD side, we have a strong thesis. In fact, we have investments both from our private equity fund and from our venture growth fund in 2 companies that has scaled OPD insurance. So we have MediBuddy from Portugal, which has about 11 million subscribers on a closed loop OPD ecosystem, which is consult, lab, and pharmacy delivery. We have a similar model through our venture growth fund called Health Board, through which we invested in a company called Care. And these companies are scaling at 20.5%. So this model of OPDs here in India, so far it's at an enterprise level, because again, at a retail level, the risk pooling is not reasonably priced. It's sort of retail model becomes very, very expensive, and also there is an element of fraud. So unless you have a closed loop ecosystem, it doesn't work. On the IP side, to address the point around the government is ensuring the bottom end of the pyramid, and you have group insurance and obviously the affluent class having private insurance, but that's in the middle of 40-50 crores. That's missing. So from our perspective, we do have models again through our venture growth fund company called Impact Guru. The way they are addressing is the OPI model that will succeed will have to be closer to a co-pay. Now the source of funding can be different. It could be, a sliver from the government, sliver from the employer, the tax benefit, and then you have a co-pay, which is where the individual can sort of buy a product to sort of take care of any expenses beyond what is covered. The other model that we've been seeing, which is working in different parts, is the affinity model, especially for gig workers, that means sort of a large part of the population and underinsured or uninsured. Affinity model works very well. You tie with NBFCs who are providing loans. They are offering an insurance product because they can pull in that kind of subscriber base and do subvention to bring the price advantage to the consumers and can sort of loop in the aggregators to get price advantage on the hospital side. So there are models. We are very bullish both on the OPD IP. We are also bullish on the entire insurance stack. So right from your distribution rail, could be physical, could be digital, to your underwriting claims, to your fraud management. All these throw up a lot of opportunities for investors like us.
So I think we are unfortunately short of time. We have a prolific set of speakers. We wish we could have another hour to go, but I think we are out of time, so we probably have to call it here. Thank you so much for everybody to be on the panel. We hope to continue the conversation online. If somebody has any questions, we would request to take it online so that we can call it a day. Thank you so much, everyone.
Thank you very much indeed, sir. Let's put our hands together, ladies and gentlemen, as I request for a group photograph of the panel. Thank you very much indeed. And ladies and gentlemen, with that, we now move towards a very special address of today's summit. And we are honoured to have with us our special guest, a distinguished leader from the Government of India, Shri Madhukar Kumar Bhagatji, Joint Secretary, Ministry of Health and Family Welfare, Government of India. Shri Bhagat is a senior officer of the Indian Revenue Service, 1995 batch, bringing with him decades of rich administrative experience across governance, policy, and digital transformation initiatives. In his current role at the Ministry of Health and Family Welfare, he plays a pivotal role in driving India's digital health agenda, overseeing the key domains such as e-health, telemedicine, electronic health records, data centers, and standards and national digital health platforms. He has been closely associated with advancing technology and healthcare transformation, including strengthening the digital infrastructure, promoting interoperability and enabling data-driven governance across the healthcare ecosystem. So ladies and gentlemen, please join me in welcoming Shri Madhukar Kumar Bhagatji for his special address.
Very good evening to all of you. Respected Mishra Sir, former Health Secretary, members of NATHEALTH, members of the industry, leaders from the hospital, and all who are present over here. Thank you for this opportunity to meet. I would say that around 5 years ago, there was a shift in the Government of India policy, in the society, and in the general approach towards digital health. When we talk about digital health, we often think about areas such as telemedicine, we think about AI, we think about the IVDM, Ayushman Bharat digital mission, and when we think about these issues, the areas which come to our mind is essentially ABHA, Ayushman Bharat health account. We also think about interoperability. We also think about that the wearables, the point of contact devices, and these are some of the areas which come to our mind when we talk about the digital health. Digital health is playing an increasingly important role in our lives. That is for sure. Now, there is hardly any day that we are interacting with the health sector and we are not interacting with the digital platform. You see people who are wearing the wearables, the watchers who are watching the vital parameters. We see people who are monitoring their health parameters, whether it is the sugar level, the glucose level, the BP, etc. But then let's take a step back and see how has the industry or how has this sector progressed. We come to 2020, we come to a phase when COVID struck India, and that is when our dependence on digital sector became more and more important. It was not only in the health, but it was most profound in the health. Whether it was education, whether it was entertainment, whether it is socialization, all was moving towards the digital sector. But as far as health is concerned, everybody was dependent on one form of the digital health for it, or the other form of digital health for our own health needs. But you will be surprised to know that digital health had been making progress since quite a long. SGPGI Lucknow had a whole vertical of digital health as early as 2003. In 2017, Government of India came with the digital health policy. And as a result of that digital health policy, we had the AVDM framework which had come. As a result of the AVDM framework, we look at the elements of interoperability. We look at how there has to be a basic digital identity. And that digital identity has come in form of Ayushman Bharat Health Account, which is called AHA. AHA is again derived from what we call Aadhaar. Based on Aadhaar, we generate an AHA. And over a period of 5 years, the Ayushman Bharat Health Account system has generated nearly 870 million or 87 crore AHAs. The vision of our Honorable Prime Minister was and is that the citizens of this country should be mapped on their digital health system. Nobody should have the need for the purposes of even carrying their physical records. And therefore, from the physical systems, we should be able to transfer ourselves to the digital systems. I mentioned that one of the fundamental building blocks was the Ayushman Bharat digital system, which provides us a framework. And in that, the most important element was creating an identity. We have seen the significance of identity. We saw how our Aadhaar came up. We understand the significance of PAN in the taxation systems, in the banking and the financial systems. We understand that the JAM Trinity came and it revolutionized the fintech, which has been an important ingredient. And therefore, we have to appreciate and understand that AHA plays a very significant role as far as our own health systems are concerned. Now, we want interoperability. What does interoperability mean? There are different health systems, there are different units, there are different hospitals. And we cannot have a uniformity of a single system either. Why we cannot have? Because the greatest challenge over here is that our health sector is divided into 3 distinct verticals. We have the central government health systems, we have the state government, which is an important player, and then we have an equal strength of private sector, which is almost the 50% of the sector. And therefore, we cannot have one single system, and therefore, interoperability becomes extremely important for us, that the record should be transferable. Now, how do we go about this interoperability? We have created the framework of AVDM 1 compliance, 2 compliance, and 3 compliances. What is AVDM 1? That whatever our health management system be, that should have essentially AHA inseated in it, or should have the capacity to generate AHA. The second level says, okay, the record should be mapping AHA and it should be able to search the records based on AHA. And the third element is that within the various systems, I mentioned that why there is a need for various systems, because eventually health is a state subject, it is not even a central government subject or a concurrent list. Therefore, records should be migratable and transferable. Therefore, we need an interoperability, and that interoperability is essential for our systems. Our vision is not just focused on interoperability, but mapping the entire digital health of an individual right from before the birth. And these are integrated in the various programs. Pre-maternity programs, maternity programs, and even post-maternity after the childbirth, vaccination programs all are based on such iridium compliable systems. We saw the success of UN at the time of pandemic, COVID, and now we have the UN systems, even came in between. These are a part of the public health systems. But beyond public health systems, there is a certain element in digital health, which I often mention, works as the nucleus around which the whole digital health revolves. And that is a hospital information management system. A hospital management system, essentially it brings together the entire paraphernalia of what is required at the level of a primary care, secondary care, or a tertiary care of the hospital. And whether it is the registration of the patient, generation of an AHA, whether it is OPD services, IPD services, all is provided. To promote this, the government has come up with two systems. First is the e-hospital nation system, which is already present in 3,500 hospitals. We are targeting 10,000 hospitals. It is a microservice architecture-based service system which is being given free of cost to the states and the central government hospitals. And on a paid basis, CTAC-based system is there, which is called e-Shushu. Next element comes is the telemedicine systems. Now, e-Sanjeevani, which is again a Government of India initiative, has done enormous job in telemedicine. I have not come across a speech of Honorable Prime Minister where he does not talk about the success of e-Sanjeevani, and over a period of 5 years, 460 million free of cost consultation, even in the most rural areas, have been conducted on this e-Sanjeevani platform. But e-Sanjeevani is not limited just to the primary healthcare, to the Ayushman AROGYA mandirs. It is essentially telemedicine systems which is integrable with the different systems, which is offering benefits in different domains, whether it is developing follow-up clinics for the patients who need to follow with the tertiary cares, whether it is mobile ICU, whether it is tele-ICU, or whether it is integrating ERSS 112 systems with e-Sanjeevani. These are some of the vital elements which telemedicine can perform, and even expert consultation, doctor to patient consultations. These are all possible and is being done on the e-Sanjeevani platform. Next what? We come to the variables. I broached that variables issue at the very beginning, that they play such an important role in our life that we hardly take note of them. Whether it is the apps on the mobiles, whether it is the smartwatches, whether it is instruments which are directly sending our data, etc. AI. We had the AI Impact Health Summit, one of the Government of India project which I was interested to lead, won an award in the AI Summit, which was AI-based diabetic retinopathy. A plethora of such projects have come up. And again, this opens an area of challenge for the industry. What to adopt? Does AI sanctify everything? What is the efficacy of the product? What is the security? Who has approved it? What are the security elements? Is it free from the cyber attacks? Are some of the areas. But what cannot be denied is the increasing significance of AI in the world health setup as well as the Indian health setup, where we have the potential of it filling the gaps. Many times people argue that is AI going to replace the doctors? 10 years down the line, perhaps, I don't know. But given the immediate future, next 5 years, 6 years, we see a lot of gaps as far as the Indian health sector is concerned, and AI will be helpful in supplementing some of the gaps in some of the manner, especially in disease triaging elements. But at the bottom of it lies standards. And what are the standards? If we talk about digital health, two standards are extremely important, and that is the syntactic standard and the semantic standard, which the industry has to be conscious of and very cognizant of also. The semantic standards which the government has approved and is broadly adopted is the international standard, the cutting edge, which is the FHIR standard, HL7 fire as we call it. And the semantic standard, because the codes, the disease codes, the drug codes, the laboratory test codes, all have to come on a single platform, is called the Slow City, which is adopted. And of course, ICT 11 is also there. However, Snowman City, which is the licensed one, the government of India has taken a license which it is giving free of cost to the industry, even to the private sector, and this should be known to the private sector. After the standards comes the guidance, and the guidance has to come from the NABH and the NABLs, and there is the ISO standards of the 17,000 series and other standards which are there for various hospital standards and treatment standards. But at the base of it is all security, which we often forget about. And here I have to sensitize the industry through the platform of NATHEALTH and through some of the industry leaders who are present over here. I recently had interaction with the National Security Advisors and the National Security Council. And one of the areas of cyber security which is flagged is health. There is an increasing attack on the health sector. The reason is very obvious. It is the vulnerability of the health sector and the lack of preparedness of the health sector. And therefore, health sector has to take note of. As and when more and more operations of the health sector is moving on the digital domain, the chances of upsetting, the chances of completely derailing our operations becomes increasingly high. There is an increasing trend of ransomware attacks, especially on the private sector. And why not in the government sector? Not because it is more secure, but for a reason government is not sanctioned to pay the ransomware. They will not sanction it. And therefore they realize the futility. You can attack the health sector, you can do a crippling attack like the ACE which happened in 2022. However, you are not going to get the ransomware, and therefore the private sector, which has a greater prestige and has got operations, has got the private players linked to it, and is wary of loss of image. The traffic of ransomware is getting diverted towards that, and that you really have to take cognizance of. It cannot be ki chalta hai, hota hai, or I am safe. Nobody is safe till you are hacked. That is the rule. And you are already hacked, that is the second rule. Whether you like it or not. Now, a very important element which has come is the DPDP. And therefore, it is my bounden duty also to sensitize the sector, as the Secretary Mighty has sensitized us. Not that we were not sufficiently sensitized, we were, but then his words provides me the impetus that I further sensitize it. It is shortly going to come into picture, into effect, and the health sector has not got any exemptions from it. Now, health sector, as I said, because of the threat perception, is already in the process. The first element is that consent. There has to be a consent management framework. Consent management also means revocation of the consent, and that is a very challenging part. How do I manage the revocation of the consent? Second aspect is data anonymization framework, because of the privacy requirement, and that is also extremely important, especially for the private sector. Third element is pertaining to the security, which I have briefly emphasized upon. And it cannot be led to just 3 elements in the security. I would be very excited to speak about it someday, but my time is limited. I was part of the Global Forum OECD panel as a country expert in information security, did audit of more than 40 countries. So I understand a bit better about this subject. And normally when we talk about information security, we think it is IT. But the weakness and vulnerability is more at the management level. Have we created the policies and the protocols? Have we disseminated the protocols? Have we sensitized our end users, especially our workers, about that? Are they following it? Is incidents being reported? Are we doing incidents, vulnerability and penetration testing and security audit? We think the firewalls are there and we are safe. We are not. And at the last level of this lies what I call the end user, then the endpoint management and the network security. However, coming back to again to this topic, please do not ignore it or consider that it is fine with me. I am a prestigious hospital. I have a very good team of IT management. You have to constantly reinvent yourself. And definitely, I have interacted with NATHEALTH several times on another platform, which is called the Medical Value Trap. As India embarks on this journey of gearing itself up, one of the basic concerns of the foreign travelers earlier used to be hygiene, earlier used to be about competencies. Competency of Indian doctors, I doubt, is a concern with the foreign patients. Hygiene with not big medical hospitals like Apollo's or the Maxes, but data privacy still remains a concern. And that is why on the base element of digital health, which is the security and the standards, I have emphasized more. Because of the operation sides, it is the demand which should drive the industry. I have said a few words. You may like to expand it. Thanks a lot. Best wishes to all of you.
Thank you very much indeed. I would invite Ms. Amira Shah to do the honors of felicitating our very special guest, Sri Madhukar Kumar Bhagatji, for that wonderful keynote address we had from him, and all the valuable insights on advancing digital health adoption in India's journey towards Viksit Bharat. Thank you very much indeed, sir. And ladies and gentlemen, now it is my privilege to invite our special guest, Shri C.K. Mishraji, former Secretary, Ministry of Health and Family Welfare, Government of India. Shri Mishraji is a distinguished former Indian Administrative Service IAS officer of the 1983 batch who served as Secretary, Ministry of Health and Family Welfare, Government of India. During his tenure, he played a key role in strengthening India's public health system and advancing several national health initiatives, including the implementation of Ayushman Bharat, expansion of healthcare infrastructure, and strengthening of diseases control program. Ladies and gentlemen, let's put our hands together to welcome Mr. C.K. Mishra to kindly deliver the special address.
Thank you so much. Thank you everyone for trying to stay back to the last session. It's a pleasure to be here. NATHEALTH has always had a special place in my thought process at least, not because it's a great organization only, but also because this is a single integrator in the healthcare sector which has, which has really huge scale and convening power. And that is very critical if we want to put all the dots together and get healthcare in a circle. So thank you very much for having me. It was a pleasure listening to Mr. Madhukar Bhagat, who really put things in perspective. And I must say, you shared absolutely intricate things and things that are of critical value to everyone. I plead guilty on the ground that I am no expert on digital health, but have seen the impact that it is likely to have on healthcare delivery. And therefore, what I am trying to speak today is on a slightly different note of maybe asking a few questions to this knowledgeable audience and perhaps trying to answer some myself. So what do you do when you have a caption like Viksit Bharat 2047? What is it that comes to your mind? For a general person seeking healthcare, what is it that you would like to have in 2047? I would just place three aspects to it. First and foremost, he would like to have access to services. And he would like to have access to services as close to his residence as possible. Secondly, he would like to avail of those services at a cost which does not burn his pocket. And we just heard that healthcare cannot be affordable. But what he wants is affordable healthcare. Whether we like it or not, we'll have to get it for him. And that should be the aim of Viksit Bharat. Third, he or she must have reasonable assurance on the quality of care that he is going to get. So if these things combine together, that is the aspiration a common man would have for Viksit Bharat. You are the providers, so you are the key to this entire game. And perhaps you are the ones who have the questions as well as the answers to the key questions. Because without the private sector, the digital health initiative will largely remain a non-starter. Because what government has done very well is laid the foundation, built the pillars. The architecture has to be yours. And that is why I feel very happy being here before you today. But as I said, we need to ask a few questions when we come to adoption of digital health technologies in future and today. First, who is it for? When you design a technology and you want to implement and think that the digital health will get adoption, who did you design it for? Was it designed for the provider? Was it designed for the machine? Was it designed for the individual seeking healthcare? Who is the ultimate recipient of the digital health technology? And that defines why you did it and how you did it. The reason why I say this is that it is very critical to answer a question like this, because unless you have the person who is seeking healthcare in India at the center of it, your technology does not mean anything as far as healthcare delivery is concerned. Let us get that clear once and for all. Second, why was it designed? Why did you choose that particular design? Is it because in terms of technology, you found it very convenient and very, important to do that? Was that design influenced to any extent by the felt needs of the people who are going to use it? If you have not kept the felt need of the people in mind, a design for the design's sake is not likely to succeed to the extent that you would like it to. Third, can it see scale? We've had, I think, thousands and thousands of pilots in this country, all brilliant, let me tell you. Great ideas, not coming to scale. I mean, technical explanations of not having finance, not having X, Y is all very good, but at the core of the thing lies the fact that you did not design as per the felt need of the person who was going to use it. That is why it did not get to scale. The rest are all doable. The other question is it adoptable by the regular health system, or are we trying to create another class of people who's going to use it? The Indian healthcare system, according to me, cannot afford another layer. The simpler and better and convenient we make it, the better it is for the person who is using it. But my final question is, does it push up the outer pocket? And this is connected to the point I made about affordability. Any technology introduction which burns a hole in the pocket of the patient seeking healthcare is an unlikely start. Therefore, we need to keep this in mind. Of course, we can go on discussing that if there is an increase in out-of-pocket, we can get insurance support, we can get XYZ. And we need to keep it at the back of our mind all the time that this is not the government's business at all. Healthcare provision is not government's business all by itself. So, brilliant ideas have not come to fruition at a large scale that they should have. But then, we all have to admit that there has been no greater enabler to healthcare delivery in India than digital health in recent times. But then, and this is a point I keep making and people keep disputing, but I'll continue to make it. It is the greatest enabler, no doubt, but not the entire story. Digital health will not be equal to healthcare delivery systems all by itself. But the other side of the story is that without digital health, you may not now be in a position to provide healthcare. Therefore, it is very, very critical. But it just falls short of completing the circular story. There is something else that will fill in the entire circle. But then there are areas like diagnostics, there are areas like screening where tremendous use of this technology can be made and is being made. You must keep in mind that any new idea that comes in to fill a gap. If you look at the global healthcare scenario today, I mean, dramatic changes have taken place. Healthcare financing has changed, WHO's position has changed. I mean, you know, you had organizations like USA intervening with technical knowledge everywhere, that position has changed. So now, in this change scenario, there is government and there is private sector. And the two have to make it together. So countries basically are looking for new models. A model that is scalable, a model that is affordable, and it is built on an open standard. This is what people want, and this is what we should be able to deliver. The best example of how scale happens has been the pandemic. I still remember those days, early 2020, I think, when as the head of the task force, I was struggling to find testing kits and other smaller diagnostic tools. And we had a huge problem of connecting to people. But the way the digital technology took over and just filled all these gaps was remarkable. That is a proof that Indian health architecture already has digital technology built into it. We just need to make better and more judicious use of it. And who will do this? My favorite point once again is the private sector, which must take the leadership in this. You know why the most successful program of government of India was the National Health Mission? The reason why National Health Mission succeeded was the fact that, you know, in the NHM, you enrolled government, you enrolled private sector, communities, civil society, and everyone was concerned. And then you put them in a shared purpose. It is time that for ABDM, we do the same thing. It's a time for a similar architecture for ABDM to be built. And government has done the heavy lifting already. You need to just carry this forward. The infrastructure is in place, the incentives are there, everything is going in terms of regulation. You have to step in a big way. And I do not like the word disruption, but you have to step in a big way to actually rebuild what should have been built much earlier. The journey has to be about deepening engagement and moving to real use of digital health. Please remember that the private sector is not peripheral to healthcare. It is the most critical part of healthcare in India, and therefore it needs to be fully involved. It really means that hospitals, laboratories, insurances, everyone needs to embed ABDM in their lifestyle, not as a requirement to be fulfilled, but actual acceptance. B, they need to invest in interoperability. C, they must provide that leadership role where, the best practices, and they must demonstrate the scalable utility and scalable possibilities in digital architecture. Government too must make things easier in regulation, and since I am speaking to audience which would like to think about it, procurement as well. Because at the end of the day, the two things must meet. So the roadmap, if you have to talk about, it must include these factors. And as I said earlier, in this construction of the roadmap, it cannot be the government's business alone. Integration, innovation has to be the key. And we know that this is the only possibility of servicing the healthcare needs of a population as big as ours. And as I said earlier, digital health does not provide the whole answer, but provides a brilliant story on which you can build and provide healthcare facilities. Thank you very much, ladies and gentlemen.
Thank you, sir. May we have you back on stage as I request Ms. Amira Shah to kindly do the honors of presenting a token of gratitude, a memento to Shri C.K. Mishraji. Ladies and gentlemen, let's put our hands together for sir for that wonderful keynote address we had from him. And now we are left with two very interesting fireside chat sessions. The first one is on scaling NHCX in healthcare benefits, barriers and enablers for hospital adoption. We are privileged to have with us our distinguished panel of leaders representing healthcare providers, technology innovators, and industry experts. I now have the privilege of inviting Dr. Ritu Garg, Chief Growth and Innovation Officer at Fortis Healthcare, who has extensive experience in driving strategic growth, digital innovation, and patient-centric transformation. Warm welcome to you, ma'am. I invite Mr. Aditya Patkar, Chief Executive Officer of Plus 91 Technologies Private Limited. He is a leader in healthcare technology solutions focused on enabling digital healthcare systems. I invite Mr. Sanjay Murdeshwar, Regional President at Danaher Corporation, who has significant experience in advancing healthcare technologies, diagnostic solutions across global markets. And to moderate this conversation, ladies and gentlemen, let's invite Mr. Ashish Rampuria, partner at Deloitte, where he works closely with healthcare organizations on strategy, digital transformation, and health system innovations. Ladies and gentlemen, we have been informed that we have to vacate the hall by 6 p.m. sharp. So I would request our eminent speakers here if they could kindly conclude the fireside chat in 10 minutes. Over to you.
Did I hear 10 minutes? So I think first of all, thanks Nadir and esteemed speakers who are on the stage. Now, sort of since I have to crunch the entire conversation from 30 minutes to 10 minutes, I will sort of do it a bit differently. So I think the entire session that we were running, I think we wanted to cover two things from a digital perspective. One, obviously, talk about national healthcare mission. My partner colleague Neha will speak about EPDP. And I think we heard Mishraji today as well as Madhurji, where we spoke about how over a period of time, from a digital perspective, there is a lot of activity that's happening here reaching a pivotal stage, and the whole idea of ABDM maturing, NSA being implemented was a movement towards interoperability. However, from practicality perspective, I think we see only maybe less than 500 to 700 hospitals on NSCX platform, so there is significantly lower adoption. And even with that adoption, I think the usage is, and I think we did a small survey of 40 hospitals which today are on the NSCX platform. And the usage actually is less than 10-20%. Right? So there are two issues. I think there are less hospitals on the platform, and also those who are there are not using it in a more comprehensive manner. Right? And I think that's what the entire panel will discuss today, and that's why we have a stakeholders side from the technology, from people who focus on technology, people from the provider community, as well as the medtech community, so that we can deliberate what the solutions could be. And I just want to also refer to what Mr. Ji had. I think you mentioned very interesting points, right? I think it should help with affordability. I think the solution should help in scaling up. Right? I think that's where the fact that the solution is not scaling up itself is indicating maybe there are some design issues or not being implemented properly as the case may be. Now, given we have less time, so the way initially we had envisaged was we spent 10-15 minutes talking about the problems, and then maybe we will talk about solutions. Given the current timeline, I'm just thinking what we will do is we will sort of talk about the problems and solutions with the same question. Right? So we will have one question each to my panelists. Right? And I want to sort of start with you, Dr. Ritu. Now, given today, as you see, right, there is less adoption as well as less, right? And as they say, beauty lies in the eyes of the beholder. Provider perspective, value lies in the eyes of the provider, right? So which means they are not seeing some value from a platform perspective. So both from you as a large provider and you represent the provider community, what challenges do you think they perceive that they have not onboarded on the platform? And even if they onboarded, per se, sort of what prevents them from using it more? And hence, what solutions can work better to ensure the fact that they are sort of going forward, those barriers can be removed and NS6 can become the success that it was envisaged to be.
Thank you. So I don't think the providers have any apprehension of the concept. On the contrary, I think the concept, while it's great, I don't think it's very ambitious also. There are not many precedents to that. Having said that, it's a complex problem because it has multiple stakeholders, and I think our problem starts with the fact that in healthcare, especially in India, one, the digitalization of data is not there. So you're also trying to create a tunnel for something which is not as evolved today because EMR adoption is obviously very low and we do not have standard codes, etc. Second, there are multiple stakeholders in terms of insurance companies and providers, right? So the biggest challenge is the product itself. I think the product itself is not matured enough to onboard multiple integrations in a seamless manner. I think that is the biggest hesitation. I don't think, at least from Fortis' perspective or from other healthcare providers, there is any hesitation on the concept of the NCX.
Thanks, Dr. Ritu. I think you highlighted clearly the fact that maybe the products are not fully matured yet. I think we could relook at the design. I think also given the DPDP, how the data etc. will flow, who will be liable and so on and so forth. But I think also you made a very interesting point about the cost of IT updation, and I think we as larger providers that's easier for them. But given the structure of the healthcare ecosystem in India, where 90% of hospitals are less than 10, 15 beds, that also might be significant cost to them. Fair enough. Coming to you, Aditya, picking on from what Dr. Ritu mentioned, so from a technical integration, HIS readiness, EMR, and so on and so forth, where this seems to be a big challenge. From your experience, what should they do, and then also what should maybe the government, the policy bodies do to enable smaller providers to be technically competent to move to an NSCS platform?
Thank you, Ashish. So the claim essentially is, data coming from multiple departments. And today, if I look at the small hospitals, medium hospitals, most of them have very simple billing solutions, right? Very few are using EMR. So the first challenge comes in is how are you able to generate this data to fill the NSCS, right? So there is a lot of confusion over there. The government itself is obviously bringing in policies, starting with the APDM compliance, and in the private sector there is a slow shift happening towards shifting from their old solution either to a new solution or their existing providers who are serious about this business, actually upgrading their solutions. On the other side, there are multiple insurance providers, and today there seems to be a lot of confusion between the RRDA as well as the providers. While if I go to the APM side, they all are displayed on the NSCS panel, how many of them are actually able to take the data we send and be part of the NSCS is a mystery. I am trying to work with one provider to actually show a completed use case. They give me 1 hour with my tech team a month to actually be able to test it out. So there doesn't seem to be a lot of push from the IRA, NHA to actually get this done. What has been great is the NHA decided to leapfrog the private sector in this case for the moment and say that PMJ claims are only going to be on NSCS in the next 2 months, 3 months. In fact, multiple letters have gone out at the state level. 4 or 5 states have sent out letters to their PMJ and private hospitals that either take an APDM compliance software, which is also working on the NSCS or close to getting certified. Otherwise, we will not process the claims, so they will be treated as later plus obviously given some incentive. So that's a great step, and I think once the PMJ system can be seen as working, hopefully the other insurance providers will come on board. The technical challenge mainly for newer people is fire compliance. I think there is still a lot of gap in terms of understanding how to convert your data into fire compliant data. The big challenge comes because it's something like the NSCS, which is completely driven on fire. In AVA, what happened is they could still send PDFs, they could still send smaller bundles of data which was not really fire compliant. And we've seen this when we are trying to report that data. But in NSCS, they try to make it completely fire compliant, and there is a technical challenge there. There has to be more outreach in terms of getting data up to speed on that.
Thanks, Aditya. I think highlighted 2 key important points in my perspective. I think clearly there needs to be data, which means the smaller providers need to be tech enabled. And also importantly, there has to be a policy push from both IDA and NHA. And I think you also mentioned NHA started taking those steps, right, from a PMJ perspective. Essentially coming to conscious of time, right? I think as a medtech company and importantly from a claim perspective, I think equipments are getting now interconnected, right? And they're generating data on diagnostics, they're generating clinical authentication and so on and so forth. So what role can medtech companies play, right, in this entire integration such that entire claim approval can become faster as well as there's resolutions?
Thank you so much. I think on a daily basis, I know Dana Corporation generates around 11 million tests. So there's enough data out there. The problem is that the data is not owned by us. We are just merely a highway where the labs labs and the hospital companies really own the data around the patients. So the most important element is how can the diagnostic companies like us get aggregated data, which is not specific to an individual, on which we can build very strong AI models. That's been happening around the world and is helping in better clinical outcomes. So I think that's the first one, if you can have access to it's done on that, but we don't know. Yeah? I think in the interest of time, maybe I'll just stop here. Is that for us or something else? Okay. And I think the second element we talked about is that it's not just large hospitals and labs. It's, I think, the nursing homes as well as the unorganized labs who are actually some of the backbone of our healthcare infrastructure. And do they have the capacity to build this infrastructure, and more importantly, the change management to do that, and the workflow solutions required to fundamentally change how healthcare is delivered. This new set of data is going to be very important. Technology is a simple thing. Change management is the
Thanks, Sanjay. I think you reiterated the point of data and who owns the data, but also I think you brought a very important point around change management. So to just summarize, I think the key points from a recommendation and from a solution perspective what clearly came out. I think the data needs to be there, and hence for the data to be there, what action that needs to be taken, especially for the smaller providers and smaller labs who might not have the resources to do it, I think is an important element. Two, from a TDD and who owns the data, what claims are like, etc. Seems to be a big area, and that's somewhere more clarity needs to become. And then thirdly, I think whether it's pilots or push from NHA, IIDA to ensure implementation will go a long way to make sure NSCX becomes a success in the near future. I must thank my esteemed panelists for their time, as well as NATHEALTH for the opportunity. I must also request NATHEALTH that if you can plan this better study at the appropriate time when we do the panel next year, so that would really help. Thank you and appreciate the patience.
Thank you very much, Lisa, and we are once again extremely sorry for the less time that we had to give you. We have been cutting short the time from all of our sessions, and we have request for a group photograph. So we now move to the next fireside chat titled Navigating the DPDP Act, Compliance Challenges and Readiness for Healthcare Stakeholders. And we are privileged to invite our eminent panel of experts, Dr. Milind Antani, Nishit Desai Associates, a leading expert in healthcare law like regulatory frameworks and policy. We invite Mr. Dev Tripathi, Chief Financial Officer at Philips, with deep expertise in healthcare technology, global corporate governance. Mr. Rajeshwar Nerulkar, Informatics Cluster Lead, APAC, Southwest and Roche, who brings valuable insights into digital health systems and data-driven healthcare solutions. Mr. Sudhir Behel, Vice Chairman, Board Member at Cresta Healthcare, and moderating this discussion is Ms. Neha Agarwal, Partner at Deloitte. And I now hand over to Ms. Agarwal to kindly lead the fireside chat. Ma'am, 10 to 12 minutes maximum. Over to you.
All right, so yeah, it's a right time. I'm sure that when we keep this session more interesting in terms of some of the very important elements that the new regulations bring into play. When we talk about healthcare system, again, healthcare system has evolved with the transformation of technology, and we did hear Mr. Mishra and Mr. Madhukar also talking about how the concept of interoperability, the concept of consent, the concept of data ownership, the kind of responsibility each of the stakeholders have today is very, very essential in this ecosystem. And therefore, this is a point of time where the DPDP Act is enabled, the rules have come out, and now we have time to implement it. So the question really lies in is that how are we here in terms of the preparedness of implementation, and what are the kind of challenges that we really face in terms of implementation, whether one-size-fits-all approach does work, or do we need something more? So I think that's the broad theme of this particular session that we are going to talk about. And therefore, the first question that I have for Dave is that, being a medical equipment company, what is it that, you have seen in terms of, the evolving digital ecosystem and, the impact that you're seeing in the DPDP?
Thanks,
Tanzania. So being 100 years in India, Philips in India plays a very critical role in our innovation ecosystems in Philips globally. More than 4,000 engineers based out of our Philips Innovation Campus today. Today they work on integrated system solutions that really integrates our advanced imaging systems with AI-driven clinical decision support tools and continuous monitoring that helps faster diagnosis, precise treatment, as well as better patient outcomes. So this is what we are doing in India, and all the implications of DPDP, if you ask, there are 3 areas where I see, and it is not from the commercial side I'm saying, it is more from the innovation side, which helps the DPDP and consider as an opportunity actually. First is in the data consent and how you gather and what you gather from the principle. That is one. Second thing is the data anonymization and the masking and data minimization. And the third thing is that data interoperability, where we say that the flow of data, because now the ask will be that how nicely during this implementation phase, we see that standardized data processing agreements being drawn so that there is complete transparency is established from the principal to the fiduciary, the significant fiduciary, the roles and responsibilities, the purpose of what the data is gathered, at the period for which the data is gathered, and the ownership of the people are clear. And the second thing is that anonymization, who has to anonymize this data, whether it is upstream or downstream. And the third thing, as I mentioned, that the necessity for innovation is when you leverage your capability and competencies across the globe, across the R&D sites across the globe. So for that, some clear national level guidelines which is very much aligned to the global level, how the data should flow across the globe. That helps.
That's a fair point, but probably that's a question to you because as a hospital, you're the first point of contact from when Mr. Mishra also said that who is the recipient of the service. So at the end of the day, you have a larger responsibility, but at the same time, not the individual responsibility. So at that point in time, how are you seeing that hospitals are redesigning their consent architecture without really compromising on the hospital management workflow, and also at the same time making sure that the delivery, the patient delivery from a care perspective is not getting compromised?
No, it's a fair point. I think one thing as Dr. Paul said, evening we heard from Mr. Mishra that data privacy and security is becoming a big norm. One of the fundamental things is the infrastructure in the technology side has increased, but so is the leakage also. I feel this DPDP Act, which brings in some standardization. However, at the same time, we can't create a consent friction. The thing is, when a patient comes, so probably a uniform consent program has to be there. And there is a lot of legacy issues with our IT systems. While there were good controls on the internal processes, but external processes still are being evolving as the policy is evolving. Second part, which is very, very important, is we spoke in one of the sessions that there are multiple stakeholders in the data. It starts with the patient coming to the primary care, taking some kind of treatment, and if there is some surgery, they're giving another consent for surgery, goes to the insurance, and then goes to the payer. That entire cycle works well, but putting the DPDP layer will add, are we ready as a country to integrate that and make it interoperable? And I didn't miss the equipment part there, but that is again third very important, and which we should all debate, I think we are very few of us now here, is that are we doing it for just being adhering to some regulation
spirit also, or just we want to do it in. So right now, if you see, when 70% of healthcare delivery partners, small nursing homes, doctors, are not even automated. So what is the policy there? Is it that those 30% who have IT system, they should only comply? Or is it everybody first has to build an IT system and then adhere to that compliance? So these are a couple of questions we should ask ourselves internally as an industry, and then maybe go to the regulator saying we welcome this. But at the same time, what is the right point in implementing this?
I think, Sunil, you actually raised a very important point in terms of are we ready for this? But again, the most critical piece comes in is that, the legislations are implemented. But does it really get implemented in terms of spirit? Or does it also complicate the matters in terms of creating some more legal complexities and therefore, prone to litigation? And therefore, my question then to you, that, with respect to these, this liquidity has undergone significant consultation, so there is no doubt in that. But in terms of, the risk of liability, the interpretation on significant harm and breaches, these are very important elements, because at the end of the day, these are the ones which are disputed in the court. And therefore, what's the take of yours that, are we ready for this? What is it that probably are learnings that probably we could really suggest?
Yeah, thank you. Very important point. When I was a surgeon for 14 years, or an ENT surgeon, I hated the color grey. But then I became a healthcare lawyer 23 years ago, and I'm learning the color grey. So that's my bread and butter. So significant harm, unfortunately, is a term which is not explicitly defined in the law. And when nothing is defined in law, goes to interpretation. And another challenge is that it's a great law. Let me tell you, there's a number of people, whether you love it or hate it, you can't ignore it. Accept it, whether it's a pinch of salt or a ball of salt. You have to compare. But the challenge is this no definition, specific definition of significant harm is going to lead to significant problems, because liability is directly proportional when it comes to data to significant, it's not inversely proportional. And the liability would be quantified depending upon the what significant harm has happened. Now, who interprets? Unfortunately, there are so many games here. I am combining both questions that you can't make every sector's legislation as a privacy law. You can't be a pharma healthcare law as a healthcare regulator becomes a privacy lawyer, insurance IRDA becomes a privacy lawyer. You have to have something which is a nodal authority which interprets, that is number one. But unless and until significant harm is not defined, it is going to, one, huge risk of misinterpretation, leading to varied liability, significant harm for healthcare, for patient. It is very different. My illness is declared to somebody else versus his bank account declared to somebody else, a huge impact. So entire liability will be dependent on the what impact that significant harm creates. That is true. And third, another risk is either there will be over-reporting, people will be very cautious, or there will be under-reporting, and this will lead to compliance fatigue. One thing what we can do, I think, is to avoid this chaos and have one global authority which really plays role. I will just end with my favorite line. It looks great, everybody talks great about digital health, DPDP. It is said that at the end of the tunnel, always there is a light. But it can be of a coming vehicle. So walk carefully.
No, this is right. And therefore, the whole idea is really to debate on it before really we have the deadline of next year coming in, to have some of these problems really laid out and probably some sort of explanations to these pieces are coming in. It will really avoid the complexities of future. That is the question to you. I mean, again, you have, you're part of the global firm, and privacy by design is something that has been prevalent across other geographies also, right? Especially
electricity which is supplying, which is invisible, and you really can't see. So that has to be basically in the DNA. What we've done is we've implemented and integrated this into the firmware. So the encryption technologies are already in the firmware. So if my engineer is, say, going and trying to operate a machine, he does not see the patient data, he already sees the analyzed data, and only the machine data. So that is the level of security that we already built. However, one thing is overall the nation really needs to be sensitized on what DPDP is all about. What is this privacy all about? Because I don't think most of our people are really aware and they don't understand the sensitivity of it. So the impact is substantial. Also, when I look at today's DPDP, it's very generic. So we really don't have a healthcare sector-specific sector, and it's really, really
One second, I think what you said, that the healthcare industry needs DSHA back. DPDP is not going to help us because it doesn't talk about the criticality of the health data. DSHA was introduced. I was one of the final 4 signatories when we was totally, I feel so sorry. But I think a movement needs to happen that DSHA needs to come back, or DPDP must carve out criticality of healthcare data. Otherwise, we are heading for a huge chaos. DPDP from law point of view is much better than GDPR, much better than HIPAA. But when it comes to healthcare, there will be a chaos.
No, I think that's very relevant because, when we are saying that, Indian legislations have thought about and, they have seen how the impact of some of the global legislations like HIPAA, like GDPR has impact. What are the quick learnings? I think we've already crossed that path. But what really needs an impact is in terms of really going deep into the sector. What are the sector requirements? What are the obligations? What is the need of having these kind of regulations? Who bears that responsibility? What kind of an expected risks that we foresee, both from legal perspective as well as from the patient care perspective? All these are very relevant. And I think what Mr. Mishra also said is right, that healthcare continues to be at the center of some of these risks. So again, these cannot be compromised on. I mean, I was looking at some data in past. I mean, around more than 20% is actually the healthcare share in terms of the ransomwares. So again, that cannot be compromised. And I don't think that any of the panelists is actually saying that we are not wanting to accept. I think everybody is wanting to accept. But I think the only case is that, this is something that really aligns with the overall objective of patient care, and therefore, when we talk about consent to care, the primary aspect will be care, but at the same time not compromising on the risk of personal data. So I think that's what we are concluding on, but I mean, we do have some takeaways on, where are we on this, how do we really integrate the entire system, how do we really bring in some more clarities on the legislations to avoid any kind of disruptions that's going to happen. Thank you so much.
Thank you very much indeed. May I request for a group photograph of our esteemed panel. So ladies and gentlemen, as we approach the conclusion of the 12th NATHEALTH Annual AROGYA BHARAT Summit 2026, we will now present before you a short video on NATHEALTH One community. And with that, we will come to the formal close of the summit proceedings. On behalf of NATHEALTH and all our partners, we thank each one of you for your participation, valuable insights, and continued commitment to strengthening India's healthcare ecosystem. And after this closing video, we will invite all our distinguished guests and participants to kindly join us for high tea and networking, once again served at Regency 3, which is one level lower to this hall. Thank you once again, ladies and gentlemen. We look forward to welcoming you at the future NATHEALTH engagements. Have a wonderful day ahead. Safe travels. Good evening. Namaskar. And please watch this video of NATHEALTH One.